Okay, good morning, everyone. In dental trauma, the first 30 minutes set the trajectory for healing, for complications, and for the lifetime of the tooth. Today, I'll show you how to think clearly, act fast, and protect the child and the tooth when it matters most. So every trauma case starts the same way. It doesn't start with diagnosis, it starts with emotion. A frightened child, a panicked parent, emotion, confusion, blood, and all eyes looking at you for answers. In that moment, you are the calm in the storm. Your tone, your presence, the way you enter the clinic, that stabilizes the family before you ever touch the tooth. Once that calm is created, then the clinical thinking begins. And once the room is calm, the clock begins. The very first step in those 30 minutes is safety. Before we examine the tooth, we make sure that the child is safe, medically and socially. If you suspect head injury, vomiting, confusion, drowsiness, dental care stops, and medical referral is urgent. Look for airway danger, loose teeth, lost fragment, bleeding, any aspiration risk. If the airway isn't safe, then that's the true emergency. Control bleeding early with pressure and gauze, as a clean field lets you see the real injury. Any open or contaminated wound, always ask about tetanus. If in doubt, refer for medical review for a booster. If the story doesn't match the injury or bruising appears in unusual areas, think safeguarding. We don't diagnose abuse, we recognize red flags and report. So our duty is to protect the child, not just treat the teeth. Once the child is safe, then we begin the structured dental assessment. Trauma can feel chaotic. A structured assessment is what pulls you out of this chaos. It gives you control, sharpens your decision, and protects the tooth and the child for avoidable mistakes. And we see this pattern everywhere, in the literature and in our own service. Under stress, clinicians don't lose knowledge, they lose structure. And we have seen this in the Quality Improvement Project by KBBD resident Dr. Zahra, which showed exactly that. Critical details were missed, not from lack of skill, but from pressure and lack of guided framework. These 5 domains guide every dental assessment. What changes in trauma is the level of detail required within each one. This is the KBBD trauma assessment tool, built on NDRACEN and AAPD documentation tools, and refined through 7 years of real cases, real errors, and real complications. It changed how we practice. It keeps you focused when the room is loud, the child is distressed, and the clock is ticking. Start with history, how it happened. It tells you the force and direction. When it happened, it tells you which tissues are at risk. Where it happened tells you the contamination and the tetanus risk. And always ask about the red flags. Then the clinical exam, extraoral first, then intraoral. A structured sweep ensured nothing is missed, fractures, swelling, displacement, laceration, and occlusal changes. Then move tooth by tooth. Fractures, any pulp exposure, discoloration, mobility, displacement, any tenderness to percussion or palpation, and sensibility testing in permanent teeth. These small details are what shape your diagnosis and the treatment that follows. Radiographs anchor your diagnosis. So for primary teeth, a PA and upper occlusal are usually enough. For permanent teeth, take at least 2 PAs with different angulations, and don't rely on one, as fractures love to hide. CBCT is powerful, but selective. So use it only when it will change your management, not as a routine. But remember, your first radiograph becomes your baseline. So every trauma follow-up compares back to this moment. Now everything come together, the history, the exam, and the radiographs. This is where you name the injury accurately and choose the correct immediate treatment and follow-up plan. To diagnose accurately, we need a shared trauma language, and then Racine classification is that language: clear, simple, and the gold standard worldwide. And remember, if it's not documented, it didn't happen. Good records protect the child, protect your plan, and protect your license. Once the diagnosis is clear, those same 30 minutes demand an action. And the very first decision is simple: are we treating a primary or a permanent tooth? So in primary teeth, our priority shifts from saving the tooth to protecting the successor. So in young children, most injuries are luxation, not fractures, because the alveolar bone is soft, flexible, and absorbs impact. So our immediate management is gentler, more conservative, and always guided by do no harm. And since luxation injuries by far are the most common in preschoolers, let's start there. Here we always think conservative. Observe when there is no occlusal interference or in cases of intrusion, because these often improve naturally within 6 to 12 months. Extract only when the tooth is excessively mobile or severely displaced, especially if there is a risk of aspiration. Reposition and splint only in highly selected cases, a cooperative child, mild displacement, and reliable parents for follow-up. Let's look at how this translates into real cases. Here we have a 2.5-year-old fell at home. Tooth number 5-1 was laterally displaced with no occlusal interference. We reassured and observed. At 1 month follow-up, it spontaneously repositioned with gray discoloration, which is in primary teeth often reflects blood pigment, not necrosis, unless symptoms appear, of course. So we informed parents about possible effects on the developing permanent teeth and the need for follow-up. Our next case shows a different management of the same injury. This is a cooperative toddler, had a lateral luxation of tooth number 6-1 with moderate occlusal interference. So here we repositioned and splinted the tooth. At 2 weeks review, there was a gray discoloration on the tooth, which was simply, again, blood pigments, not pathology. And it faded over time. 3 years later, the tooth remained stable. Let's move to the next one. A 5-year-old hit by a car with severe luxation and unstable anterior bony segment. The incisors were extremely mobile with aspiration risk, so extraction was the safest option. We sutured to stabilize the fractured alveolar segment, and at 1 month follow-up, as you can see, the area has healed well. But when the tooth is completely out, the rules change. In primary teeth, we never replant. It can damage the developing permanent tooth germ and offers no long-term benefits. So management is simple. Control bleeding, reassure parents, clean sockets gently, and document. And always take a radiograph to confirm it's avulsed, not intruded. And if the tooth isn't found, refer to rule out aspiration or ingestion. Here's an example. 1.5-year-old boy playing at home, referred from a private clinic with radiographs already taken. Imaging confirmed avulsion of tooth number 5-2 and intrusion of 5-1. No intervention was needed. We observed and followed up, as most intrusion in primary teeth will re-erupt naturally, which can be seen at the 6 weeks review. 5-1 has erupted naturally. So not every trauma displaces the tooth. Sometimes it breaks it. So let's look at fractures. Always ask 3 questions. Is the pulpus vital? Is the tooth restorable? Can the child tolerate a treatment? For enamel or enamel dentine fracture, smooth or restore. If the pulp is exposed, preserve vitality if the child is cooperative, usually with partial pulpotomy. Otherwise, extract. For crown root fractures, remove the coronal fragment and assess the restorable structure. If not, extract the coronal piece only and leave the apical root unless it is visible and is easy to retrieve without causing harm to the permanent successor. Root fractures are treated by displacement, either observe, allow spontaneous reposition, or extract if very mobile. Here is a case to illustrate that. This is a 2-year-old who had mid-root fractures of the upper central incisors. Both teeth were extremely mobile, creating a real aspiration risk, so extraction was the safest option. Moving to the next case. This is a 3.5-year-old who fell at home. Both upper centrals had complicated crown root fracture with a gingival laceration. Because the fractures extended subgingivally, the safest option in the primary dentition was extraction. At the 1-week review, clinically, the gingiva healed beautifully and the site remained infection-free. We informed the parents about possible effects on the permanent successors and the importance of routine follow-up. Moving to management in permanent teeth, where the story changed. Here, our focus becomes pulp survival, PDL healing, and long-term prognosis. Let's begin with the true dental emergency, avulsion. So once a permanent tooth is out of the socket, time becomes biology. Every minute dry dramatically reduces the chance for the PDL to survive and drops the prognosis. Our immediate priorities are simple: keep the tooth moist, replant gently, and act immediately. Whether the apex is closed or open, the answer is always the same: replant. The difference is only in the pulp plan. Open apex, give a chance for revascularization. Closed apex, plan RCT within 2 weeks. When replantation is delayed, ankylosis is expected, but we still replant to maintain aesthetic and preserve alveolar bone for future. And this is where public education becomes critical, as most poor outcomes are from prolonged dry time or incorrect storage. If the public simply knew to place the tooth in milk, a physiologic medium that protects the PDL cells, the chance of survival increases dramatically. So the rule is simple: keep it moist, not clean. Let's look at how this plays out clinically. Here we have a 12-year-old ran into a door and avulsed tooth number 4-2. The tooth was kept in patient mouth for 10 minutes and replanted immediately, then splinted, and root canal treatment was provided or initiated within 2 weeks. More than 4 years later, the PDL remained healthy, a perfect example of how proper storage and quick action can completely change the outcome. Let's move on to another case with a longer extraalveolar time. Here we have a 14-year-old with avulsed 2-1, which was replanted, splinted, and had root canal treatment. At 20 months later, infraposition and replacement root resorption appeared, which is expected in avulsion cases. So we performed decoronation to preserve the ridge and fitted an immediate partial denture. The takeaway here: even with ideal care, ankylosis happens. Decoronation protects bone for future implant placement. Moving to luxation injuries. Here, both the pulp and the PDL are injured together, but they don't always recover together. So your goal in the first 30 minutes is simple: preserve the PDL, reposition gently, splint flexibly, and always follow up. Let's walk through the injuries one by one. Concussion and subluxation, no displacement, so observation only. Extrusion, gentle repositioning, and flexible splinting for 2 weeks. Lateral luxation, realign the bone, then splint for 4 weeks. And now the one that causes most confusion: intrusion. Intrusive injuries depend heavily on 2 things: the root maturity and the depth of the intrusion. So for open APCs, allow spontaneous re-eruption for about 4 weeks, and if nothing happens, move to orthodontic traction. For closed APCs, the deeper the intrusion, the more active we must be. If it's mild, less than 3 millimeter, observe or orthodontic traction. If it's moderate, 3 to 7 millimeter, surgical reposition or orthodontic traction. If it's severe, more than 7 millimeter, surgical reposition is preferred. Pulpally, in open apex, revascularization whenever possible. Closed apex, initiate root canal treatment within 2 weeks. And now, when there is an alveolar fracture and severe displacement, treat the whole segment as one unit, reposition and splint. Let me show you some cases. Here we have an 8-year-old with a severe subluxation with grade 3 mobility. We splinted for 2 weeks to stabilize the tooth and protect the PDL. At 1-year review, the tooth remained vital with continued root development, exactly what we aim for in immature teeth. Moving to a more severe case. Here, we have a 10-year-old was hit by a car and presented with a severe lateral luxation of tooth number 2-1 and uncomplicated crown fracture of both upper central incisors. So we repositioned and splinted the teeth for 4 weeks. Root canal treatment and composite restoration was provided. For 4 years, the child had good function and aesthetic, which helped restore his confidence after the accident. And now he's in orthodontic treatment for crowding, and because these traumatized teeth have a poor long-term prognosis, they will be extracted as part of his ortho plan. So after repositioning, the next critical step is splinting, and the principle is simple. Support the tooth, don't strangulate the ligament. Splinting in trauma must always be short-term, passive, and flexible, so our goal is not to embolize the tooth rigidly. It's just to give the PDL a stable environment to heal. In practice, we commonly used wire composite splint or TTS splint, titanium trauma splint, because they adapt easily and keep the tooth physiologically mobile. Always extend the splint to at least one tooth on each side and reinforce soft diet and good oral hygiene. And remember, 2 to 4 weeks is usually enough depending on the injury. The moment the PDL is ready, remove it, as keeping it longer doesn't improve outcomes. Moving to fractures. So if the pulp isn't exposed, our focus shifts to protecting the dentine. Untreated dentine exposure allows bacteria to progress and causes pulpitis, followed by infection, then necrosis. So cover it immediately with composite or reattach the fragment when possible. But in cases where the child is distressed or you can't achieve full isolation, a thin layer of resin-modified glass ionomer serves as a safe temporary seal as you're buying time until definitive restoration. If the pulp is exposed, the priority is to preserve vitality. Partial pulpotomy remains the gold standard, showing up to 100% success across studies. Full pulpotomy works well if the inflammation extends deeper, while direct pulp capping shows poor, unpredictable outcomes in trauma cases. The choice of material, whether calcium hydroxide, biodentine, MTA, or the new calcium silicate putties, make little difference when used correctly. In anterior cases, aesthetic matters. MTA may discolor due to bismuth oxide, while others are bismuth-free and color stable. In short, preserve vitality and choose color-safe materials. Let's look at the cases. Here we have a 10-year-old presented with a complicated crown fracture of tooth number 2-1. We performed a partial pulpotomy to preserve vitality using calcium silicate material and composite buildup. At 3-year review, the tooth showed apical root closure and pulp canal obliteration, which is a favorable healing response. The next one. We have another 10-year-old who had a complicated crown root fracture of tooth number 2-1 after a scooter fall. The mobile fragment was removed, gingivectomy performed to expose the margin, and a cervical pulpotomy with bioceramic was done to preserve vitality. At 2-year follow-up, the tooth shows apical root closure and a calcific barrier, confirming successful healing and continued root maturation. Up to now, we focus on how to act in the golden first 30 minutes. But many of the failures we see don't come from what we did in that window. They come from what happens later. Most complications happens because the child returns late, never returns, or was never given a clear follow-up plan. In the next cases, you will see the same pattern repeated. These were perfect replantations, but without follow-up, the teeth severely infrapositions and the surrounding bone disappeared. A simple review schedule could have prevented a lifelong prosthetic challenge. Here, even simple injuries fail without follow-up. These teeth were stable at first, but silent pulp necrosis led to infection-related resorption months later. So missing one review can cost the tooth. This child arrived late after the injury, and what could have been a simple vital pulp therapy turned into infection and bone loss. Most of these complications were avoidable, as early assessment could have changed the entire outcome. So the message is simple. The first 30 minutes define the injury, the follow-up defines the outcome. As you've seen, trauma complications are silent. They only show themselves when it's too late. So by having a clear, structured follow-up plan is how to prevent that. So we don't wait for pain. We don't rely on parents to notice changes. We follow an evidence-based timeline. Every injury has its own timetable, and missing even one review can change the prognosis. So again, the message is simple. The first 30 minutes define the direction of the injury, and the follow-up defines the final outcome. And beyond the clinic, there are 3 pillars that shape every trauma case: prevention, education, and connection. Let's start with prevention. Most dental trauma is preventable, and even after an injury, secondary prevention is key, especially for children with a previous accident. Simple habits make a huge difference. Mouth guards for sports, safe play at home, helmets, seat belts. And at every follow-up, we have to reinforce these messages. And as clinicians, having a trauma kit ready means we're never unprepared. So remember, prevention isn't an action, it's a culture we build with families. Education is a community effort. We train our staff, guide parents, and involve schools and hospitals. And through public awareness campaigns, we prepare the whole community to respond. The more people who know what to do, the more teeth we save. Early referrals protect the child, the tooth, and the clinician. So once you've done the immediate management, or even if you're unsure, refer to us, KBBD, straight away. We are here to support you with clear pathways and multidisciplinary care. And remember, referral isn't stepping back, it's leading responsibly. In the rush of immediate management, even the best of us can miss a step, and that's normal. So what matters is having tools you can fall back on. Dental Trauma Guide website gives you a clear step-by-step guidance in both English and Arabic. Tooth SOS app helps parents act immediately and gives us a professional section linked to IADT. These tools keep you anchored when the situation is fast, loud, and emotional. So in every trauma case, those first 30 minutes shape far more than prognosis. They shape trust and long-term confidence. When we respond with calm and compassion, we do more than save a tooth. We protect a smile, a memory, a future. So the first 30 minutes define the injury, but the care that follows defines us. Thank you.
Thank you, Dr. Aisha, for your outstanding lecture. Door is open for questions. If anyone have any question? Thank you, Dr. Aisha, again. Please accept our award.
تشيك على المايك بس تمام.
إذا لا سمح الله وصلنا راح نتعدل. Don't worry.
Good morning, everyone. It's our pleasure to have Dr. Layla Al-Kadhimi here today. Dr. Layla Al-Kadhimi is a UK-trained pediatric dentist with over 15 years of experience in Kuwait. She holds a membership in pediatric dentistry from the Royal College of Surgeons of Edinburgh and a doctorate in clinical dentistry. Please welcome Dr. Layla Al-Kadhimi.
So good morning, everyone, and thank you for being here. My presentation title will be The Cleft Patient's Journey from the Perspective of a Pediatric Dentist. Okay, it's been a while since my last presentation, so I'm shaking, so excuse me. Okay, so cleft lip and palate is an interesting area in dentistry that majority of dentists don't get the chance to work with or deal with. I was fortunate to join the Clift Lip and Palate in 2014, where it was a single clinic in Amiri Dental Center run by Dr. Ashraf Mukhtar, who sadly passed away last week. Allah yarhamah bi-rahmatil wasi'ah. Dr. Ashraf's passion and dedication were truly inspiring. When I joined, I initially thought I'll do a conventional oral health care for cleft patients, including restorations, extractions, and preventive oral care. But Dr. Ashraf took me further. I was, again, one of the lucky dentists who get the chance to take impressions for newborn babies with a cleft lip and palate using the traditional techniques, that is a tray and an impression material. Consenting parents that there is a risk of inhalation and suffocation, and also working in Amiri Hospital in the pediatric ward under emergency setting, adding on witnessing the nasal cavity through the mouth was such an stressful experience that is no longer in use. Thanks for the revolutionary technology of intraoral scanner, where now we can have three-dimensional image of the detailed topography of the oral cavity within minutes and with minimal risk. I need to drink water. Sorry, huh? Okay. So this is my presentation outline, and it includes the introduction, dental phases, and the challenges. Starting with the introduction, I'll talk briefly about what cleft lip and palate is and how it is classified. So basically, cleft lip and palate is the most common craniofacial anomaly that results from failure of fusion of the facial processes during embryonic development, where a cleft lip is due to failure of fusion between the median nasal process and the maxillary process, and it can be detected as early as 13 weeks of pregnancy through ultrasound. While a cleft palate is due to failure of fusion between the palatine shelves, and it cannot be detected through the regular ultrasound as it's an internal structure. This can further be classified according to its extension and location into combined isolated, unilateral, bilateral, complete, and incomplete. Cleft lip and palate can also be classified whether it's syndromic or non-syndromic, where the majority of cases falls under the non-syndromic type. This can also be classified into sporadic and hereditary. The sporadic type, it's a new mutation, so there is no family history of a cleft, and again, the vast majority of cases accounts to the sporadic type. Cleft lip and palate is inherited as multifactorial mode of inheritance. So it is a complex interaction between different types of genes and environmental factors, including maternal health, like if the mother has folic acid deficiency or has any infections like rubella, or is taking any medications like anti-epileptic medications. So this is the non-syndromic, this is the syndromic. The syndromic is where the cleft is one features of a recognized pattern of abnormalities, and I have listed the most common type of syndromes that includes cleft as one of its features, like Apert syndrome, Pierre-Robin or syndrome or sequence, and Treacher-Collins syndrome. So the impact of this condition is far-reaching. It's not just a cosmetic concern, it affects children's development in different areas. Starting with the immediate concern, that is the feeding. It is not significant for patients with a cleft lip, but patients with a cleft palate struggle to achieve the negative pressure important for sucking. Moving to the hearing issue, where the child with a cleft palate will have abnormal function of the Eustachian tube, and this will result in accumulation of fluids behind the eardrum, which will lead to mild to moderate hearing loss. Speech also is affected with patients with a cleft palate as due to the velopharyngeal insufficiency, and this will lead to the nasal sound or the hypernasality. The dental impact, I will talk in details in the coming slide. Emotional and social impact is massive, along with the aesthetic concerns. So the presence of cleft, it will affect both the development and the growth of jaw and teeth. There will be deviation in number of teeth, and this will present as hypodontia and supernumerary. Mainly affected tooth is the lateral incisors, followed by the premolars. Also, there will be developmental defect of enamel, represented as hypoplasia or hypomineralization. The molar incisor hypomineralization, known as MIH, occurs at high frequency in patients with a cleft lip and palate, particularly with those with severe types like bilateral complete cleft lip and palate. This is one of the references. There will be also deviation in position and shape of the teeth. And this mainly affects the central permanent incisor, represent as displacement, rotation, morphological abnormalities like microdontia, notches in the teeth, as you can see in the pictures. Also, various other abnormalities, including ectopic eruption of the maxillary first permanent molar, transposition between the canines and premolars, also tarodontism. The entire timeline will be affected, so there will be delayed in eruption of the permanent dentition. The natal and neonatal teeth are also found to be more common in cleft patients compared to general population. For those of you who are not aware, the natal teeth are the teeth that the child is born with. The neonatal teeth are the teeth that will appear 30 days after birth. So for cleft patients, it's usually a maxillary tooth at the region of cleft. For the general population, it's usually a pair of mandibular central incisors. And this is another reference. So the prevalence is crucial to understand the scope of the condition in the society. Looking at the global figure on the left hand side, it's a systematic review done in 2022 and reported 1 in 1,000 to 1,500 live births affected with cleft lip and palate globally. Turning our attention to Kuwait prevalence, where it's a nationwide study done by Dr. Latif Al-Khrafi in 2024, around 1 to 2 per 1,000 live births in Kuwait are affected with cleft lip and palate. And this sets Kuwait in a moderate range globally. So based on this data and the long-term need of treatment for patients with the cleft lip and palate, the cleft unit is no longer a luxury, but it's a must as part of the oral health care system in the country. When we talk about cleft, we're not talking about a single procedure. We're talking about a journey that starts early on life and extends until early adolescence. It addresses issues, as I mentioned, with hearing, speech, feeding, dental impact, along with the emotional well-being. So a centralized, coordinated care is a must. That includes a surgeon who will do the lip and palate surgery and the revision surgeries, as well as the bone graft surgery, an ENT specialist who will deal with the hearing issue, a speech therapist who will ensure that the child will develop a clear and understandable speech, a genetist who will counsel the family and will give advice whether there is a chance of recurrence, whether the cleft is part of a syndrome or not. And a dentist who will do a lot, and I will mention this in my presentation, and of course our nurses who are the anchor of the team. So in 2022, it was a transition for cleft care in Kuwait from a single clinic in Amiri Dental Center to a whole unit in Farwania Specialized Dental Center. This massive effort was brought through the massive, this standard of care was brought through the massive effort of Dr. Latif Al-Khrafi together with Dr. Fawzi Al-Qtami and different healthcare providers who all have come together to create an elevated standard of multidisciplinary care in the country. This is our amazing dedicated unit team. And every member is well trained to deal with the cleft cases. This is one of our monthly meetings where we discuss cases, we plan for their future treatments and intervention needed. And also, we suggest things to elevate the standard of care. It is worth mentioning at this point that every cleft case in Kuwait, whether they are Kuwaitis or non-Kuwaitis, belong to any governance in the country, are to be referred to this unit. So in this website, you can find the referral form, and I will share with you the QR code on the coming slide. Also, of course, it's worth mentioning the names of all our amazing members in the team, including the dental team, the ortho, the peds, the prosto, the oral surgeon, and our general practitioners, and also the medical team, including the surgeon, the ENT specialist, speech therapist, and the genetist, and our amazing nurses. This is the QR code for the referral form in case you came across any cleft case or a patient with craniofacial anomalies. Okay? Okay, so I want to focus our discussion now on what the pediatric dentist exactly brings to the team. My first goal will be to walk you through the cleft patient's journey, highlighting the strategies of a pediatric dentist within the multidisciplinary team. So I will, like we pediatric dentists are really unique in that we deal with the patients from infancy until early adolescence. So I will show you exactly where the pediatric dentist fits within the team and how we ensure a healthy oral environment every step of the way. And my second goal will be to share with you the challenges that we face while treating our patients. So here where the journey truly begins. When we see a child like this, of course, the first thing we acknowledge is the emotional reality that the family are in. If we look closer, this is a unilateral complete cleft lip and palate case, the most common type of cleft lip and palate. And I will walk you through the patient's journey. So moving to the second part of my presentation, that's the dental phases. Okay, so as for cleft treatment, at each developmental stage, there will be an intervention, whether surgical or non-surgical. So we break down the patient's journey into 4 phases, directly aligned with the dental development. And I will detail how our rule adapts at each developmental stage. Starting with phase number 1, that is between 0 and 3. So, our main rule at this stage is we focus on parent support and building in the foundational oral home care. This phase can also be divided between 0 to 1 and once the first tooth erupts until the age of 3. So between 0 to 1, the child will have a minimum of 1 to 2 surgeries, either lip, palate, or both, depending on the type of cleft, and also the NAM appliance for every cleft patient. So what's the NAM appliance? It's basically the nasoalveolar molding appliance. If you remember in the beginning of my presentation, I mentioned that we have to take impressions for newborn children with a cleft lip and palate, and that is to fabricate the NAM appliance. It's basically, this is how it looks outside the mouth, this is how it looks inside the mouth. It basically creates a more favorable anatomical foundation prior to surgeries. So it allows the molding of the nasal cartilage, elongating the calamella, and provide nasal symmetry and projection. And this is well taken care of by our ortho team now. Okay, so once the first tooth erupts, our main rule is foundational oral health. So we also have to collaborate with the ENT specialist, make sure that the child did the first assessment, especially children with a cleft palate, and also the speech therapist between the age of 14 months and 24 months, the genetist, and we have to know the results, and also make sure that the patient is fed well and is gaining weight. So for cleft patients, we treat them as patients who are at high caries risk due to multiple factors, the dental anomalies, as I mentioned, and also other factors. I will discuss it later on. So the 4 preventive pillars have to be part of the prevention plan, starting with the habit building. We don't just ask patients or parents to brush their child's teeth, but also show them the exact technique at each stage and what tools they need to use, and to make sure that they build the routine early on in life. As you all know, التعليم في الصغر كالنقش على الحجر. And this is the general advice that we advise every single patient in our pediatric clinic. I know I get angry when I talk about this, but despite of all the education, unfortunately, parents still lack the knowledge. The diet counseling, of course, is as important as the oral hygiene. So we give the general advice, like for our general population patients, to reduce the sugary intake, to have water as the main drink in between meals, also to stop the night bottle as early as the first tooth erupts, and so on. And we know that parents love to please their children with snacks and with sugary stuff, and we always, of course, try to make them as educated as possible and to be really selective on what they allow their children to snack on. But always our words are just wasted. Fluoride, of course, is our favorite remineralization tool. It has to be applied for high caries risk patients every 3 to 4 months. Adding on the fluoridated toothpaste, that is really important. And we are now coming across the dilemma of turning to organic diet and organic lifestyle. But we have to be really strict in that point, that fluoridated toothpaste is the only known way to prevent dental cavities. And yeah, this is a general advice for all the society. The recall visits, of course, we have to have as short intervals as possible to follow up with of course, the medical treatments and the dental appointments. Okay. So to gain the compliance of the child and family, starting from infancy until adolescence, it is impossible without a strong foundation of trust built early on between us and the patients and parents. And of course, parents are the primary caregiver, the decision makers. Their anxiety and stress is massive. And I can assure you that at every visit, parents will repeatedly ask, will my child have a normal smile? Will they develop well-aligned teeth? Will their speech be understandable? And of course, we have to forget at this point being a dentist and listen to them, empathize, and really try to support them. And we have to address also these issues with the team. So in case of any things that we can treat and solve, of course, we will do our best to reassure them and make them as comfortable as possible. We have to be, of course, really clear while communicating with patients. So our advice should be clear, our treatment plan should be clear. If we refer to any member of the team, we have to be really clear why we are referring and giving the exact reason in a way that parents can understand. Our consistency in the treatment plan, in our preventive advices and in our scheduling is also another important factor. The coordinated care really elevates the trust between the patient, parents, and the team. Similarly, the child. So similarly with the child, building a positive relation between the child and the dental setting is really important so that the child will tolerate future complex ortho treatment and other treatments. Our pediatric team is doing a great job at this point. They're making sure that the child is really comfortable and is welcomed and setting their behavior early on. Start using the very basic behavior management techniques to the most advanced, the general anesthesia. Okay. So moving to phase 2. Phase 2 is the mixed dentition phase. We continue, of course, our preventive and restorative care. and our restorative and preventive care become more structured. This is not the mixed dentition, sorry, it's the primary dentition phase. So our preventive and restorative care become more structured. The child at this stage will develop some sort of independence as general children, but we have to re-emphasize at every visit that parents' brushing and supervision while brushing is really important, as children cannot do flossing at this stage, of course. Also, also we have to assess the speech. So we have to refer the patient at the age of 3 to the speech therapist to assess the speech. It's a preschooler stage, and we want the children to enter school with being comfortable and confident as possible to avoid, of course, bullying and so on. At this stage, the cleft will manifest on the growth of the jaw. So we will see a lot of arch collapse, cross bites. Also, the face panoramic radiograph will be taken at this stage. So we will know if there is any supernumerary, ectopic teeth, hypodontia. And we have to collaborate with our ortho team to plan things early on and in case of any early intervention necessary. So this is one of our amazing patients at the age of 5. Okay, so moving to the third stage, it's the mixed dentition stage. It is centered around the alveolar bone graft. The golden rule for alveolar bone graft is that the patient will have the surgery when the maxillary permanent canine crowns are covered with bone and around half of the root is developed. The decision, of course, is entirely made by our surgeon and ortho team. This surgery is done to stabilize the maxillary arch and also to allow the permanent canine to erupt in sound bone. Of course, we continue our preventive and restorative care. At this stage, the first permanent molars are erupt, and as the patient is high caries risk, we will fissure seal, of course, the 6s. Adding on, according to the BSPD, the first perio assessment should be done by the age of 7. Using the 6 index teeth. We have to prepare patients for alveolar bone graft by providing the ortho and surgeon a patient who is dentally fit. That means there is no active caries, there is no gingivitis, no periodontitis, and also all the existing restorations are sound. And of course, we have to make sure that the family understand that the alveolar bone graft is a major surgery and oral hygiene is really necessary for the outcome, of course, and the proper healing. Moving to the last phase, that is 12 and above. So at this stage, children usually are under complex ortho and surgical treatments. We try to motivate them all the way. If you dealt with teenagers, it's really difficult to convince them to take care of their hygiene. At this stage, children are usually more concerned about their appearance, so we will use that in a way to convince them about brushing and the importance of brushing and keeping a good hygiene for the improved outcome. Yes, so children will move to our general practitioner at this stage, and this is one of our patients at the age of 9. So adding on challenges to us, the children are considered as high caries risk, as I mentioned in the beginning, not only because of the dental anomalies, including the crowding, the ectopic eruption, and so on. Also, the scar tissue that results from the lip surgery, which makes approaching the front teeth really difficult. So we advise children to retract their lip and brush underneath. Also, the complex ortho treatment is another risk factor. And the oronasal fistula, it's a common complication following the palate surgery. So we will advise them on the use of the interdental brush, the water pick, the floss, and so on. Another challenge is the compliance. We understand in the beginning of the journey, the family will be packed with loads of hospital appointments. So in our department, we have a direct communication through WhatsApp. Parents can schedule and reschedule according to their convenience. And also, we follow up with patients so they don't get lost from us. Another thing is the oral hygiene. As I mentioned, this is a continuous dilemma with patients with challenges or without challenges, unfortunately. Of course, we understand that parents will praise their children with all the sugary intake and snacks and so on. And we have to make things really clear to them and tell them that إذا بتعطون حلويات لعيالكم وتونسونهم, remember that the dental visit will be really tough and a big challenge to them. And you don't want that for your child. They're struggling enough in life. It's really heartbreaking that it continues. Despite of all the education, the number of dentists present, still people are really not appreciating the importance of oral hygiene. I wish parents were sitting here instead and tell them this. Okay, so another thing is the uncooperative behavior in the dental setting. And this is expected from a child who has a lot of hospital visits, dental treatments, and of course, we cannot ignore the parental influence. And as I mentioned, that our team are really well trained to deal with the children, to try to reset their behavior to the maximum that they can afford. The last challenge is the radiograph interpretation. Of course, due to the associated dental and maxillofacial anomalies like the supernumerary, the ectopic teeth, the hypodontia, and also the complex anatomy of bone before surgery and after surgery. It was a really tough task for me when I joined initially to read the radiograph. And you should never be ashamed to ask colleagues, ask seniors to help you in understanding and interpretation of radiographs. We are all here to help each other. But of course nowadays, due to the advanced technology of the cone beam CT and the easy access of it, things are much easier. Of course, technology is taking over a lot of things, as I mentioned in the beginning of my presentation with the impression, the intraoral scanner, with the radiograph, the cone beam CT. So it's making our job much easier and the complex tasks much simpler. And of course, it's all for the patient's best outcome. So in the end, we pediatric dentists, we don't just see a tooth that needs to be fixed. Our true work is to earn that child trust. We see a child who is separated from parents, sitting on this large dental chair, surrounded by all these weird instruments. So as I said, our true job is to earn that child trust throughout the journey with us. This is our reward, and it's immeasurable. So I just wanted to share with you happy moments in my journey, and these are my triplets. Thank you for listening, and I'm happy to answer any question.
Thank you, Dr. Leila, for the rich and informative lecture. And if anyone has any question,
أول شيء الله يعطيك العافية حق البرزنتيشن العجيب.
حبيبتي.
بس بغيت أسأل، أنا بالنسبة لي أشوف إن explaining each complication that comes with any type of treatment is very important. يعني حتى the very severe type. يعني عادي أقول you're gonna have necrosis and the teeth might fall out. How do you tell the child this while still maintaining that trust that you're gonna do a good job?
شوية ما فهمت
يعني
سؤالك صراحة.
how do you tell the patient that something might go bad يعني through يعني within the treatment without losing their trust in you?
We really don't need to share this with kids. يعني you mean in what way things will go bad? I don't understand.
يعني with every surgery ممكن إن مثلا يصير في complication، يصير في infection، يصير في وايد أشياء ممكن يعني can go bad. أنا بالنسبة لي it's really important to educate them on يعني this part, not only the good sides, even the bad sides.
Yeah, you mean sharing the risks that may
Yeah.
happen from any treatment. We have to be really, reasonable with the words that we select. We're discussing treatments and risk of treatments with parents and children. And sometimes things not really necessary to be shared with children especially. Parents know that there is a chance of failure of treatments when it comes to surgical things, yes. But dentally, how bad things can go bad, I'm not sure. I mean, they know that we're doing our best, and we always try to keep them optimistic as possible with the outcome. Yeah, if that's the right way to say it, I'm not sure.
Thank you.
حبيبتي حياك الله.
Any questions?
Thank you, Leila, for your informative lecture.
حبيبتي.
I just a comment
يا والله شكراً.
on your question. I think telling them the prognosis builds actually trust. That you know what can go wrong, you know what you're doing, and you're expecting this. So you'll not lose their trust. To me, that shows how skillful, how knowledgeable you are, and how experienced you are in the situations that you are sure that this is one of the complications, especially when you are like telling them the percentage of this complication in particular to happen. So to me, it's not, you will not lose their trust. They'll trust you even more. Okay? Okay.
شكرا. شكلي خلصت وايد مبكر ها؟ وايد أسئلة.
Does anyone have any more question? Yeah.
Thank you, Dr. Leila. It was a really
حبيبتي.
great informative
حياك
lecture.
الله.
I'm new to Kuwait, and I've treated these patients, and I'm very passionate about treating these patients. I want to know from your experience, in a private setting, how do we treat these patients and still still have the ideal team where we're using other healthcare professionals? Because we know for these cases to succeed, it requires
شوية ما قاعد أسمعك دكتورة حبيبتي.
ها.
إي والله.
أحسن؟
وايد.
Okay. فقاعدة أقول إنه for these patients to be treated with the ideal care, it requires a team.
صح.
And for in a private setting, I feel like that could be difficult. So do you think from your experience يعني in Kuwait, should these patients only be treated in a hospital facility, or is it something feasible to be in the private sector as well?
Okay, أول شيء welcome to Kuwait, دكتورة. Such a pleasure actually to have you in here.
شكرا.
It's like a pleasure to have such a care and a unit that provides such a high standard of care for patients. So I understand that private is always competing with government sector. I think the coordinated care is really important, so that the patient will know that they are not lost, things are documented, things are discussed with other members of team, and this, of course, will elevate the standard of care and the outcome.
Thank you. يعطيك العافية.
حياك الله.
Thank you, everyone. Thank you very much, Dr. Leila.
نعم.
ممتاز.
Good morning, everyone. I'd like to present today Dr. Mariam Al-Khadr, who is a board-certified pediatric dentist and assistant professor at Kuwait University College of Dentistry. She earned her Bachelor of Medical Sciences and Bachelor of Dental Medicine from Kuwait University, later completing postgraduate training in pediatric dentistry at Loma Linda University in the United States in 2021, and a Master of Science in 2023. She's a diplomat of the American Board of Pediatric Dentistry and a fellow of the International Association of Pediatric Dentistry. Welcome, Dr. Mariam.
Hello, everyone. Good morning. My name is Dr. Mariam Al-Khadr, and today I'll be talking about managing pediatric dental trauma in the general practice setting. I have to shout out Dr. Aisha. Honestly, she covered a lot of things that I was actually going to talk about. So that's, I think, is going to allow me to skip through things and maybe talk more about clinical hints and tricks that might help you manage these patients when you see them in clinic. But I thoroughly enjoyed it, Dr. Aisha. Honestly, I was like, I love it. Okay. So, starting this talk, I want to emphasize the need on adopting a systematic or a structured approach when managing a dental trauma in clinic. Oftentimes, what happens is that we find that there are still treatment mistakes in the managing of dental traumas. And when we go back and look at where the error went, it's often because of an improper initial assessment. So that's why having a structured approach is very important. So I initially added a historical structured form. So, sorry, excuse me. Let me go back a step. So the literature shows us that using a structured form for obtaining history, for doing our clinical examination, is very helpful in making sure that we don't misdiagnose any tooth and that we provide ideal standard care of treatments for patients. I included a couple of free accessible resources in my presentation, but from the KBPD board, I apologize. They basically combined all the references I added and made their own structured form. So I think it would be a good reference to have on hand in clinic whenever you're faced with these patients. So, the way I structured this talk is by going through the steps one by one of what happens when I have a patient that comes into clinic. I have a panicked mom, I have a crying child, I have blood everywhere, and I'm just staring at all of this. So basically, the calm, as you said. Let's start off, first of all, by centering, being calm, projecting that demeanor to the parent, and focusing on going through specific steps, 1, 2, 3, 4. Doing that for every patient will make sure that everything is covered. So I typically start with a short medical history, asking about relevant medical conditions. So do you have any significant medical conditions, any bleeding disorders, any immunodeficiencies? Do you have, for example, endocrinological conditions? Are they controlled? Are they not controlled? Are you on any medications? And do you have any allergies? One thing to keep in mind, and I highlighted it here, and Dr. Aisha spoke about it as well, is we need to rule out non-accidental injuries. When we're dealing with kids, they're a very vulnerable population. Whenever we see trauma in a kid, we have to be the voice for that kid, and we have to advocate for that kid. Not saying I'm looking for, I'm not suspecting a certain thing, but keep your eyes open, ask the right questions, and if you're suspecting something, say something. So after a short medical history, I typically go with a short dental history. My main question is, if I know that there's a tooth fragment that was lost or a tooth is lost, I'll ask, where is the tooth? Is the tooth in a tissue in your hand, or is the tooth in a park where it fell out? If the mom says, oh, the tooth is inside his mouth, is it inside the buccal vestibule, or is it inside the socket itself? Ideally, if it's in the vestibule or if it's in a in a tissue, I immediately transport it to milk if possible. If I don't have milk, I'll ask the patient to spit in a little cup and add it there. And now there are recommendations to use saline as well. Okay. And now we'll go to the most important point, in my opinion, is to do a central nervous system assessment. So again, we don't want to laser focus on a tooth. We have to think of the patient as a whole. So we ask questions like, did your child lose consciousness? Did they experience any vomiting? Did they sleep on the way coming here after the trauma? Do you have any runny noses, anything coming out of the ear? And I would recommend doing a very short cranial nerve exam. I'll talk about it in just a second. And then we do usually an immunization, I ask about immunization, specifically tetanus. So before I get into the clinical exam, I highly recommend investing in a little pen light. When I first started my residency, my program director gifted me a pen light on my first day. And I put that pen light to use, both in the US and Kuwait, because little did I know that Loma Linda, when I got there, was considered a trauma center. So we used to see trauma every day. Second day I was there, I got called. They're like, oh, we want you in clinic. It's a lateral luxation on a permanent tooth. And I was like, oh, you know? So having a structured form helped me zero in and focus on how to help patients. So. Typically, in a cranial nerve exam, this is courtesy of Dr. Mike, and it's available on his social media as well. We start off with the first cranial nerve, which is smell. So what you can do is wash your hands with some mild soap in clinic. If you have coffee grounds in the break room, or if you have alcohol swabs. So what you would do is ask the patient to close one nostril, ask the patient to smell, and then use the other nostril. The second thing we would do is we'll do our optic cranial nerve. So we'll close one eye and we'll drag our finger from the side all the way to the front. The patient should be able to see it. It shouldn't just jump at them. Similarly to the other side. And this is where our pen light comes in. So we will shine the pen light on the patient's eyes, and we should see constriction of both pupils equally at the same time. If one is okay, one is not, refer them to medical evaluation. Okay? Continuing. Okay. And then we check on eye movement. So we're going to do, So we're going to do our H shape and ask the patient to follow along with his eyes. So for the trigeminal sensory, we will touch our forehead, the cheek, the chin bilaterally. And for the motor branch of the trigeminal, we'll ask the patient to open against resistance. For hearing, we will basically just we rub our fingers together and we move it away and close to the patient bilaterally. Okay? For the gag reflex, I won't recommend putting your finger inside the patient's mouth. I usually use a tongue depressor. Ask the patient to say, I'm just looking at your tonsils, and then just shove it slightly in there just to elicit that gag reflex. Another thing you can do is to ask the patient to swallow, but a lot of times these patients are in pain and they're in a lot of discomfort, so they don't want to do that, okay? Lastly, we're going to ask the patient to shrug. So ask the patient to lift their shoulders all the way to their ears and ask the patient to stick their tongue out and make sure there's no deviation. Okay. Another useful CNS examination scale to be used in clinic is the Glasgow Coma Scale. It's very reliable. It relies on 2 and 3 things: eye responses, verbal responses, and motor responses. So for example, for the obeys commands, I will ask the patient, can you raise your hand? Very simple. If they can, I'll score him a 6. Similarly to the other things, if the child scores within 13 to 15, that indicates that they have a mild head injury, so I can continue my examination and my treatment, etc. Anything where it's moderate to severe, I'm going to refer you to get immediate medical evaluation. Now, when it comes to the tetanus, so we discussed the medical history, we discussed the dental history, we talked about cranial nerve exam. Next, we talk about immunization, making sure the child's immunizations are up to date. Specifically, the tetanus is up to date. The tetanus immunization is very important in cases of wounds that are contaminated with soil, with soil, with gravel, with things like that. So I went back to the Kuwait tetanus schedule. So kids in Kuwait typically get tetanus vaccinations at 2, 4, 6 months. They get it at 18 months and again at 3.5 years. And then they get it during school at 10 to 12 years. And then just before they graduate high school at 16 to 18 years. Now the previous guidelines had limitations of, has 5 years elapsed, has 10 years elapsed. If you go back, the guideline does recommend that if you are suspecting if the patient needs a tetanus shot, to refer them back to their physician and to get that tetanus within 48 hours. So just make sure that you refer them promptly. Okay? So after we make sure that there is no serious head, neck, or brain injury, this is when we ask our injury-related questions. Where did it occur? Was it indoors, outdoors? Was it in a clean area? Example, was it in a mall, in a house, in a park, on the grass, on the pavement? How did it happen? And for this question, this is where I kind of typically start sussing out if it's non-accidental injuries. So if the parent is telling me, oh, the kid just randomly slipped and hit their shoulder, for example, but then you see a lot of facial trauma, bruising, things like that, there's scratch marks, there's bite marks, anything along those lines, it doesn't make sense. So when something doesn't make sense, we have to investigate further. We ask about when did the injury occur. This is important for avulsions. Was there a period of unconsciousness? Again, because we're caring about the patient as a whole. Is there any disturbances in the bite? Because that tells me if there's a possible luxation injury or alveolar fracture that's preventing the patient from biting properly. And is there any reactions to cold or heat exposure? That tells me there's possibly a dentin exposure or a pulp exposure. And if there was any treatment done elsewhere, was the tooth reimplanted somewhere? Was it placed in a storage media? Okay. So basically, we talked about injury history. We talked about a neurological assessment, medical and dental examination, clinical examination, and radiographic examination. Now we're going to move on to clinical examination and radiographic examination. So again, with everything else that we do when it comes to traumatic dental injuries, we have to have a systematic or a structured approach. The general principle is to examine from the outside going in, but then to treat from the inside going out. i.e., we start with palpating and inspecting the extraoral soft tissues going inwards. So again, because a systematic approach is recommended, I provided a little sequence that you can follow. This is not done by my efforts. It's also done by the trauma team at the International Association of Dental Trauma. But I have been following it since I started seeing more trauma patients since residency. So when it comes to dental trauma injuries, I always say you can't treat what you can't see. So make sure that you're cleaning the oral cavity and the soft tissues before you start. Get a syringe with either saline or water and gently just wash the patient's face. If you feel like that's too much for the patient, take a piece of gauze, soak it, and just gently wipe it. It calms the patient down, makes the parents more comfortable, makes the child more comfortable. They kind of see that maybe it's not as bad as they initially thought. Okay. Next, we examine the face, lips, oral muscles for soft tissue lesions. Whenever you see bruising on bruising on the mastoid region or bilateral periorbital bruising, that's indicative of basilar cell fractures. Whenever you see clear liquids coming from the nose or the ears, that's also indicative of possible head injury. So these cases, again, you need to stop and refer the patient for medical attention, okay? Some of these lesions don't show up until about 48 to 72 hours after the injury, so it might be missed on initial diagnosis. Okay. So this is just a little guide of the soft tissue injuries, how you can classify them, the extent of them, and just to give you a visual guide of what's going on. Now, after examining all of the soft tissues, next we'll move on to palpating the facial skeleton for any signs of fracture. Again, we're going with a systematic approach. So we're going to palpate the supraorbital first, and then we're going to palpate the infraorbital, checking the zygomas, checking, leaning the patient back or sitting in front of the patient, and making sure that there's symmetry, there's no depression, checking the nasal cavity from the inside as well as the maxilla, checking the occlusion, and finally palpating the mandible and checking that, okay? So we're looking for any discrepancies bilaterally, any sharp edges, any depressions, anything that seems off, so we're not missing it. Okay? So once that's done, we're gonna move into the intraoral soft tissues. Make sure that you're checking all over. So this is a sublingual hemorrhage, and it's often indicative, actually it's pathognomonic of a mandibular symphysis fracture or a mandibular canine fracture towards that canine area. So sorry, this needs to be reduced and fixed most likely. So just keep in mind that, you know, we are working in a multidisciplinary team. We understand our limitations. Sometimes things are beyond our scope and maybe we need to refer them out. Whenever you have a missing fragment, always look for it. Okay, so the parents might say, oh, he fell and bumped his mouth, and we don't know where the tooth is. I think it fell down, and we didn't look for it. But you can maybe find it lodged somewhere in the lips, here on the face, and in this one in the ventral tongue. Okay, thanks. Once we establish all of that, next we have inspection of the actual trauma region. So we're gonna look for any fractures, any abnormal tooth positions, mobility, abnormal responses to percussions, any displacement if it's buccal or palatal, and if there's a fracture, what's the extent? Is it into enamel? Is it into dentin? Is it into pulp? These are just some of the cases that I've worked with in managing traumatic dental injuries. And this picture is courtesy of Dr. Susmitha from IPEDO. So there is a pediatric forum on Facebook where pediatric dentists send their cases, and oftentimes it's very interesting cases. They get feedback. We just share our experience. So if you're able to join, I think it's a good resource to have. Once we do that, then we can go into our mobility testing. So again, in mobility, number one, we're determining the loosening of the tooth, and we're determining if multiple teeth are loose at the same time, i.e., is it a single tooth that's mobile, or is it an alveolar fracture causing all these teeth to be mobile? Next, we do our percussion testing. Again, we need to do these testings if possible because we need a baseline for our injured tooth, because we're gonna follow up with this patient and we need to make sure, is it improving, is it getting worse, et cetera, et cetera. So percussion testing has two functions. Number one, we're checking if there's tenderness to percussion and any damage to the PDL. Number two, we're checking for ankylosis with a high metallic sound. And if ankylosis doesn't develop, it might develop in the future. Now, when it comes to pulp sensibility testing, there's a huge, I guess, I don't know what to say, question mark on it. So it should be noted that kids with young, immature, permanent teeth do not respond reliably to pulp testing. However, in the guidelines, it's recommended that we do it again as a baseline so we can follow up with that kid. So I would recommend that you do it. However, if the child is super young, if the child is cranky, if they can't handle it, then wait and the next follow-up and you can do it then. Sometimes that initial visit is too much for the kid. Now, when it comes to primary teeth, pulp testing does not give me any benefit. So I would not recommend doing it, neither do the guidelines. Okay. I'm going to go with radiographic examination. So a guiding principle when we think about exposing the patient is this image likely going to change our treatment management? We can say, oh, each tooth requires X amount of X-rays, but at the end of the day, we are dealing with a growing child, so we want to minimize the radiation as much as possible. So whenever a kid comes to me with what appears to be a bloody socket, there are three things that come in mind. Either the tooth is avulsed, either the tooth had a root fracture and lost the coronal fragment, or the tooth is intruded. So it's very important to take an X-ray in this case. You can see that the tooth has been intruded. Similarly, this is just another case to show you that it happens more often than not. Okay. So the typical radiographic criteria for taking radiographs in traumatized teeth, I'm going to use the maxillary teeth as an example. So we want a central PA showing both the traumatized teeth. Then we typically take one angulated to the right, showing the lateral, as well as showing the central incisors and the canine. Similarly, one on the left, showing the lateral, the central, and the canine. Now, when a child falls, or a ball hits their face, or an elbow hits their face, it's not targeting those little incisors, top incisors. So oftentimes, the lower mandibular teeth are affected as well, and they can be missed. That's why we have to take a lower occlusal. Now, the reason we take an upper occlusal is just to make sure that there is no alveolar fractures or any missed root fractures. Also, the reason for taking multiple radiographic projections is just to make sure that we're not missing any root fractures. Okay. So remember the little picture where there was a tooth stuck in the lips? I hope you do. Okay. So whenever there's a cut and a laceration on the lip and there's a loss of a tooth fragment, it's always recommended to take a soft tissue radiograph. Now, there are two types of soft tissue radiographs. We have an intraoral soft tissue radiograph, which is where we put the film between the lips and the teeth, and we reduce the exposure by a quarter. This will help me identify if there is a fragment or something in those lips that I'm missing. Then I have another exposure called a extraoral soft tissue, where I take it, the film is placed outside, and I reduce the exposure by half, and this will just show me where the fragment is in relation to the soft tissue. Is it up top? Is it down low? Things like that. So if I am planning on taking it out myself, I can have an idea. Again, we do have more advanced techniques. I am just suggesting this as a general, the general practitioner setting, a polyclinic, for example. Okey-dokes. We're going to get into cases in just a bit. That's why I'm trying to get through this. So, children obviously are unique. They're growing, they're developing, and their teeth are also growing and developing. So it's very important when when a child presents with dental trauma to assess if that traumatized tooth is primary or permanent. Typically, kids under 5 have mostly primary teeth. Kids about 8 from 6, 7-ish onwards, they start getting their mixed dentitions. We can say as a general rule, typical, not 100%, but by 8 or 9, the 8 incisors would be permanent, and then 13 and above typically is all permanent. So keep that in mind, and when you have an avulsed tooth that is primary, please do not reimplant it. The reason I'm emphasizing this is I went to a couple of trauma conferences, and there are still questions about people wanting to replant primary teeth. but the risk, first of all, the success of that tooth lasting are so low, and the risk of damaging the permanent tooth are so high. Now, if you're able to always take photographs just as a baseline to document what happened to the patient and your follow-up later on, but obviously always take consent from the family. So with this combined information from the clinical, radiographic examinations, then we can treatment plan. So the intraoral injuries are divided into injuries to the dental hard tissues and injuries to the pulp. I just wanted to share this resource with you. It is from the trauma guideline. Basically, it's like an interactive website. So if you have a patient and you're not really sure of what's going on, you want a little bit of guidance, you basically click on it. It tells you, is it primary or permanent? If it's permanent, is there tooth structure loss or not? Yes. Is it enamel, dentin, or pulp? Yes, etc., etc. Until it guides you to what the likely cause is, and then it will give you how to examine, how to take radiographs, how to do emergency management if you're not able to refer to specialist care at that time. Okay. So I'm not going to talk about all the injuries because that's a whole other topic on its own, but I did want to talk about a couple that I wanted to share some cases with. So we have crown fractures. Whenever the pulp is not involved, it's called an uncomplicated fracture, and whenever the pulp is involved, it's called a complicated fracture. Again, this is within the trauma guideline website. I just wanted to show you the resources you have. So for example, in the enamel fracture, it will tell you that you have the option to just smoothen the edge and then take an X-ray, obviously, or you have the option to do a composite restoration. This is sped up a little bit, okay? In cases of enamel dentin fracture, you would clean the area. You can apply chlorhexidine or sodium hypochlorite, and then you would put cellulose matrix so you don't stick to the other teeth, and then you can apply your liner, typically resin-modified glass ionomer liner. I typically use Vetrabond. Okay, so this is one of the cases I'm presenting today. This is Carolina. She's a 9-year-old. She presented to our pediatric clinic saying, per mom, saying she was running at home yesterday, chasing her little brother, and then she fell and she broke her teeth. I took her to my family dentist. I had some teeth, broken teeth that I had with me. He told me to put them in water and go to the emergency room. So by the time she presented to us, it had been 24 hours after the emergency, and there were no neurological symptoms. So we ended up, obviously she has an upper lip laceration as well as some little bleeding on her lower lip, so we ended up taking a soft tissue radiograph, just making sure that there's nothing going on. We took 3 X-rays, again, one centered towards each tooth of the trauma. That just helped us eliminate any root fractures. Okay, so we diagnosed the tooth with an uncomplicated fracture of tooth number 1-1, complicated fracture of 2-1, and 2-2. So these are the fragments. They were placed in water for 24 hours, which is perfectly fine. So when we were thinking about how best to manage this child, we had a lot of options available to us. So the first one was to do pulp therapy on those complicatedly fractured teeth for the pulp treatment, and then do fragmentary attachment to restore as a restorative option. The second option was to do an RCT with a post-in core and maybe strip crown those broken teeth, and again, fragmentary attachment or composite on 1-1. Number 3 was root submersion or decoronation and prosthesis, and do basically a removable or a fixed appliance. And last option, which definitely would not recommend, but again, we have to take into account parents' finances and their family situation that's going on, was extraction and prosthesis appliance. We informed parents the risks, alternatives, benefits. We told parents that if we do move on with choice 1, it doesn't mean that it's going to be 100% successful. The fragments might fall off. We might need to do RCT. We might end up doing a core buildup and strip crown. So just for time's sake, I didn't go through the entire process, but what we did is basically a partial pulpotomy on 2-2 and 2-1. and we reattached the fragments. Now, one thing I wish I could change is that we did use white MTA for this kid because Biodentin was not available at that time. And you can see in the radiograph, it has a little bit of discoloration right here. The child is fine with it. It was just me being a little bit picky. Yeah. I just wanted to show, obviously, when I'm working with a kid, I wasn't documenting, oh my gosh, let me take every picture of my fragment reattachment. So I just wanted to give you a little clinical steps. So basically, we isolate. This is called a field mouth isolate. I have not used it before. We acid etch both fragments. We rinse and dry. We apply bonding agent to both. We apply composite to both, and basically we stick them together and remove the excess composite, and then we light cure. Okay. One thing I want to mention, just so I don't forget, is don't forget, if there's any remaining pulp tissue in that fragment, please make sure you remove it so it doesn't blow up and cause infection, okay? So this is the patient 1 month after. You can see there's gray discoloration of the MTA on 2.1 and 2.2 with generalized mild plaque-induced gingivitis. However, periapically, everything looked good. However, we did notice a little ledge on tooth number 2.2 that we ended up smoothing. And this is her 1 year after. Everything is healed, looks good. There's something going on here with the gingiva, but other than that, the teeth themselves are good. Okay. Now, this is another case. This is my strong kid, honestly. So this is Trinity. She's a 13-year-old who was skateboarding down a hill, not wearing any type of protective equipment, when somebody, so imagine she's going full on skateboarding, somebody crossed her path. So in order to avoid them, she tried swerving. She fell on the pavement and literally hit her chin. She hit her chin, she broke her arm, she got a concussion. So by the time I saw her, they called me at the emergency department. I think it was like 2 or 3 a.m. She was just in pain overall from everything that she was going through, and I could not do a proper examination. I saw the exposed pulp on tooth number 3.3, so ended up just capping that and putting some flowable composite on it. And then I don't know if you can see, but there are some fractures all over here and here, so we ended up just literally holding the pieces together and just placing composite or GIC and seeing her in the clinic the next day, because in the emergency department, I don't have any instruments, nothing to play with. And the ED would not sedate her because she's been through so much already. So without getting into too many details, do you see the arrows? Every arrow had some sort of fracture. Every tooth had some sort of fracture on it. And she was in a lot of pain. She was very tired from everything that was going on. We took x-rays after anesthetizing the patient, and we basically went over of what should we do for treatment. Obviously, tooth number, it's supposed to be 3.3, was referred for grad endo for evaluation. The premolars all had a crown fracture without knowing the extent. Now, did we consider doing a CBCT on this kid? Yes, we did. But because of the amount of fractures that were going on, we just, as a department, thought it would be too much of an exposure for her to go through, to risk, And she was a very good kid, so she could handle treatment in clinic. So I'm not going to talk about all the definitive treatment. I just want to show you what we did in terms of emergency management. She was very symptomatic on this tooth, so we ended up dealing with it first. The idea was just to place a band in order to stabilize the tooth, but she was in a lot of pain, so we ended up removing the mobile fragment. We found a pulp exposure. We did a direct pulp cap of MTA and did a Fuji restoration just to temporize it. The plan was to do possible crown lengthening and reattach the segment, but again, because this patient also had other ortho concerns, this is a multidisciplinary case. Trauma in general is a multidisciplinary case. So we had to meet with ortho, with pros, with perio, and we ended up deciding that the best option for this patient was an SSC. Similarly, the tooth next to it, you can see also has a fracture line. And if you see from the x-ray, you can't really tell how deep the fracture line is. So we temporize this tooth just by placing a band in clinic. Other options would be just to approximate and, like I said, place a little bit maybe of flowable or composite until you can get them to specialized care like the KBPPT board. So we basically ended up temporizing it, and she was fine, but after consulting with ortho and figuring out a more comprehensive treatment plan for this patient, the decision was to extract this tooth after getting parents' consent, but that allowed me the opportunity to show you of how deep that fracture line was. So if we were gonna save that tooth, that was gonna need crown lengthening, and perio was very questionable about the crown lengthening, and just a lot going on. Okay. So again, we have here, in this case, the pulp wasn't exposed, so we ended up just cleaning the tooth with sodium hypochlorite and placing Vetrobon. Now, I'm not gonna go into all of these teeth. I just wanted to tell you that on the teeth that we did end up saving, we made them all 1 millimeter below occlusion with knowing that ortho will extrude them and maybe we'll change the crowns later on. Okay? So this was her before and after, and then this was her after starting ortho. She's still doing good. The teeth are still surviving. I have an issue with MTA if you can't tell. But this was great MTA. Okay. So I just want to talk about splinting very briefly, just talk about the management of splinting and lateral luxation before I leave you. When we think about things like root fractures, luxation injuries, splinting is, so there's mobility of the tooth. So we always want to stabilize the tooth. Now, if you want to go to the exact indications of when to splint and how to splint, the trauma guideline is available and we'll give you all the details, and Dr. Aisha did an amazing job of also glossing through that as well. So whenever we want to splint, my number one thing, and sorry, I can't see it here. My number one thing is to protect the patient's airway, please. So again, these patients are pretty tired, they can't open, sometimes they can't even handle a bite block, so we have to rely on them opening them out. So make sure you have a 4x4 gauze to protect the airway so that nothing falls in the patient's throat. Okay? So in splinting, we will clean the oral cavity, the trauma site. We will apply acid etch, and we will wait for 20 to 30 seconds, wash and dry. We will basically choose a size. So like Dr. Aisha said, we typically go at least one tooth beyond the traumatized tooth. Now, again, in kids, sometimes we have exfoliating teeth, sometimes we don't. We have mobile teeth, so we have to extend it a little bit further away. So that's another complication, because the longer the splint, the more likely it is to detach and the kid coming back and needing replacement. So that's in clinic, we typically use 0.016-inch ortho wires. However, I understand that's not available for every clinician. So per the guideline recommendation, you can use fishing line about 0.13 to 0.25 millimeter. This is a fishing line that is readily available in Kuwait. So this was, sorry, ما أعرف الكلمة بالإنجليزي، لوازم العائلة، موجود بلوازم العائلة 900 فلس as an option. لأنه we don't all have access to ortho wires. We might not all have access to, those ideal power, the power chains and all of those things. Okay, so make sure that you measure the splint, cut it, acid etch, bonding, and then. So this is the bonding, sorry. So then we put a little bit of composite, we place our splint at the top, and then sometimes I add a little bit more composite, and then we light cure, and then we wait until, however time we need to, and then remove it. We typically remove it just with high-speed burrs. Now you can see that they adapted the wire to the teeth, and that's just to create a passive, flexible splint. We don't want the splint to be active. We don't want the splint to move the teeth. Do I always do it? No, just because it's not always feasible, especially with a difficult kid, okay? The wires we're using are not rigid enough to, I'm okay not always adapting it because the wires are not extremely rigid. Okay, so when it comes to luxation injuries, typically in concussion and subluxation, we just observe. It's basically like a bruise to the tooth. There might be a little bit of tenderness, might be a slight mobility, but there's nothing much. By 2 weeks, they typically resolve. Now, where we actually do something is in lateral luxations, extrusions, and intrusions. So, as I told you, my first experience as a pediatric resident, do you know when they tell you that cliche story of, oh, it's 5 p.m., you're almost done with clinics, suddenly this emergency patient comes in? Exactly, that's literally what happened to me. So they called me, they paged me, emergency patient coming in. So first, you're going to anesthetize the tooth because it's going to hurt, okay? So we're going to anesthetize the tooth, and then we are going to clean the area and take an X-ray, supposedly, yeah. So we typically take an X-ray afterwards because the patient is in too much pain sometimes to take it before, okay? So we anesthetize and then take our X-ray. The way we do the lateral luxation injury is we have a tooth, and because of the force of the trauma, the tooth basically moves either in a buccal or palatal direction and gets locked within the bone here. Sorry. It gets locked within the bone. So what you want to do is we want to apply pressure to dislodge the tooth from the bone. But now if you just apply pressure and leave it as it is, that tooth might slip away from the bone and go inside the patient's mouth, and the patient swallows it. ما عندنا ضرس خلاص. So it's very important to keep holding the tooth while you're pressing down so it can go back into that socket. Okay, so let me show you. Again, all of these are from the trauma guideline, okay? So we stabilize it, and then we clean it, and then we place a splint. Easy peasy. It's hard to do it the first time, but once you get the hang of it, once you do it a couple of times, it's very easy to grasp. Sorry. This is just a slide showing you the management of an extrusion. So this child was in a motor vehicular accident. After obviously resolving her, they ended up, she had an extrusion of tooth number 1-1. They ended up splinting it, I think, for 2 weeks. This is the 1-month follow-up, 3-month follow-up, 6-month follow-up, and 1-year follow-up. Amazing results. I'm not going to go into intrusion. Dr. Aisha covered all of that, so that was amazing. But typically, again, monitor is where we typically, it depends on if the apex is fully formed or not. If it's not fully formed, we typically wait for 4 weeks. If it is fully formed, it depends on the degree of intrusion. The more the degree of the intrusion, the faster we have to intervene. And then the interference is by doing either ortho extrusion or surgical extrusion. Again, that's why it's very important to have a multidisciplinary team working with these kids. Finally, just in terms of avulsion, the only two tidbits that I want to share is that you can invest in a Save a Tooth solution, which is Hank's balanced solution, and you can keep it in clinic so that if a child loses a tooth, I typically recommend it, especially in like sports gyms, things like that, just because it's great to have it and to keep the tooth in, to keep that PDL viable. Obviously, if you don't have it, milk works great, the patient's saliva works great. Is it the best? Is the patient's saliva the best? No. Milk is our number one choice, but you're not going to have milk, for example, in a park, you know? Okay. This is just one of my cases where we had avulsion of the tooth, so we just ended up re-splinting it. This is just to show you that, again, this patient is, look, he has still his primary maxillary teeth, so he's pretty young, and I didn't have anything to splint on, so I had to extend it all the way to the canine. And he did it under nitrous. He's a good kid. Okay? So I'm going to end the last couple of slides with focusing on parent education and post-op instructions. Post-trauma, maintaining oral hygiene is very important for healing the teeth. So make sure that you're brushing twice a day with a soft bristled toothbrush. I typically recommend something called, a Nimbus toothbrush. It's extremely soft bristled. I like it because it reminds me of Harry Potter. Kids like it as well. It's very gentle on their teeth. Clean the area with chlorhexidine using a Q-tip. Soft food diet for up to 2 weeks. But if the child can resume their normal diet sooner, let them resume the normal diet sooner. It will be better for the healing of the teeth. And talk to them about follow-up. So I put this little meme here for you guys because like Dr. Aisha said, we can do the best treatment, but then we lose the patients and they come back with disastrous results, and it's a shame because we want to help them and we don't want them to go through that ordeal. So emphasize the importance of follow-up. This is the actual structured sheet that I personally use. It's from the AAPD guidelines, but honestly, I think I'm going to grade up to yours since it already combines both. Okay, so my last few thoughts are knowledge is power. The more you educate yourself, the more confidence you gain, and the more you're able to provide high standard quality of care for your patients. So I'm thankful for you all today for coming here and listening to this talk and getting more in-depth information about dental trauma. We have the Tooth SOS app that's developed by the International Association of Dental Trauma. It's both for the public as well as professionals. It basically gives you a little hint of, if my tooth is knocked out, what do I do, etc., etc. It's good to have it on your phone, easy to access. So they also have different resources to educate parents, to educate families in different languages so that you can educate your patient regardless of the background. I think they said 30-something languages. Now, all that to say is that we can't talk about international efforts without shouting out the local efforts in Kuwait. So there were great efforts by the School Oral Health Program to help educate the community with regards to traumatic dental injuries. This is one of my personal favorite videos. Since I discovered it, I include it in all my lectures. So I'm going to end with this one. ما في volume. And that's it. Thank you so much for listening. I appreciate you. Does anybody have any questions? Are you good? Ready for lunch?
Thank you, Dr. Mariam. Thank you very much for your very informative lecture. I think we all loved the video in the end. Just before we start with the questions, I have a quick announcement. We're going to be starting the next lecture now because we're running a bit ahead of schedule. And Dr. Abdulaziz Thnayan has requested that he start the lecture now. For those of you who are standing in the back and can't find any seats, the other lecture hall is available where you can sit and watch the lecture on the big screen. And any questions now? Does anyone have any questions?
I think they're good.
Thank you very much. Very informative and lovely lecture. So thank you. Now, just on, I think, Trinity case, the girl with the skateboard. I'm sure you did this, but just to comment and reinforce this. Since she fell on her chin, I think.
Oh, actually, I have one. Thank you so much for that. Did you mean the pen or did you want the chin
Yes.
picture? Definitely, she fell on her chin. Thank you for that. She fell on her chin, so obviously we have to suspect if there's, other than the molar fractures, if there's any condylar fractures or any issues with the TMJ, definitely to Capano. On that one, everything was good. Thank you. I should include it next time. I appreciate that. Oh, sorry.
Thank you very much, Dr. Mariam. Thank you.
Sure.
Dr. Mariam, thank you for the informative lecture.
Sorry.
I have a quick question in
Yes.
regards to the skateboard incident. When is it appropriate to take CBCT? I know it's not a first line of mode of X-ray, but when would you move to taking CBCT?
For that kid with the multiple
Yes,
fractures,
yes.
honestly, when we saw that it was multiple fractures, we were thinking of taking a CBCT, and it wasn't wrong because for some of the teeth, they ended up having a complete vertical fracture. I didn't go into it, and we ended up trying to save it and ended up extracting it and just basically did the same, did think twice before instead of once. The reason we didn't take a CBCT with her is because her parents were hesitant about the radiation, and she was a good kid, so they didn't want to expose her, especially since she got a lot of radiation in the hospital because of all of her injuries. And I was working in California, so they're very particular about these things. But if I could, I would have taken, most likely I would have taken a CBCT for that case.
Thank you.
Okay. Okay.
The Tri-Collegiate Membership in Pediatric Dentistry. His work reflects a strong commitment to advancing children's oral health and promoting community dentistry. Please join me in welcoming Dr. Abdelaziz Al-Thnayan.
Thank you so much for the introduction. Good morning, everyone. It's my pleasure to be here today. And today I'll discuss the prevention and awareness and care for improving the pediatric oral health with the focus on the 3 pillars. So over the next 30 minutes, I'll share evidence-based insights along with the clinical and outreach experience that demonstrate how to improve this outcome. At the beginning, let's take a quick look at my journey. So I started my undergraduate studies at Ajman University, and from very early I knew that pediatric dentistry was the path I wanted. And then I continued my postgraduate studies at University of Manchester, and I obtained my degree in Masters and passed the MP Dent exam. And when I came back to Kuwait, I joined Amiri Dental Center, and from there I joined the prevention team, the dentist team, and now I'm honored to serve as the president of the Kuwait Pediatric Dentistry Association and to support the specialty in Kuwait. So let's begin with the first slide, the introduction. Dental caries remains one of the most common diseases globally, and its impact starts early in life. Early childhood caries is one of the most common chronic disease, and it affects nearly 50% of children under the age of 6. So when we talk about dental caries, we are not only referring to the oral health, but also we are addressing speech, growth, and overall well-being. So the story is not only about caries, it's also about the impact on health and the quality of life and development. As a dentist, our role is not only to treat the patient, but also to stop the disease and to raise awareness and to help caregivers to reach appropriate care pathway. So we have 3 pillars that I'll focus on today. The first pillar is the prevention, and our objective is to outline preventive strategies that can be implemented in early childhood. And the second pillar is awareness, and our objective is to evaluate community outreach as a tool for early detection and education. And our last pillar is care, and our objective is to understand care pathways for the pediatric populations in Kuwait. Let's start with the first and the most critical pillar, prevention. And we will focus on early intervention, ensuring caregivers receive advice before the disease develops. So why children are at risk of caries? When we talk about the primary dentition, we have to remember that the enamel is thinner, less mineralized, and less able to resist bacterial challenges. And the early childhood caries is an aggressive form of dental decay. It frequently affects the maxillary anterior teeth, and once it's established, can progress rapidly. The etiology is multifactorial. However, diet plays a significant role, especially prolonged bottle feeding or frequent consumption of milk or juice in bottles. Clinical and developmental consequences. Children with untreated caries might experience pain, abscess, or infection, which can impact their ability to eat, sleep, or communicate. It also will cause emotional distress for the parents, and it will cause missed work days for them and school absence for the children. And many cases require early restorative intervention, and in more severe cases, pulp therapy or extraction may be unavoidable. Premature tooth loss is not just an immediate issue. It predisposes children to space loss and can create more orthodontic challenges. And many cases require general anesthesia for the treatment due to age limitation and behavior management. Prevention toolkit. Now that we've seen the problems, let's shift our attention to the solutions. And believe me, prevention is powerful. Toothpaste and fluoride recommendations. The guidelines recommend using of fluoridated toothpaste for all children aged 0 and above. And what matters is the quantity of the toothpaste. So for patients from 0 to 3, they have to use a smear layer of toothpaste, and once they reach 3 and above, they will benefit from pea-size amount. And patients with high caries risk will benefit from using 1,350 to 1,500 ppm. And supervised brushing should be supervised until at least the age of 7 or 8, according to the guidelines of the AAPD, the SDSEP, and the DBOH. Systematic reviews confirmed that nearly 24 caries reduction from fluoridated toothpaste, and habits formed early are easier to sustain. Sealing the futures. The ideal time for the fissure sealants is after the eruption of the permanent first molars, around the age of 6. The evidence is strong. Systematic reviews demonstrate nearly 80% reduction in occlusal caries among children. And we have 2 materials we can use, the resin-based or the GIC. The resin-based has superior retention than the glass ionomer. However, glass ionomer can be used for partially erupted teeth or in high moisture control, as isolation is the key, either with rubber dam or cotton rolls. Moving to diet, which is a critical factor, reducing the frequency of sugar intake is more effective than the total load of sugar. We must also flag hidden sugar. Many families don't realize that even with healthy snacks such as flavored milk or cereal bars can be carcinogenic. And juice in bottles and bedtime milk are 2 of the highest behaviors and still extremely common. We have to promote water as a default drink alongside healthy snacks helps establish lifelong habits. Prevention in the clinical setting. Fluoride varnish should be applied twice a year according to the guidelines. and recall intervals must be risk-based. High care is patient and special needs patient may benefit from applications every 3 to 6 months. The evidence is strong. Systematic reviews show a 43% reduction in caries in permanent teeth and 37% in the primary teeth. And clinically, the recommended is 5% sodium fluoride varnish equivalent to 22,600 ppm. And make sure that the surface is clean and dry to ensure optimal fluoride uptake. Now that we've covered the first pillar, prevention, let's move to the awareness, which involves community outreach through the DynoDentist team. In this section, I will walk you through how outreach activities can support early detection, reduce dental anxiety, and connect caregivers into appropriate care. This photo reflects our work across multiple community settings, from schools and special needs centers to public campaigns in malls and hospitals. We've worked directly with children and families outside the clinic settings. The DynoDentist team, we are a dedicated pediatric oral health team with a clear mission. Our mission is to take the dental education beyond the clinic, making it engaging, accessible, and fun. You will find us active in malls, schools, hospitals, and special care centers. Why does it matter? Because when children meet the dental team in a familiar environment, it will help to build trust, reduce fear, and reduce dental anxiety. So this is the team behind it all. It all started as Dr. Dalal Sabah idea. From there, we built a multidisciplinary team. Behind the scenes are pediatric dentists, Dr. Ali Akbar, Dr. Basma Al-Ataibi, Dr. Sheikh Al-Ataibi, Dr. Sabah, and myself. Our role is to organize events, to ensure accuracy, and to help in diagnosis. With time, and as we got bigger, the team expanded and general dentists joined us. We have Dr. Ahmed Al-Anizi, Dr. Abdullah Al-Wadani, and Dr. Sharif Al-Qattan. And their role is to deliver care and guide parents. And none of this would be possible without our dedicated volunteers who engage children and make the environment more welcoming. Reaching children beyond the clinic. This approach gives us an opportunity to reach children who may never had access to dental care. It also allows us to identify early lesions before symptoms develop. So it will improve the outcomes and reduce the overall burden of the oral disease within the population. Our achievements up to date, we've delivered over 85 structured outreach sessions, reaching more than 12,500 children and counting. This data is not just numbers, it represents thousands of children who are now more likely to maintain healthier smiles and who can attend dental care with confidence. Our engagement plan, so we follow a structured plan to deliver each session effectively. We have 5 stations. The first station is the oral hygiene educational session. The second station is interactive activity to reduce dental anxiety and to become familiar with the environment. The third station is toothbrushing demonstration with hands-on practice to reinforce proper technique. And the fourth station is a discussion about chirogenic and non-chirogenic food through games. And the last station is dental examination. Here we have one of our volunteers in the last event in Al-Asma Mall explaining about the stations that we offer. I think the voice is not working. So here we are giving an age-appropriate oral hygiene educational session, keeping it engaged, interactive, simple, and fun. We engage the children with the questions to help them understand the importance of healthy habits. Here I have a video of one of our volunteers, Dr. Hussein Dashti, giving a lecture to the kids, and you can see how they engage with the questions. Through experience, we found that coloring is effective in reducing dental anxiety and allow them to become familiar with the environment. Also, they can keep their color sheet with them as a souvenir. They can take it home. We also conduct a hands-on brushing session to reinforce proper technique, and children are guided step by step using models, allowing them to practice effective brushing in a supportive setting. We include discussion on diet and nutrition, helping children distinguish between chirogenic and non-chirogenic foods. Visual aids make the message easier to encourage healthier choices. At the final station and after completing the previous stations, children are more confident and ready to step into the dental chair. Here we can see dental examinations involving children of all ages, including those with special needs. And after completing all the stations, every child receives a certificate. We tell them that they've been graduated from dental school and become little dentists, creating a lasting positive memory. And each child receives a dental chart. The chart indicates whether caries were detected and serves as a note for the parents to seek further care with their dentist. It also reinforces the importance of regular dental follow-ups. Here we can see our activities taking place in multiple settings, indoors and outdoors, morning or evening, reflecting the flexibility and reach of our team. None of this would have been possible without the support we receive from Dr. Ahmed Al-Awadi, the Minister of Health, Dr. Ahmed Asad, وكيل وزارة المساعد لشؤون طب الأسنان, the head of the Pediatric Dentistry Department, Dr. Maryam Mado, the head of the pediatric units from the specialized dental centers. As you can see here, Dr. Anfal Fraidoun from Farwaniya Dental Center, Dr. Ali Safar from Amiri Dental Center, Dr. Turki Mjaoub from Al-Jahra Dental Center, and Dr. Amal Bahabahani from Adan Dental Center. And we would like to thank Dr. Salah, the head of Jabir Dental Center, and the president of the KDA, Dr. Saad Al-Shimmiri, as well as Dr. Yusuf Al-Awadi and Dr. Muhammad Al-Muhdib, who have been supporting us from the early beginning. Each volunteer receives an official Dino-Dentist certificate of participation. This certificate can be added to their CV and used when applying for postgraduate studies in Kuwait or abroad as an official proof of volunteering. And if anyone would like to join our Dino WhatsApp group, you can scan this QR code where we share updates about our upcoming events and volunteering opportunities. Now that we've covered prevention and awareness, let's move to the final pillar, care. This is where we transition from screening to actual dental services. It's an essential step that closes the loop, making sure children who need treatment can reach it without delay. The first visit by age of 1 is more than a checkup. It's a preventive milestone. This is where we educate parents about caries risk and about habits and about diet. Here we have a discussion with the parents about habits such as pacifier or thumb sucking. Also, we guide them about home care prevention guidance, about what toothpaste they use according to the needs of fluoride concentration, and about the diet tips and brushing techniques. Bridging the gap in access to care. In Kuwait, many families face confusions about where to take their children for dental care, and delays in care frequently not because the services are unavailable, but because they don't know where to go. As a dentist, we are not only treating teeth, but also we are helping families to understand the treatment pathway. So the care in Kuwait, the services is delivered through 2 sectors, the government and the private sectors. We have 3 levels of care for the government sectors, the primary in polyclinics for routine dental treatment, and the secondary specialized dental centers for complex cases and emergency. The treatment system for the pediatric population in Kuwait is based on the age, health, and area, and it's a walk-in system without referrals. The pediatric dental treatment pathways. Patients aged 0 to 6 are treated within pediatric clinics in the specialized dental centers. Patients aged 6 to 15 years are covered under the school oral health program, and once they turn 16 and above, they transition to the polyclinics. Special needs treatment pathway. Patients from 0 to 12 are managed by pediatric dentists within the specialized dental centers, and once they turn 12 and above, they transition into the special care clinics. And for complex cases, treatment is delivered under sedation or general anesthesia, depending on individual needs. And the option of general anesthesia is only for the special needs patients. Access pathways for children dental care. So the pathway exists, but parents need guidance to use it effectively. This slide shows the pediatric dental treatment pathway in Kuwait, showing the distribution of services across the 6 governorates in Kuwait. It outlines how patients aged 0 to 15 are directed to specific centers according to their age group, general health, and areas of residence. I would like to thank Dr. Sheikh Al-Ataybi for her precise work in mapping treatment pathways across Kuwait's pediatric dental services. Emergency clinics of the school oral health program. The slide shows weekend holiday emergency clinics, which ensures continuous access to urgent dental care for patients aged 0 to 15 from 7 a.m. to 9 p.m., which covers the 2 shifts during weekend and holiday. Night dental emergency clinics. So recently we have night dental emergency clinics, which operates daily from 10 p.m. to 6 a.m., ensuring that dental care for urgent cases remains available throughout the night. Clear pathways ensure every child receives the right care at the right time. Now I'll share 2 cases that we found during screening. This case involves a 6-year-old child examined during one of our community outreach events. A supernumerary tooth was identified during screening, and the parents were advised to attend the pediatric dental clinic for further management. The patient belongs to Amiri Dental Center, where I work. I carried out the treatment, and the supernumerary tooth was removed. Extraction was planned to prevent potential complication and to support the normal eruption of the permanent teeth. Another case involves as well a 6-year-old child. He was examined during one of our outreach events, and a double tooth was identified, likely fused or geminated. Also, there is an additional finding of intrinsic discoloration on the upper right A. So the parents were advised to visit the dentist for radiographic evaluation and further assessment. What these cases show: outreach detects silent anomalies in asymptomatic children. Early diagnosis prevents complex treatment, and prevention isn't just fluoride. In conclusion, prevention begins before the disease, and outreach plays a critical role in this journey. It helps reduce anxiety, build trust, and create bridge between awareness and access. Guidance alone isn't enough. We must ensure that families understand how to access the care. And finally, through collaboration, we have the power to improve outcomes and shape healthier future. Thank you.
Thank you very much.
Here are the QR codes if you want to scan them or take pictures for the pediatric dental treatment pathway for the weekend holiday dental emergency and the night dental emergency clinics.
Thank you very much, Dr. Abdelaziz. Now the floor is open for questions. Is there any questions?
Hello. Thank you, Dr. Abdelaziz, for a wonderful lecture. And I'm sure you've done a lot with prevention and educating the children in all sorts of places. But my question here, now that you're in an amazing position, being the head of the KPDA and part of the DynoDent. Is there any collaboration with, let's say, the government, such as the Ministry of Education, in working on better dietary habits in schools? Because we all know that children have a lovely breakfast, and it's all cardiogenic. And we know that the children spend half of their day in schools. One way to start with changing their diet is there. So are there any movements towards this?
We are trying to work on that, yes. But it's not very easy, but we are trying to, especially with the, like the schools in Kuwait, it's not very easy to change that, but we're trying to reach the government schools, as there are some potentials to change like the diet and the type of food they offer at the schools.
Exactly, and even with supermarkets, if we start, for example, having the flavored milk in the higher shelves and the non-flavored milk in the
and the thing that even the caregivers, they think it's healthy to use it like on a daily basis. So also in the clinics and also outside the clinics, we are trying our best to reinforce the habits and to change that.
Any other questions?
Thank you so much for your presentation, Doctor. I really liked how you covered a lot of preventive strategies and how the outreach is helping promote awareness. Now, when it comes to the stage of giving care, you might it's of course expected to encounter a child that really needs that care at that specific time period. But then you have the parents, and then the parents are really, they're really reluctant on giving that treatment, but the child really needs it. In the heat of that moment, in the heat of making that decision and trying to convince the parents to go forward with this treatment, what potential strategies can we consider to make sure, to ensure that the parents are aware that their child needs that care before pain starts showing?
So after attending the clinic, we just outline the treatment plan for the parents, and they have to follow the treatment plan that we offer to them in order to treat the patients.
Okay, thank you.
Thank you.
Okay, thank you everyone. The next presentation gonna start at 1:45. The lecture hall gonna be open at 1:30. Thank you, everyone.
Small introduction about Dr. Mohammed Abdul Wahab. He's a consultant dental anesthesiologist at the Ministry of Health and a faculty member at Kuwait University and the University of Pittsburgh, licensed in both Kuwait and Pennsylvania. He practices in Kuwait and Pittsburgh and teaches evidence-based dental sedation with an emphasis on nitrous oxide and oral sedation. Over 15 years, he has lectured nationally and internationally, developed practical protocols for patient selection, dosing, monitoring, and recovery, and also trained a multidisciplinary teams to deliver safer, anxiety-free care. His work integrates research, clinical innovation, and education to elevate outcomes and patient experience across the region. Today, he will distill best practices into clear, immediately actionable steps for your dental team. The lecture titled Advancement in Dental Sedation, Optimizing Patient Comfort and Safety. Dr. Mohammed, the mic is yours.
في صوت؟ المايك is good? Okay. السلام عليكم يعطيكم العافية. Welcome to my lecture. My name is Dr. Mohammed Abdul Wahab. Could you turn the lights off? Or I can't really see. Okay. My name is Dr. Mohammed Abdul Wahab. I'm a consultant dental anesthesiologist. I did my training at University of Pittsburgh Medical Center, UPMC. I also did my undergrad and postgrad all over there. Thank you for the invite, KDA, to give this lecture. And I'm going to talk about the sedation and how we manage and the option we have these days in Kuwait for people that have anxiety. So I'll start with the first thing. The first thing that actually the first anesthesia, the first anesthesiologist. So Dr. Horace Wells was the first dentist that used nitrous oxide. And he did that in 1866, so almost 150 years ago, almost, maybe even more. And actually before that, they did discover nitrous oxide, and they didn't use it medically. It was actually just, they discovered that gas, they didn't do what actually it's doing, the properties. But then Dr. Horace Wells, who was a dentist actually, did that, and he actually did a third molar extraction, and it was a success. And so we consider that as anesthesiologists or dental anesthesiologists as the first anesthesia provider in the world, which was Dr. Horace Wells. And they have, I think this, what is it? October 13th is like nitrous oxide day, and we celebrate that. Then after a while, after using nitrous oxide, back in the days, and the history actually shows that, people start using nitrous oxide in parties. They actually used to have big gatherings and actually have big barrels of nitrous oxide, and they just let open the nitrous oxide and they have the gas. And that's when it came the word laughing gas, because it makes people happy and people start to laugh. And they start actually to dance and do many other things. And some people, even in the literature, and if you read the history, sometimes they actually had boxing matches with nitrous oxide. They have to bring two people and they start to box with nitrous oxide just to see the effect. So that's a little bit about the history of nitrous oxide and the sedation that's been used. Now, what is sedation? Whenever we say we're going to send the patient to be sedated, or we get a request to have the patient sedated, or you have a patient that wants sedation that comes to you, and it's actually very popular now in Kuwait. We define it as the reduction of anxiety, stress, irritability, or excitement by giving a medication or a drug. So this is a basic thing. You give a patient something to actually just relax them, make them stress-free. And if they have an excitement, or if they actually have a special need patient that actually moves, you cannot control the movement, you give them medication to actually just control all of these things. And this is basically the sedation definition. Now, the route of sedation, or the route of giving that medication, we use it as the definition of the sedation, the type of sedation. So sometimes we say that we're going to do an oral sedation, or sometimes we're going to do inhalation sedation, or sometimes we say we're going to do IV sedation, because of the route of the drug administered or the agent that we give the patient. Now, based on statistics and based on study, we did a study in Kuwait at Kuwait University, and we published it, and I don't remember, but a couple of years ago. We found out that 29% of the population have fear, anxiety toward the dentist. And that's actually similar to other countries. But do you know the least country with anxiety? Can I ask? Do you know the country that have the least amount of anxiety toward dentistry? Yes, anybody? Huh? No, actually it's an Asian country. Japan. Japan actually have the least number of, least percentage of anxiety or people that anxious patient toward dental patient. And actually our percentage, our statistic, the percentage that we have in Kuwait is similar to the one in the US and in Canada. So they're actually 27 and 30. So it's actually about this. But if you translate that to patient, real patient, that means that from every 1,000 patients that comes to your office in Kuwait, you're probably going to have 290 patients that have anxiety. And honestly, with the practice, I think it's even more. I don't think that number is real. I think maybe with the population, because we did 1,360 patients, or we surveyed people, I think we have even more higher percentage of patients with anxiety. Now, from these patients with anxiety, we found out that 30% of these patients actually want to have sedation, want to have a medication. They do not refuse to actually take a medication or take a drug, and actually want to be asleep before having dentistry done. Back when I started in 2010 in Kuwait, we had this thing. Many patients think that sedation is dangerous, and they think that going to sleep to have dentistry is not needed. 15 years later, actually now it's different. The mentality have changed. Now patients come to us and they ask, I want the sedation done. I don't want to feel anything. I want to be asleep to have this. So if you're actually in Jabir Hospital, because I practice in Jabir, yes, we do offer that. If you're in private practice, yes, we offer that. Okay, so actually this is one thing that you actually should be able to offer your patient. Now, why do we do it? Or why do we need sedation? Anxiety and fear, this is number one, and the most thing that, or the most main factor that we have. The other thing is uncontrolled patient. An uncontrolled patient, we actually categorize them in two categories. Pediatric patient. Do we have any pediatrics or pediatricians? Can you raise your hand? Honestly, I applaud you guys. I don't know how you deal with kids. It's very, very difficult to deal with kids. It's extremely difficult. I work with pediatricians, and I have some colleagues here from Jabir, and they're awesome. The amount of pressure they have and the amount of patience they have, it's amazing. And also special need patients. Special need patient, we talk about patients with special or mental challenges. These patients, you cannot even reason with them. So they have very, very bad oral hygiene. And they're very difficult to do dentistry. So that's another category that we need sedation for. And just think about it. If you're a parent with a special need kid, or an adult sometimes, we have like 25, 26, 30, 35-year-old, but they're actually mentally challenged. And they never been to the dentist because they don't have the access to sedation. If you actually can provide that, it's going to be a life-changing experience for the parent and the patient. Another thing we do, or actually the need of sedation, is pain control. Whenever we do sedation, it does provide pain control. So if you have big procedures, third molar extraction, implants, all in 4, all in 6, all these big cases, yes, we can do that. Even with regular cases, sedation does provide pain control. It's actually a very good thing that you can provide to your patient. And then the control of movement. Sometimes we have patients that actually have tremors, or some patients that actually have very severe gag reflex. With sedation, yes, we can control that. You can take your impression with no problems. The patient will not be moving all the time. So you can do your good preps, and you can do very good dentistry. So basically, we summarize the need for sedation based on these kind of 4 things. Now, we talk about type of sedation. Whenever we talk about type of sedation, it's basically the route of the medication administered. Whenever we said at the beginning as a definition, defining sedation is giving a medication or a drug, something that the patient will receive externally just to make them sleepy or to make them actually sedated or relaxed. Now, the type of sedation, we talk about how we give this medication. Usually we start with inhalation sedation, and that's usually the one common thing we use in dentistry is nitrous oxide. So with nitrous oxide, it's basically inhalation sedation. If we give something through the mouth, it's oral sedation. Any pill or liquid that the patient can take is basically oral sedation. Intravenous sedation is giving medication through the IV, and then general anesthesia is basically kind of combination, or it's just general anesthesia. But in the medical field, in the dental field, each one of them kind of gives you a level of sedation. So sometimes whenever we talk to our special need colleagues or pediodontists at Jabir, or oral surgeon or periodont, whenever we do anything, they say, yeah, I don't want IV, I just want some oral sedation. So it's kind of a language of the deep or the level of sedation that we want to give the patient. So that's something whenever we talk to each other. So I'll start with inhalation sedation. Inhalation sedation, we talk about nitrous oxide. Nitrous oxide is very, very easy, safe. It's very safe, actually, and it's very easy to use. You do need a certain certification to do it in Kuwait for a certain specialty, if you're not a periodontist or like a dental anesthesiologist. So the Ministry of Health do have certain training requirement, and they do have a permit that you have to obtain. It's safe, it's very safe, and it's easy to use. The main important thing that we have to emphasize is only good for mild anxiety, and that's the misconception we see with dentists. Sometimes we get patients referred to us whenever we do our pre-op. We know that this patient will not be a good candidate for nitrous oxide because the patient has severe, severe dental anxiety and severe, severe dental phobia. So that's something you have to understand. Whenever you refer a patient to have nitrous oxide, you want to make sure that the patient is kind of falls within like a mild anxiety category, not severe anxiety. And the other misconception the dentists actually say, they tell the parents or the patient that you will be completely asleep with nitrous oxide. However, that's not true. We have patients that comes to us, we put them to sleep, or we give them nitrous oxide, and they're not asleep. They're actually awake. They're relaxed, but they're not 100% asleep. And that creates more anxiety to the patient because the patient is anticipating that he will fall asleep, he'll be 100% asleep, and he's not. So that's kind of create a circle of, I would say, just increasing the patient anxiety. The other thing that with nitrous oxide, the patient needs, we need the patient cooperation. We need the patient to be actually willing to sit on the dental chair and actually to put the nasal hood on the nasal mask on their face for at least 5-10 minutes just to have the effect of the nitrous oxide. That's the other thing that we need to make sure that the patient understands. And we do, whenever we do our pre-op for the patient, we do actually train the patient on how to do that. So we bring the patient, we have flavored masks for the patient, and we kind of, if you have a kid, we tell them what flavor your favorite, and then they can smell and choose, and then we provide them with their best or their most flavor they like. And then we put the mask on, and we tell them just smell it, take a deep breath, and we kind of give them a practice, kind of a demo of what to expect during the procedure. Now, we always have kind of different ideas about nitrous oxide with pediatric patient. We have periodontists, periodontists here, I know. They do work on, they say it does work personally. If the patient is under 6, it's very difficult to have nitrous oxide done alone. Yes, sometimes we do mix it with oral sedation. We give some to have a more sedated level or more sedation to the patient. But nitrous oxide alone on a patient younger than 6, it will be very difficult because the patient will not cooperate. The patient will be very difficult to sit and have that mask for, I don't know, half an hour, maybe 45 minutes. It's not a good idea. I know some periodontists in the audience. I know them personally, and whenever we talk, I know they actually do nitrous oxide on younger than 6. If it works for you, it's good, and it's very safe. So don't feel it. I'm not going to say it's a limit, age limit, but if it works for you and know it's safe for you, just do it. But personally, it's been very difficult for me to actually achieve good sedation with nitrous oxide on a patient younger than 6 years old. Okay. Mild anxiety. Other issues with nitrous oxide is the office limitation. You should have an external suction that actually, whenever you actually have the system, you will have an exhaust system. So the patient is breathing nitrous oxide, and then they will exhale another nitrous oxide. There is no metabolism, very minimal metabolism of nitrous oxide. So you should have an extra high-speed suction that actually connect your machine to it. So the patient, whenever the patient exhales the nitrous oxide, you do not want to contaminate the office, so you want it to suction. Actually, external suction or an extra suction. Because usually if we connect it to the assistant high-speed suction, the assistant will not have that. And that sometimes create limitation to the office or limitation to the procedure. So that's something, if you want to introduce nitrous oxide to your office, you should be aware of that. The training, you should have training. If you're a general dentist with no previous experience, there are courses in Kuwait that actually do provide nitrous oxide training with hands-on training. And then we have to talk about the misconception, which was it only works for mild anxiety, not severe anxiety. Patient with severe anxiety, nitrous oxide or inhalation sedation does not work with. Now we kind of move to a deeper level of sedation, oral sedation. Oral sedation is basically giving a medication or a pill to the patient. In Jabir Dental Center, we do provide about 3 or 4 different types of medication that we give to the patient based on the level of their anxiety. And it works really good, and we do that a lot with adult and children. The only issue we have is pedo patient, or I would say younger patient. The taste of the oral sedation, the midazolam we use, is really, really bad. It's extremely bad. So we kind of try lie to them, tell them, yeah, it's nice, people ask for it, but extremely bad. So sometimes we only have that one chance to do the procedure because the patient will remember, I went to the dentist, I already have anxiety. He comes, he said, yes, that drink that we gave you, that medication is really, really bad. So kind of you have to be prepared if you're doing sedation that you're ready and you want to do most of the dentistry in that appointment. Now, with oral sedation, there's no special equipment. It's just a pill. It's like taking Tylenol or a pill, Panadol or something. It's either a pill or a liquid. Drug interaction it's not severe. If the patient have any reactions, it's generally very, very mild, it's not severe. So it's very, very safe. And usually you do not the patient will not get very, very deeply sedated with oral sedation. Okay? And usually, I prefer personally, if I'm going to do oral sedation, I add nitrous oxide. So we usually do a combination of oral sedation and nitrous oxide. And it works really well. We have good results with oral sedation and nitrous oxide. The combination is good. We've been able to do many cases, pediatrics, adult, even surgery cases, surgical cases. We did a lot of that with just these 2 combinations. Now, if we add, whenever we do both, the patient will be deeply sedated. And the good thing with oral sedation and the medication we use is not only the anxiety reduction, is the amnesia. And one thing about anesthesia, we actually rely a lot on amnesia. For us as anesthesiologists, if the patient cannot remember the event, it never happened to the patient. So basically, even if the patient, and we see that, we give the patient medication, oral sedation, special or IV sedation, the patient might move, or the patient might actually, pediatric patient might shout or cry or something. But because of the amnestic effect of the medication, they wake up and they don't remember anything. So for the patient, never happened. For us, yeah, it did happen, but for the patient, which is the most important, that experience did not register in their brain. So it's basically never happened, and he was asleep. Now with oral sedation, it's actually worked with moderate anxiety. So it's even better than only giving nitrous oxide. So nitrous oxide is mild. Oral sedation it actually works for moderate anxiety. And it works really well. Now, another thing, well, I would say the other side, not side effects, okay, negative thing about oral sedation, you cannot really do a long procedure with it. And you cannot titrate. You're not going to give the patient a pill and then wait after 1 hour you give another one. Some people do that, but we do not recommend it. They call it stacking. It's not really recommended because you cannot titrate with oral medication. Okay? You want to titrate, you do IV, and then you give slowly and incrementally until you reach the level. The other bad thing, or a negative thing about oral sedation is the onset. It usually takes anything between 20 to 30 minutes just to have the onset, the effect, until the patient actually is asleep. So whenever we actually do that, we prepare that with the dentist, that the patient will come at 9, but be prepared at 9:30 to start the procedure. I'm not going to just start at the time of the appointment. The other thing about oral sedation is you cannot predict 100% the level of sedation. It's not an IV because we give that fixed kind of amount of dose of medication, and the patient You cannot really predict 100% compared to IV sedation or compared to general anesthesia. I would say oral, IV sedation. So sometimes you give that medication and you calculate it based on weight, you calculate it based on the medical history, chronic diseases, whatever the patient is actually have. But sometimes you cannot really control the level of sedation. Some people will be sedated, some people will not be sedated, and some people go really, really into deep sedation because the way the metabolism works. Now, intravenous sedation, I would say, is if you have access to that, especially people in the private sector, if you can actually go and find a center, a hospital, or something that you actually can provide that service to your patient. In Jaber Hospital, we do provide IV sedation to our patients, okay, in the hospital. But it's actually, I think it's the best procedure, non-invasive way of method of sedation or anesthesia we can provide to the dental patient. Usually the setup is, if you can see the patient's a dental chair. I have actually real cases we're going to show you later, but it's usually on a dental chair. You only have a monitor and you have the anesthesiologist on the back and you have the surgeon or the dentist doing the dentistry. But it's actually the best type of sedation for most of the dental procedures. It does provide many things that we want. It does provide amnesia. The patient will not remember. It does provide analgesia. The patient will not feel anything. We can give many pain medication through the IV. And we can control the patient movement. So it's excellent for special need patients. It can actually work anywhere from mild to severe level of anxiety. So you can do a lot of procedures. The patient will be just asleep, kind of. He will be very deeply sedated. He'll be arousable if you actually do big movement. The patient might just move, but he will be into that deep level of sedation. And it's very good. It's very good for pediatric patients, special need patients, surgical patient, surgery patient, regular patient. And the other thing is we as anesthesiologists can titrate the level of sedation. So sometimes, for example, whenever we do implants cases with IV sedation, the periodontist or the prosthodontist, whenever they take all these things and they want to check occlusion, they tell me just bring the patient back, meaning I want less sedation because I want to make sure that the patient can bite, or I want to talk to the patient and have them bite or do something with their mouth. So it's very good because we can titrate. I can make the patient deep, I can make the patient light. And based on this, one big, huge, actually, market came up and advertised, which is one-visit dentistry, sleep dentistry, and you can see that now, even in the street. There's a lot of ads about one-day dentistry, get all your teeth while you're asleep, come to us, you won't feel anything, stuff like that. So there's a huge demand for this, and believe me, if you're in private, especially if you're private, if you can provide this to your patient or get somehow connected to like a hospital or have access and privilege in a hospital, a same-day surgery center, or you can even establish this in your dental center, it will be very good for your patient. I would say the kind of negative things in Kuwait, there's very limited providers of IV sedation. And with IV sedation, you have to start an IV. So basically, you're introducing an IV, you actually puncture in the skin, compared to nitrous oxide, which is you basically put a mask and oral sedation, or just basically taking a pill, or you're actually swallowing a liquid. With IV sedation, no, you're starting an IV. So you go into okay, what complication can happen with IV start, infection, bleeding, and all that things. And the last thing is you do provide deeper level of sedation. So if you're not really well trained to manage very deep sedated patient, you should not do that or provide that. So these are three things. And the other thing, sometimes the provider, the dental provider, the dentist or the surgeon or the periodontist, whoever, they don't want the patient to be that level. With IV sedation, they actually do go very deep. Okay. Now, kind of general anesthesia. General anesthesia is basically, you can do any type of dental procedure with general anesthesia. So that basically the patient will come in, They need to be fasting, even with IV and oral sedation, and they actually need to go into a OR, which is usually something similar to the picture. You have the general anesthesia machine, and they will induce the patient go into 100% sleep. It's very common for pediatric patients and special need patients. And I know most of the periodontists actually do work on special need and pediatric patients do that. They don't do a lot of IV sedation. But this is very common and it's very safe. So, but you need to go into the OR. So that's kind of the bad thing. You have to have a setup, like you have to provide that in the OR. The good thing, you can do any type of procedure, even long procedure, as long as maybe you put a Foley catheter into the patient. You can do like 5, 6, 7 hours cases. You're in OR, so you can do a procedure, a very long procedure. The other thing you can do, provide most advanced surgical procedures. Sometimes you want to, like orthognathic surgery, sometimes they take like bones from the hips, they put in the face or the jaw. You can do any type of procedure, basically. The patient is 100% asleep, they won't feel anything. You will provide all the pain medication through the IV, so he won't feel anything. As for our patient, you do require more preparation for that. Sometimes you go to the hospital, you take your equipment, and not all hospitals are prepared for that. And as for cost, it's more expensive. So basically, patients sometimes don't like it because they will pay more. I will show you some of the cases that we did, or some cases of actual cases. This is Dr. Yusuf Al-Awadi. Actually, thank you, Dr. Yusuf, from his clinic, Smile Design. I don't know if Yusuf is here or not, but we got this video from him. And he's doing nitrous oxide.
شنو حاسة بشيء منى؟ منى؟ لا زين الحمد لله. بطلي حلقك حيل هنشوف. هني قولي لي حاسة بشيء؟ زين. الحين أنا راح أهز لك ضرسك لما هزه عشان تطلع الوساخة منه. زين؟ شوفي راح أهزه يمين ويسار كذا. شوف. يلا بطلي حاسة بشيء.
If you can see, the patient is awake. The patient is relaxed, awake, and he already gave the injection, the local anesthesia, and he's going to just do the extraction for the patient. So this is what I say. If a patient or a parent was been told that the patient will be asleep, and that's the level they will reach, this is the maximum level they will reach with nitrous oxide, they won't be happy. They will say, he's not asleep, he's not asleep, he's not asleep. What's wrong, what's wrong, what's wrong? And that will increase the anxiety of the patient if they're an adult, and if the parent told their kids that you will be asleep, even the kid will be very anxious. And it will be a very bad procedure. You won't have a very good experience. The other thing about nitrous oxide, if you can see, is the nasal hood. Sometimes the nasal hood will give you a limitation of doing anything through the anterior because it will actually put pressure on the upper lips and you can't do anything. Now there are some new devices, or it's called the silhouette system. It's a new system for nitrous oxide. They have very small nasal hood, which is better, and the hoses are very thin, and it works better, I would say, to the regular old nitrous oxide. So this is kind of a true scenario of a nitrous oxide case, inhalation sedation case that we did through the clinic. Now, this is a real case that we had, and this is a patient that came to the clinic, and they needed literally all his third molar extracted. If you don't provide anesthesia, your only option is either local, right? Or you tell the patient, just deal with it, I guess. Okay? So the top ones, the 1 and 16 or 1, 4, 1, 1, 1, is it? 1, 8, 1, 2, 8, they're actually easy to extract, I would say. The lower ones, the lower one, which is 3, 8 and 4, 8, they're really bad, or actually very difficult to extract. So what we did, we checked the medical history. He was 28, and we checked all his medication, everything, and he was fine, and we scheduled him to extraction. And then we did this. You can see the patient on the regular dental chair. He had the surgeon. He was, I think, our chief resident back then. and the other one is actually a periodontist. He was in residency. And you can see it's a regular dental setup. It's just a regular dental chair. We have the monitor on top. You can see the IV on his right arm area. And the patient is just in regular clothes. He didn't need to be admitted. He was just fasting. We checked everything. We gave him instructions. He came in. We put everything. We put the IV. We gave them medication. And they did everything they want in, I think, 45 minutes. And the patient was extremely satisfied, and he left. So it was a very good procedure, very, I would say, successful procedure that we did. We had other patients, and we do this, actually. We have a dentulous patient. This patient was 61-year-old, completely dentulous. She wanted implant, and she wanted like denture on top, or implant retained denture, I think they call it. Okay, so we checked everything, and the plan was to put 8 implants, and we did the same thing. The patient was dental chair, regular dental clinic, and she was just relaxed. You can see nothing in the mouth. There is no tube in the mouth. The patient is not intubated. She's just relaxed, regular clothes, no need to change into anything. We put an IV, we gave the medication, and the patient, they put all the implants they needed. That's what they did, like 4 on top, 4 lower, and the patient was very happy, and she left, and she went home, and they did everything. That's another patient that we did, but we did general anesthesia. If you can see from his OPG, he needed full mouth extraction. That was the plan. So we did all the medical history. And the reason actually we did general anesthesia was the acid reflux. Because of the acid reflux, if the patient has acid reflux, even if the patient is MPO, the patient is fasting, we're afraid the patient will actually vomit during sedation, and they will aspirate, and it's an extremely dangerous thing. So we just said, okay, well, let's do general anesthesia, and we actually intubated the patient, and they did complete mouth extraction, and the patient was extremely happy. So these kind of the cases that if you have access to sedation, you can actually broaden your practice, and you can actually do more cases to provide more service to the patient. This was a pedo patient that actually we did, I still remember, that was during residency. Not my residency, but during like one of the residents. Okay, and that was the amount of the teeth. So all the way A to L, I think you need how many? 1, 2, 3, 4, 5, 6, 7, 8 extractions, couple, maybe 3 stainless steel crowns, and the rest is a couple of composite. So I'm sure the periodontist here, they do that a lot. So we did general anesthesia for that patient, not sedation. Okay, he was 4.5-year-old. We didn't choose to do any like nitrous, because nitrous will not work for that amount of dental work needed. The other thing, it's just better with general anesthesia or IV sedation. Well, we didn't do general IV sedation because it was residency, so we wanted the resident to train. But with experienced periodontist, IV would be fine. But with this special case, we did general anesthesia. We intubated the patient. The resident took, I think, about 2 hours, and they completed everything in one setting. So they did all the teeth, they pulled everything, they put stainless steel crown on everything, and they just finished the case in one setting. So this is basically the option we have, and we do have these options in Kuwait, so don't feel afraid to actually ask us. I think that's it. Okay, ask us about the options, or if the patient has severe anxiety, or what to. Yes, with the Ministry of Health, we do provide sedation services. I know many of you don't know that, but we do. And private practice, they do. So if you have a patient, or don't tell them to just, especially kids, like don't tell them to man up, خليك ريال ولا. It doesn't, I think we're above that. We have the technology, we have the services, and please, if you have any question, just please ask me. Thank you.
Thank you, Dr. Mohammed. A very informative lecture. Any questions?
Any questions? No? Sure? Dr. Yusuf? Ah, I didn't see you. Okay. Any questions? Okay. Thank you very much. Thank you. الله يعافيك. شكرا. هذا خلص الكرة هذا.
أهلا. Hello? Okay.
This next lecture is presented by both Dr. Noor Langawi and Dr. Mariam Arab. Dr. Noor Langawi is an American board-certified specialist in both pediatric dentistry and sleep dental medicine, with advanced training from Boston University and a fellowship in sleep dental medicine at Tufts University. She earned her bachelor's and master's degrees in dental surgery from the University of Leeds and currently serves as an assistant professor of pediatric dentistry at Kuwait University. Dr. Mariam Arab is a craniofacial orthodontist and dental sleep medicine specialist. She's also American board certified in orthodontics and dental sleep medicine and a fellow of the Royal College of Dentists of Canada. Dr. Arab serves as an adjunct assistant professor at the University of Pacific, Department of Orthodontics, and as an adjunct assistant prof in Department of Pediatric Dentistry at the University of Pittsburgh Medical Center. She completed her MSD in orthodontics and dentofacial orthopedics at Boston University, followed by fellowships in craniofacial orthodontics at UPMC and dental sleep medicine at the University of Pacific and Stanford Sleep Medicine Center. Her work focuses on nasoalveolar molding, growth modification, and oral appliance therapy for sleep-disordered breathing. Dr. Noor, the mic is yours.
Good afternoon, everyone. Thank you for the kind introduction. I am honored to be here today and looking forward to sharing this topic with you. This is our academic background. Today we will touch up upon some basic background on sleep disorder breathing. We will talk about the medical and dental etiology, and then the symptoms and screening methods that we can use, and then treatment, both medical and dental, and as well as the role that we can play as dentists. So let me start by the what and why and how questions. So what is sleep? It is a natural and reversible state of rest in which your body and brain becomes less responsive to the outside world while performing essential internal processes that keep you healthy. And in sleep, we have stages, and each stage has a specific role, a specific purpose. So for example, we have the non-REM, which is the light sleep. Here we do the tissue repair and the energy restore. And we also have the REM sleep, which is the rapid eye movement. It is the deep sleep. Here we do dreaming, we restore our memory, and we also have the emotional process. Why do we need to sleep? Sleep is essential for cognitive function, thinking, focus, learning. It is also essential for emotional balance, physical recovery, hormone regulation, immune strength. So without enough sleep, almost every system in the body suffers. And then how many hours do we actually need to sleep for? The amount of sleep you need depends on various factors, especially your age. You notice here that with increasing age, you need less hours of sleep. Other factors include sleep quality, previous sleep deprivation, and pregnancy. I want to show you this clip. It is of a child who was picked up by his parents from school. He fell asleep in the back seat. You will notice here, he started by loud snoring. Then briefly he stopped breathing. And then he will gasp for air here while changing the position of his head to reopen his airway. So this is a classic example of possible sleep-related breathing disorder. So what is obstructive sleep apnea, which I will refer to in this presentation as OSA? It is basically a disorder of breathing characterized by prolonged partial upper airway obstruction or complete obstruction that disrupts normal ventilation during sleep. Some other basic definition: apnea, a complete absence of airflow for at least 10 seconds with a corresponding drop in blood oxygen saturation, and also the number of arousals, which is the number of the times the patient is waking up at night. Hypopnea, it is very similar, except that it is a reduction in the airflow not necessarily that complete pose of breathing. And then apnea-hypopnea index, is what defines OSA in a formal sleep study. It is the number of apneas and hypopneas per hour of total sleep time. Here I want to show you the difference of apnea-hypopnea index in children and adults. Children are diagnosed with obstructive sleep apnea at much lower AHI threshold. Here in this table you can see anything below 1 for children is considered no disease. However, for adults, anything below 5 is no disease. I also want to show you this diagram. It shows the spectrum of sleep disorder breathing. You can see here on the left, the green side, the patients can range from normal quiet breathing, maybe some light snoring, then heavy snoring, but they all fall under no disease. But then, of course, it can go all the way to the red side, where it can be severe OSA symptoms. Here, they fall under disease. The airway becomes more blocked, the breathing pauses, and oxygen drops, and it can affect health. But even having habitual snoring doesn't mean it can't go to the OSA symptom. It is actually part of a spectrum. So it can actually progress to OSA. This is why we have to distinguish if this is just normal routine primary snoring or if it is something more serious like OSA. Here I want to show you the global prevalence of OSA. It is approximately 1 billion for ages 30 to 69. And in Kuwait, there is a recent study that was done by Dr. Al-Gattan that showed that 1 out of 5 working adults were actually at a higher risk of having OSA. So now let's move to the etiology. I will start by the medical etiology. The number 1 cause of any type of OSA is hypertrophy of the tonsils and the adenoids. So, for example, at the dental clinic, you are doing your exam, and then you see the size of this tonsils back there in your patient. It should allude to you that, hey, this patient might have symptoms of sleep, so you can dig deeper and screen. Second is obesity, but also patients that are not obese, underweight, especially in kids, can have OSA. And then craniofacial characteristics, such as patients with Treacher-Collins syndrome, any patient that have small mouth, micrognathia or high palatal vault, narrow palate, mandibular retrognathia or microglossia, these are all patients that can be at a higher risk for OSA. Then finally, patients with neuromuscular disorders, which can affect the muscle tone and function, so the airway is more collapsible, such as patients with muscular dystrophy, cerebral palsy, and Down syndrome. There are also other categories that we have for our patients that are born premature, patients with metabolic disorders, patient with gastroesophageal reflux disease. There is a sign that you can see in those patients. They have erosion in their teeth, and a clue that you can see with the erosion is basically this is a clue that can let you do a screening for OSA in those patients. And then also we have patients with immune dysfunction, and then also environmental factors, patients who may be prone to secondhand smoke in the household or any other type of environmental allergies, and finally genetics, as OSA can run in families. And then for our dental etiology, we have mouth breathing. This can lead to a narrow and high arch palate. You may see typical in our patient what we call adenoid faces. Patients that have seasonal allergies. Patients are not sleeping well. You can see dark circle under their eyes. You will also see open mouth structure like this patient up here. And then we have dental agenesis for patients with ectodermal dysplasia, for example. Patient missing 1 or more teeth. The concern here that the alveolus is actually dependent on the actual presence of teeth. So if teeth are not in the arch will be more collapsed, and this will actually worsen the problem. And then we have bruxism. This is very common with any type of sleep disorder breathing. And then, of course, we have the breastfeeding and bottle feeding topic. We always say that breastfeeding is actually better because it will provide us with good immune system against a chronic inflammation of the airway and the tonsils, but it also involves a very peristaltic movement that can, of the tongue, that can strengthen the muscles of the jaw and also the development of the mandible. And then finally, malocclusion. Those are patients who have class 2 or more of a class prognathic maxilla, retrognathic mandible, and perhaps anterior or posterior cross bites or open bites. I want to show you this case. This is very famous all over the internet. It is a classic case of twins. What happened here is that one patient was trained very well to breathe from her nose, and the other patient clearly did not follow the instructions. Can you raise your hand if you think that the patient on the right have OSA? And who thinks that the patient on the left has OSA? Okay. So actually, it's the patient on the right. It's the one who have OSA. You can see the result of mouth breathing here. You can see the flattened cheeks. You can see the crusty lips. You can see the mentalis strain. And you can also see that the patient developed a steep mandibular plane angle, which developed into a long dolichocephalic face pattern. So it is very important to train our patients to breathe from their nose in order to have proper development of the arch forms and the mouth, and also to decrease the risk of having issues like OSA. Okay, so why do we care? Why do we need to screen for OSA? Because sleep disorders are actually very serious. It can cause car accidents. It can cause cardiovascular events. It can cause high blood pressure, stroke, heart attack, diabetes, obesity, depression, impaired productivity, and also learning difficulties for younger kids. And actually, 85 to 90% are undiagnosed. So how can we screen them? We are in a very unique position to be able to identify patients at the greatest risk with a good history and a careful clinical exam at each dental visit. We can identify the signs and symptoms that may raise a concern for OSA. I know, most of us don't have time in the clinic. We have lots of patients, but at least ask the basic questions. Ask, have you been told that you snore? Have you been told that you stop breathing at night? Do you often feel excessively sleepy during the day? If a patient have issues, then dig deeper. Then you can go and ask about the sleep history questionnaire. There are actually questionnaires for the adults and children. 3 questionnaires for adults, 1 questionnaire for children. The adults questionnaire, they are all validated, and they are sensitive enough to detect the presence and the severity of OSA. Like the upward sleepiness scale, it tells us how sleepy the person is. And then we have the stop bank questionnaire. Most of us use this in our clinic. It is the most common and famous one. It is a better also sleeping tool. It evaluates the snoring, tiredness, observed apnea, high blood pressure, BMI, age, and the neck circumference, and a high score indicates a greater risk. This is the pediatric sleep questionnaire. It has 22 questions, and if a parent answers 8 or more yeses, then this prompts us to refer the patient to a sleep study. We ask in this questionnaire if the child snores loudly at night, if they stop breathing, if they occasionally wet the bed at night, if they sleep in an unusual position, if the teacher in the class have any comments about the child being sleepy during the day, or even if they have learning difficulty. This is a study that talks about the association between childhood sleep disorder breathing and disruptive behavior disorders in childhood and adolescence. It states that snoring has double the chance of an ADHD diagnosis or having symptoms of ADHD. It also shows that OSA is associated with 3 to 4 chance of having behavioral disorders. This is a form that was created by Dr. Audrion. She is a pediatric dentist and also an orthodontist. She is a big name in sleep. She uses this in her clinic, hands this to the parents before they see her for a consultation. And if the parents, for example, picks a box on this, she uses this as a chance to educate the parents on, for example, why is bedwetting related to OSA? Why is snoring related to OSA? Why is learning difficulties related to OSA? So this is a form that also you can use in your clinic. Now let's move to the physical exam that you can do. First, we can start by the BMI. If the patient have BMI of 30 and above, then this puts them at a higher risk. You can do the neck size exam. 17 inches in men or anything above 16 inches in women will put them in a higher risk. And also any craniofacial abnormalities. I talked about this earlier. And also we can check for any nasal patency. So the nose can be evaluated for any deviations, valvular collapses, and possible obstruction. And also we can check on the oropharyngeal appearance. So this is the Brodsky classification, which tells us about the tonsil size. A grading scale for measuring how large the tonsils and how much space they occupy in the throat. So it ranges from 0, where the tonsils are actually removed, and then to grade 4, where the tonsils nearly are touching each other. And then this is the Mallampati score. It is a system used to evaluate how easy or difficult it may be to see the airway when the patient opens their mouth. It ranks visibility of the soft palate and the uvula from class 1, which is the most visible, and then class 4, which is the least visible. And then, of course, we have x-rays in our clinic. So this is cephalometrics. This is one of the most common screenings that we have in our offices. It is not the best, actually, at looking at the airway patency because it is taking when the patient is standing up. It is not taking in a supine position or when the patient is actually actively sleeping. Here, in this case, you can see the adenoid size, how large it looks, and you can see also the tonsillar tissues. And in between, you can see the airway at its thinnest part. Also, you can see how the mandible is very steep. So this kid is very crowded with her oral structures, and I do suspect that she has OSA. And then we have CBCTs. It is even better if you have access to those in your clinic, but this is basically a 3D volumetric airway that you will be able to define much more clearly with a CBCT than a cephalometric. But do we actually need to take an X-ray for each patient that comes to our clinic? Of course, no. X-ray should be justified. And for us to diagnose OSA or sleep apnea, it doesn't come from X-rays. We can only diagnose it from a sleep study, which is called polysomnography. I will let Dr. Mariam continue the presentation.
Hello? Yes, it's working. Okay, thank you so much. Hello, everyone. Thank you so much. I hope no one is asleep right now. Okay, so we will continue. Thank you so much, Dr. Noor, and we will proceed. So let's start with dentists do not diagnose. That's the first statement. The second statement, our job is to screen, as Dr. Noor mentioned, and then we have to refer them for a sleep physician for a proper diagnosis. How do we get the diagnosis? Via sleep study. A sleep study could be done at the patient house, we call it in-home sleep study, or at the lab by using polysomnography. And according to the sleep study, the physician will provide us with a report that tells us exactly how many patients the patient posed breathing while they are sleeping at night. And we categorize them into mild, moderate, and severe, depends on how many times they have stopped breathing. And then it should be a collaborative approach interdisciplinary approach between the physician and the dentist in charge in order to determine what is the best treatment approach if the patient has sleep apnea. So this is like a picture for polysomnography for adults. For kids, the gold standard for diagnosis is to do in-lab sleep test. Versus adult, it depends on the severity and the signs and symptoms of the patient. The physician will determine, can they do it at home by using a watch that detects how many times the breathing stops at night, or it should be in-lab sleep test. And it does record multiple things such as brain activity, the heart rate, the movement of the leg in order to determine does he have other things besides sleep apnea, such as restless leg syndrome. Apology for my voice. I am so sick, but I'm trying to talk in a very clear voice. So OSA has multiple factors. There is no single cause that lead to obstructive sleep apnea. There are anatomical factors such as micrognathia or adenotonsillar hypertrophy. Other causes could be poor muscle responsiveness. Other patients have low arousal threshold. So again, because there is no single cause that lead to OSA, this graph can we have to do extra report beside the sleep test in order to determine what was the phenotype and the endotype of the patient for the underlying mechanism. And based on that, what was the mechanism causing the obstructive sleep apnea, we have to determine what is the goal. And of course, we don't have one single thing that fits all. So if it was poor muscle responsiveness, we will target in increasing the muscle strength by doing myofunctional therapy or using hypoglossal nerve stimulation. Versus if the cause of the obstruction was mainly anatomical, we will use treatment modalities that improve the anatomy, such as mandibular advancement devices, surgical approaches, weight loss, because with obesity, most of the fat, especially in obese men above the age of 50, most of the fat will be deposited around their pharynx, and that will lead to collapse while they are breathing. Or if the cause was due to low arousal threshold, the physician can give medication for the patient in order to raise that threshold. What about kids? What are the treatment options that are there for patients with pediatric sleep apnea? So first of all, the gold standard is to refer to ENT physician in order to adenotonsillectomy, because as Dr. Noor mentioned, most of the cases are due to enlarged adenoid or tonsils. There are other nasal surgeries that can be used also in order to enhance the patient breathing. But what are other options for patients who do not respond for adenotonsillar hypertrophy or they do not have an enlarged tonsils? There is a CPAP, which is a continuous positive pressure that opens the airway regardless the cause of the obstruction. Also, we can refer them to a pediatrician. If the patient has allergies or rhinitis, we would like to address that. A very important thing is we need the patient to breathe from their nose before jumping into other things. So establishing nasal breathing is very important, especially for kids. Oral surgeon can be involved, especially in patients with a craniofacial anomaly, such as patients with Pierre-Robin sequence, for example, that they have very short mandible and lead to severe obstruction early at life. That can lead to high morbidity and mortality. So doing distraction osteogenesis, for example, can help them breathing, especially at early ages of their life. And what can the dentist do for kids? We can do growth modification that we'll highlight on that later on. And we can refer them for myofunctional therapists as well with any of the treatment mentioned in order to enhance the strength of the tongue, given that they have the appropriate space in their oral cavity. So again, if I want you to remember one thing, if you see enlarged tonsils, please refer them for ENT for adenotonsillectomy. It does have a good success rate in decreasing the OSA and pediatric OSA signs and symptoms. And this is a very famous study. It's called the CHAT study, that they compared a patient with OSA, mild OSA, and a different severity, those who went watchful waiting and they didn't do anything for 6 months versus those who had adenotonsillectomy early. And they noticed that in the surgery group, It did improve their behavior, the quality of life, and there was normalization for the sleep study reports. And actually, almost 80% in the surgical group versus 4% in the watchful waiting group, all the signs and symptoms have been normalized in the PSG. And they didn't only focus on looking at the sleep reports. They also looked at the the cognitive, behavioral, and the quality of life, all the sleep factors in the adenoid tonsillectomy group versus the OSA, those who underwent the surgery reported higher success. So what can we do as a dentist or orthodontist for patients with OSA? So we did say that the first line of a treatment is adenoid tonsillectomy. So what are the dental factors? We'll talk about all of these in the following slide, whether it's a growth modification, RMEs, or orthognathic surgeries. So this is a chronological timeline for what are the different timelines that we can actually do something about, at what is the best treatment modality that is the best for each age group. So we will start from the age of preschool. Okay, so we'll start from the primary dentition at a preschool stage, where we would like to establish nasal breathing. And why is that? Because nasal breathing promotes proper development of the maxilla to be downward and forward. And in this study, they have reported patients with mouth breathing. If we did not establish it early on in life, the patient will have increased lower anterior facial height, decrease in nose prominence, decrease in nose width, and then it can lead to increased mandibular plane angle and retrognathia of the mandible. So we could have avoided all that if we just focus on one thing, that the kids should breathe through from their nose while they are throughout their life. And one other study, we call it, if kids have mouth breathing, there will be something called nasal disuse, meaning there will be residual sleep disorder breathing was higher in a chronic mouth breathing group compared to non-mouth breathing group 6 months after adenoid tonsillectomy. So as we said, adenoid tonsillectomy is very successful. However, with those with mouth breather, there was residual OSA. So you would like to establish the habit early on in life. And something else we can do at this age group is to look at any abnormal habit of the kid having a digit thumb sucking habit or digit sucking, whatever. If there are abnormal habits, we need to break that habit by using different modalities like orthodontic appliances in order to stop development of the increase over jet or open bite that can be targeted earlier in life. Because if we didn't, as Dr. Noor mentioned, mouth breathing can lead to the development of long face syndrome. And this happens with the chronic nasal obstruction. And as you can appreciate here, the patient have very dolichofacial, long face appearance with lip incompetence and increased maxillary incisor display at rest with the black holes. So now we'll move on to the later age group, which is the school age group that ranges from early mixed dentition to later mixed dentition and then permanent with adolescents. And we'll be talking about mainly the expansion and the correction of the AP. So we'll start with addressing the transverse. What is a palatal expansion? Using a palatal expander, we can disarticulate maxillary and palatal bones to move them laterally, with the most inferior and the anterior parts moving the furthest. Meaning, when we do the expansion, it's not only at the level of the teeth. The bone separates as well at different sutures, from different circummaxillary sutures. And most of the separation will happen anteriorly. That's why we see diastema when the patient is smiling. And they happen at the level of the teeth versus at the level of the nose and like the forehead. And the lateral walls of the nasal airway passages also will be carried outwards. So, and the transalar width, the nose will be slightly wider. And with the RME, there were different hypotheses how it's working with the OSA. And different articles suggested that it leads to increase in nasal airway dimension, thus enhance breathing, or by leading to better nasal septum deviation correction. It will also lead to increased laminar flow versus turbinate flow, and intranasal soft tissue actually shrink by decreasing the amount of inflammation. And this is a very famous study that it was the first study that they did actually a sleep test on patients with OSA that have a narrow palate, and they underwent RME as a treatment modality. And the AHI was reduced from 12, which is severe, considered to be in kids, to less than 1, which is normal. And the normal nasal resistance, 4 months follow-up, was decreased significantly in this age group. And in this report, they actually confirmed via it was a systematic review and meta-analysis. They reported that the existing evidence does support that by increasing the nasal cavity, there will be increase in the volume of the nasal cavity and thus decreasing the nasal resistance. And this is a recent study that hasn't been published yet. It used computational fluid dynamic, meaning they do take a CT scan for the patient, and then from that they measure the patient nasal pressure and velocity by creating models and looking how the fluid passes through that. And it doesn't matter if we do adenotonsillectomy versus RME first or RME first versus adenotonsillectomy. However, most of the guidelines support that adenotonsillectomy should be the first line of a treatment, and RME should be followed as long as the patient has a transverse discrepancy that needs an RME to correct. So different expanders have completely a comparable effect by widening the nasopharynx and the oropharynx, and they do not have significant effect on the laryngeo or the hypopharynx. So it doesn't matter what kind of expansion you are using for a patient with this age group. And the same study have reported using different type of palatal expander, the nasopharynx volume have been increased in different dimensions. And this study, they report they used the quality of life questionnaire in order to see in those patients who were snoring and they have transverse discrepancy, they did an RME. Actually, it did improve 14% after an RME for those who were snoring. What about an adolescence group? So the older we get, the harder it is to separate the palatal bones. So for patients with adolescence, like the age of 14 and above, 14 to 18, we would like to use mini screw-assisted rapid palatal expander in order to help us to get better separation of bones and then avoid dental tipping, especially at the back teeth. Now, what about AP? If we want to correct someone that have maxillary deficiency, we would use face mask therapy in order to move the maxilla forward and downward, and it has an indirect effect in rotating the mandible clockwise, thus helping in patients with a class 3 appearance. And the literature is kind of not conclusive about the effect of face mask on the airway. A lot of the studies are supporting that using the face mask will lead to widening of the nasopharynx and the oropharynx, on the nasopharynx. However, there was no significant effect on the oropharynx and as well the laryngopharynx. However, none of these studies uses a proper sleep test. Most of them have been reported using only airway volume and minimal cross-sectional area, which gives us an idea, but it doesn't tell us actually, was it working? Did it actually succeed in reducing the OSA or not? And again, if the patient is an adolescent or they are almost done growing, because face mask therapy works the best for those in early at the age of 7 and 8 years old. So if someone is presenting at the age of 14, 15 years of age, would you like to use plates or TADs in order to support the movement of the maxilla forward? And in this study, they did report they did actually have a sleep test as well as a questionnaire, and confirming that in young adolescent patient using BAMP, which is the bone-anchored maxillary protraction, did help in resolving sleep issues. Now, how about the mandible? For the mandible, we do have two main goals in unlocking deep bite and use functional appliances that can help us to let the mandible grow forward in a better position. And as we get older, again, it becomes harder. So the only thing we can use is TADs in order to help vertical control for their face. There are so many designs for functional appliances. All of them lead to the same mechanics by pushing the mandible forward and thus helping us in opening the airway. However, again, the literature is controversial. Most of the effects are short-term, but most of the studies have reported increase in oropharyngeal volume. Now, apology for the font being up and down. It wasn't like that. So for adenotonsillectomy, we did cover that at different age group, we would like to correct different issues depending on what does the patient present with. For the adenotonsillectomy, we can do that for all age groups. And we should pay attention, a lot of patients with Down syndrome or those in the age group of 16 to 18, the lingual tonsils can be enlarged, not only the adenoid and the tonsils, and thus we can add that into our calculation. Myofunctional therapy to help establish a proper nasal breathing and then train the tongue to sit at the palate instead of the teeth. It's important. So whenever you use any treatment modality, it does actually help in reducing OSA. What about non-growing? So we have been talking about those till the age of 18. So what about adult patients? There are many treatment modalities for adult patients, such as positive air pressure, surgical options that targeted soft tissue and hard tissue surgery. There is hypoglossal nerve stimulation and oral appliances that we will talk about. So as we mentioned that for kids, the gold standard is adenotonsillectomy. For adult, the gold standard treatment is CPAP, which is continuous positive airway pressure. Because regardless the cause of the obstruction, it will pump positive airway that will lead to the opening of the pharynx. So it is the recommended first-line treatment. It's almost always effective if the patient uses it. And we can see whether it's effective or not, depending on, we can do a sleep study, another sleep study with the CPAP to see if it's actually working or not. But it doesn't come, it comes with so many side effects, and like dry mouth, discomfort, aerophagia, a lot of patients to swallow a lot of airs while they are using CPAP. A lot of them develop claustrophobia. Majority complains about nasal congestion and the dry nose. So, and actually, almost 50% of the patients discontinue using CPAP after a year of using it. And 8 to 15% reject the treatment from the beginning. So as dentists, what can we do? This is just a diagram to highlight. So the patient comes with OSA. They have a diagnosis with obstructive sleep apnea. And it's a growing patient. We should consider any of the previous modalities we have talked about for growth modification. If the patient is non-growing, we do have multiple options, and we will highlight. We have MARPI, oral appliance therapy, and orthognathic surgery. We did talk about mini-screw-assisted palatal expander, that we use mini-screws in the palate in order to get the anchorage and the support in order to separate the palatal shelves of the palatal bone and get the separation. The SARPI, it's surgically assisted rapid palatal expander, and it's a treatment modality in adults that the surgeon will actually, through a Le Fort 1 cut, will separate the bones and put them into a wider position. So they will do the separation, and then with using regular RME, we will activate it and get the proper separation. And this is meta-analysis, actually, this is an RCT that was done in young adults in order to see the efficacy of MARPI, which is the mini-screw-assisted rapid palatal expander. And the success rate for correction of a transverse was almost 85%. And there was statistically significant improvement in sleep reports such as apnea-hypopnea index. The correction was almost 60%. The mean oxygen saturation, snoring duration, all of them have improved. However, one-third of the patient, one-third of the patient finished the study with an AHI less than 5, which means normal. However, the conclusion was we can use it as a treatment modality in young adults with maxillary transverse deficiency. So, do we widen every single arch? No. If there is a reason for it, yes, we should go for it, but do not widen someone who does not have an actual crossbite or a skeletal transverse discrepancy. Now, we talked about the transverse. What about the AP? If the patient comes with a severe class 2, convex profile, maxillomandibular advancement with counterclockwise rotation have been reported to help patients with severe sleep apnea. So if a patient at the age of 30 presented to you, do I want to consider CPAP for the rest of his life or oral appliance for the rest of his life? No, I will offer a surgical option if the OSA was severe. So who are the best candidates for a patient with MMAs? Those with severe sleep apnea, as we mentioned, and those who are PAP intolerant. They have typical narrowing for the oral or the hypopharynx. Those with retrognathia, as we mentioned, and we can collaborate with the ENT in order to determine if the patient will be a good respondent for the sleep for the DISE or not. For the sleep surgery or not. By using DISE, DISE is drug-induced endoscopy. They will determine the type of collapse that the patient is having while they are in semi-sedated state in order to see if the patient is a good candidate or not. Those with concentric collapse for the pharynx, they are not a good candidate. Those with lateral collapse, they could be a good candidate for oral appliance therapy and surgical option as well. And in this study, it was done, most of the reports for the MMAs, they report that the success rate is almost 60 to 70% for those with severe sleep apnea. If we look at the AHI less than 5, of course, the effectiveness reduced to 50%. However, if it was more than 50% reduction in the actual AHI, initial AHI, the success rate goes higher to 80%. Now, someone doesn't want to do surgery. They are older, they don't want to do that, so we'll consider an oral appliance therapy, which works similar mechanism to what we have discussed earlier by pushing the mandible forward and stabilizing the jaw into a forward position, and that will stretch the muscles of the pharynx because there is a connection between the base of the tongue and the muscles around the pharynx. That's one theory. The other one is by moving the jaw forward, the tongue will we will prevent the tongue from going backward as we are relaxed while we are asleep, and thus preventing a tongue collapse. There are more than 150 designs for oral appliance therapy, and all of them have the same mechanism by pushing the jaw forward. You would like to use the one that is aesthetic, develop function, depends on how the patient will present to you. Do they have a proper dentition or not? Do they have undercut or not? And are they looking for something aesthetic actually or not? And this study, it was very famous comparing oral appliance therapy versus CPAP. We said CPAP is almost 100% effective if the patient uses it. But the problem, a lot of the patients, they don't use it. The maximum hours that the patients are using it is 4 hours, and you need definitely more than that in order to get the benefit out of the CPAP. So they compared the CPAP versus the oral appliance therapy, effectiveness versus compliance. And the compliance of the mandibular advancement devices were more than those with CPAP. Thus, the mean disease elevation was the same into both age group. And actually, both have comparable effect in healthcare outcomes. They measured that both of them will reduce the blood pressure similarly. However, not in every single thing, not like in someone with comorbidities like a stroke, a history of a stroke, or diabetes. You would always aim for CPAP for the better effectiveness and the overall effect on health. However, if the patient is resistant to that, you should consider oral appliance therapy, even in severe OSA cases. And in this study, OSA actually, if we want to say a percentage, OSA does work in majority of the patient, mainly mild to moderate. It's considered, according to the American Association of Sleep Medicine, that it's the first-line treatment. And however, in 1/3 of the patient, we go with the role of 1/3. 1/3 of the patient, they will not respond. So I cannot promise the patient that it will 100% be effective for all of the patient. Depend on the severity and how does the patient respond. So who are the good candidates for oral appliance therapy? We would like to have sufficient number of teeth, at least 6 number of teeth in each jaw. The periodontal health should be in a good, good periodontal health. You don't want to place an oral appliance on someone with the grade 3 mobility. That's no, don't do that. And those with mandibular retrusion usually have a better range of motion, better movement in a protrusion that we can play with, and that's how the mandibular advancement device works versus patient with a class 3. And this is a study we published last year. Actually, we wanted to highlight the interdisciplinary approach and collaboration between physician and dentist that we, in pediatric patient, if they come to us, depending on the severity, if it's mild, moderate, or severe, or if the patient is healthy or have residual OSA after adenotonsillectomy, or they have like complex conditions. Based on that, we would like to tailor the approach for each patient, whether it was a growth modification, watchful waiting, or adenotonsillectomy. And this is a study that I felt it was like, it gave us like a nice map to guide us. Patient present with different classification. If someone is with severe sleep apnea, you should think about CPAP or surgeries. Versus those with moderate, think about oral appliance therapy, or surgical option is valid for all the cases. But if a patient have mild OSA, would I like to do a surgery on that patient? Maybe not. Maybe soft tissue surgery, but not an actual MMA. For those with mild obstructive sleep apnea, positional therapy, meaning if the patient, most of the sleep apnea happens when the patient is sleeping on their back. And if they turn to the right side or the left side by using a special pillow that prevent them from sleeping on their back, it actually does help in patients with mild sleep apnea. And in recent RCT, it does actually said that it was comparable effect to oral appliance therapy. So I think start with the least invasive method before jumping into doing aggressive treatment. And our study, we currently now summarizing that, currently we are at the level of multidisciplinary care where the patient goes from one clinic to the other clinic, and then hoping that the physician will interact with the dentist in order to communicate about their case. But we are aiming for more interdisciplinary approach. That's why now a lot of the dental schools are screening for OSA, and some of the medical centers, I did my training in a medical center, not actually in a sleep, like dental center. So having the patient as the focus of the care, and the physicians and the healthcare providers communicating between them to what does the patient want and what is the best for that patient. This is called an interdisciplinary care model versus multi. And now I would like to show you just one case. This patient was 39 years of old, female. She does have diabetes type 2. She was CPAP intolerant. Her AHI was 42, which means severe sleep apnea. And most of the obstructions were happening while the patient were in supine position. And the desaturation index for the oxygen was really high. And this is the intraoral pictures. If you can see, there is multiple gum recessions. The patient had underwent ortho treatment before, so that's why she's missing upper first premolars. We can see she has transverse discrepancy. I did offer MARP for as a treatment modality. However, the patient refused going to another round of orthodontic treatment. So the other treatment modality is to use an oral appliance therapy. And with the oral appliance therapy, I lowered the patient expectations because the patient was obese, and she does have high AHI, which was 42. So I referred her for the nutritionist in order to help her to have a better lifestyle, and hoping that the weight loss will reduce the severity of the OSA. With the oral appliance therapy, because it does have side effect, we would prescribe a morning aligner. We call it, the patient use the morning aligner for 5 to 10 minutes in the morning in order to guide the patients into biting their original bite, and monitor if the dental changes are happening with the oral appliance therapy as it's reported in the literature with the long-term use. And in order to validate our treatment, we have to do another sleep test while the patient is wearing the oral appliance. And I was really surprised that the patient has, their original HI was from 42, it dropped to 4, and less than 5 in adults is considered to be normal. And the patient was feeling more fresh, she doesn't snore anymore, and also she is reducing her weight. So it's multiple factors leading to this improvement. And she stopped using CPAP, of course, because she wasn't tolerant from the beginning. And this is a code that is Dr. Muna Al-Awadi and I are running the dental sleep clinic at the Kuwaiti Board of Orthodontics at the Farmaniya Dental Hospital. If you ever have in doubt if the patient if you ask the patient about snoring or sleep problems and you suspected they may need a sleep test, you could refer directly to the sleep physician. However, for pediatric patient, please refer them to us first, at least that we can titrate, because we only have one pediatric respirologist in Kuwait, and the waiting time for the sleep test is too long. So you can refer the patient if they need oral appliance therapy or expansions or MMAs, or just for consultation if you are ever in doubt. And we hope that we get back to you and tells you what's the treatment needed. So the take-home message is dentists should be familiar with obstructive sleep apnea signs and symptoms. Please screen all patients and refer suspected cases to sleep physicians. Orthodontist or dentist, qualified dentist, may assist in managing the OSA by doing growth modification or oral appliance therapy. And we have to remember it's always interdisciplinary care that provides the best outcome. And this is our contact information for Dr. Noor and I in case you need to ask us any question. And thank you so much. Do you have any question?
يعطيك العافية. Thank you for the interesting, very informative lecture. Based on the screening, how accurate I would say the method you gave us? Because what I face in the clinic, whenever we do sedation, we got a lot of patients that we don't know they have sleep apnea, and we literally just ask them, do you snore at night? Do you don't sleep well? Are you tired in the morning? Is there a more accurate way to predict that the patient will have sleep apnea? Because, based on that, it differs on the, I would say, the method of sedation we provide. Thank you.
Thank you so much for your question. So for the screening, there is no single questionnaire. That's why we are using multiple questionnaires. The Epworth Sleepiness Scale, as Dr. Noor mentioned, it only tells you how sleepy is the person. So it doesn't tell you if the patient has sleep apnea or not. However, the Stop Bank questionnaire has a better validity and sensitivity. What was the sensitivity of? It was, I think, around 80%. And it's dentist friendly, so you can actually use it in the everyday dental office.
It also checks on the factors. When you ask the Stop Bank questionnaire, they also calculate the factors that the patient has for OSA, so it is validated to screen for OSA.
And for pediatrics, the PSQ, the Pediatric Sleep Questionnaire, is the gold, not the gold standard. It helps the most because it's an easy questionnaire, and the sensitivity and the specificity is very high for both of them. However, to diagnose, it has to be a sleep study, so it should be a referral. However, because of the long waiting time for the pediatric sleep lab, because we only have one in Kuwait, Dr. Saadoun runs pulse night oximetry, oxygen oximetry. I forgot the name, sorry. So they do titration, depends on how much the oxygen drops at night. And it doesn't give you all the information. But those with craniofacial anomalies or comorbid obesity, for example, they need in-lab sleep test urgently. But those who are healthy, we can use the type 4 sleep test. Thank you.
Thank you, Doctor, for your presentation. I have a question. So obstructive sleep apnea, usually the patient has some psychological or maybe in depression. So how can you keep the patient motivated toward using MMA appliance?
So thank you so much. It's just, as we can say, if the patient is not sleeping well, as Dr. Noor mentioned earlier, they will have so many cognitive psychological issues, a lot of them. And actually the sleep center I worked with, it's under psychiatry department. So it's psychiatry with the sleep medicine. It runs together because you will ask for psychological help or psychiatrist in order to keep the patient motivated. If someone has an actual medical condition, such as depression or an anxiety, you would like to handle that. And then hoping the motivation is better. So always refer for when you suspect any psychological issues. However, because they need it so badly, if they are aware, it all go back to patient education. If you spend a lot of time with them, explaining for them that because if you are not sleeping well, this will happen, that will happen, and highlight the importance of it, they will feel the difference. It's not a placebo effect, but it does help a lot. So I guess spend more time on educating the patients and why they should use it. And because usually they are so desperate to use it, to not snore, especially if they have bad partners, they will use it. So again, working on patient education and referral for other specialists. Welcome. Okay. I guess we're done.
Any other questions?
Hello, everyone. My name is Dr. Ziad Al-Zaid. I'll be the chairperson for the next lecture. It's my great pleasure to introduce our next speaker, Dr. Hamid Bourashid, who will be sharing his insights on integrating Invisalign Smile Architect interdisciplinary orthodontic restorative treatment planning. Dr. Hamid Bourashid is a senior specialist in orthodontics and dentofacial orthopedics and an assistant clinical professor at orthodontics at Kuwait University. He is specialized in both orthodontics and prosthodontics, holding a DMD degree from Boston University, a Master of Medical Sciences and Prosthodontics specialty from Harvard University. He is currently a faculty member in Kuwait University and the City University of New York. Dr. Bourashid is a board certified and a diplomat of the American Board of Orthodontics. Please join me in welcoming Dr. Hamid Bourashid.
All right, thank you so much, Doctor, for the introduction. Good afternoon, everybody. So we do have a little bit of a technical difficulty. I have a lot of nice videos as part of my presentation. Unfortunately, I don't think they'll be working, but I think I'm going to try to manually do them. So just, bear with me during this presentation. So today I'll be talking about a very rare feature that a lot of you may not know about that's available with Invisalign. It's called the Smile Architect feature. And this feature is a very great feature that helps you trim and plan any cases that involve restorative treatment plans. So it's a good multidisciplinary tool to use for your interdisciplinary cases. So before I begin, I do want to acknowledge and thank the Kuwaiti Orthodontic Society. Dr. Hamid Al-Suwaidan and everyone who works at the Kuwaiti Orthodontic Society have been instrumental and great in elevating our specialty, and I want to thank them for actually nominating me today to give this presentation. And of course, I want to, thank the Kuwait Dental Association for organizing this amazing conference and getting us all together here today. All right, so we'll begin the presentation. Today I'll be speaking about integrating the Smile Architect feature of Invisalign and treating, planning our ortho restorative cases. So before I begin this lecture, I want to kind of let you guys know a little bit about my background, and it'll kind of tell you why I chose this specific topic and why this topic is something I'm very passionate about. So I'm a graduate of Boston University. I got my undergraduate and DMD degree over there. Afterwards, before I became an orthodontist, I was actually a prosthodontist. So I specialized, got my degree as a prosthodontic specialist at Harvard University. And did a Master's of Medical Science over there. So during my time at Harvard, I worked as a research fellow at the Cleft and Craniofacial Center at Boston Children's Hospital. And during that time, it's where I discovered my passion for orthodontics. So after graduating at Harvard, I moved to New York City and began an orthodontic residency at a hospital known as St. Barnabas Hospital, which is affiliated with the City University of New York. And then I worked in the United States for a couple of years as an orthodontist mainly before coming back to Kuwait and joining as faculty at Kuwait University at the Department of Developmental and Preventive Sciences. So because of my background as both a prosthodontist and an orthodontist, I have a great passion and a high interest in treatment planning multidisciplinary cases, especially those that involve final restorations in the aesthetic zone or complex full mouth reconstructions with the aid of orthodontic treatment. So during my specialty training and during my prosthodontics residency, there was one statement I remember from one professor that really stuck with me to this day. This is a concept that really, to this day, sticks with me. The fact that every comprehensive dental treatment plan should begin with the end in mind. So for any plan that involves more than one specialty, or even if it's in prosthodontics only or orthodontics only, if we don't have the end product in mind, if we don't plan for the end right from the beginning, then we kind of go in there almost blind. So this is one thing that really I try to implement on all my treatment plans. And the Invisalign Smile Architect feature is an amazing tool that I have to really follow this principle and kind of treatment plan with the end product in mind before I begin any complex multidisciplinary case. So again, it is this principle that in Smile Architect that makes it a great tool for my Invisalign cases. With Smile Architect, we can create a digital smile design on our actual ClinCheck, on our orthodontic ClinCheck. We can create a smile design of our final restorations and plan out not only the orthodontic movements, but the final restorative result for the patient right on one digital platform. So let's start by defining what Smile Architect is. So Smile Architect is a treatment planning and smile design software that's integrated into Invisalign's ClinCheck. So it allows to treatment plan both orthodontic and restorative treatment plans all in one single platform. So you can visualize the final restoration and do your actual digital smile design directly on your ClinCheck with treatment planning or orthodontic movements all together at the same time. So it's a great visualization tool, not only for the specialist, but also for the patients. So currently it's available in 3 of the packages, the Invisalign Lite package, Moderate, and Comprehensive. Unfortunately, it's not available in the Express packages, but if it's a complex multidisciplinary case, really you shouldn't be doing an Express case. So let's start about how we can submit for a Smile Architect. A lot of you may not know about it and may not even see it when you submit a ClinCheck with Invisalign. So of course, first of all, you have to choose the Smile Architect feature. So I'm going to show you how you can do that. The second requirement is that you have to take a photo known as the wide smile photo, and that photo needs to be taken with the Invisalign Practice app on your phone. It cannot be done with your regular camera. So you have to download the Invisalign app on your phone and take what's called the wide smile photo to integrate into that case. And then finally, on your prescription or your FlexRx prescription, you have to make sure that the ortho plus restorative option is enabled so that you can get the full effects and the full features available with Smile Architect. So I'm going to go over like a quick workflow on where to go to find it. So you want to, of course, choose adult. It's going to be an adult case if it's a multidisciplinary restorative case. And then over here, instead of Invisalign clear aligners, you want to choose Invisalign Smile Architect on the far right. So some of the GPs and the prosthodontists should have this available to them right away. I have both a US and a Kuwaiti Invisalign account. In the US account, every type of dentist, specialist, GP will have this available for them. In Kuwait, I discovered that for some people or some orthodontists, this may not be available, and some it may be available. So if it's not available for you, just ask your clinical specialist or your rep in Kuwait. I believe it's Nasser. Just ask him to enable that for you if you're an orthodontist and you have an orthodontic Invisalign account. So once you get to Invisalign Smile Architect, you can choose among these 3 packages, Comprehensive, Moderate, or Light. And then once you upload your records, this is where you upload your photos. You want to make sure that you upload something called the wide smile photo, which is in the middle of this composite over here. This photo is not something you can just drag on the computer. You have to download the Invisalign Practice app. So here's a QR code for it, but you can even just go on your phone, go to the App Store, download it. It's the Invisalign Practice app. And I'm going to show you some screenshots of where to go. So once you log into your account on Invisalign on the actual app, if you haven't already added the patient, you can click on Add Patient on the bottom. Then choose Invisalign. Enter all the relative information, all the patient information as necessary. And then you go to Add Records. And then this pops up just like your regular ClinCheck on the website. But you want to choose this middle one, the wide smile photo, and that should open up your camera, and you can take a photo of the patient's face. So this has to be on the phone. Invisalign won't let you do it on a computer, and you can't just upload it on the website. One workaround that I found, some people might say, you know, the patient already left, I forgot to take a photo of the patient in the chair. I would take an exaggerated wide smile photo of the patient with my regular camera, blow it up on a computer, open the app, take a photo of the photo. It works just as well. So that's a workaround if you forget to do it when the patient's in the chair. So that's the second requirement. The third requirement is to have the ortho and restorative feature available for you. So when you submit your prescription, you need to make sure that you have ortho only and ortho restorative available. If it's not, you need to go to the chat feature, speak to the agent, and have them add that for you, or speak to your local agent here in Kuwait. So what you're going to get is you're going to get 2 ClinChecks. You're going to get an ortho ClinCheck, and then you're going to get an ortho restorative ClinCheck. And you want to make sure that ortho restorative function is available for you. Under the prescription, you can choose however many restorations. So this is in collaboration with your dentist, your GP, your restorative dentist. You can choose however many restorations you think is going to be needed as the final restorative product. You want to make sure you choose that in your prescription. If you don't know, just choose however many you think you may need, and then you can modify that, add and remove as needed during your treatment planning process. So these are the 3 requirements. There's also some optional features available for you. You can take a CBCT. So you can upload a CBCT of the patient. And the beautiful thing is you can superimpose that CBCT on top of your ClinCheck, on top of your smile design. So you have the restorative smile design, the patient's orthodontic tooth movement and ClinCheck, and the CBCT all superimposed under one platform. And you can get your periodontist involved, your surgeon involved. If there's implants that need to be placed, crown lengthening that needs to be done, you can treatment plan your final restorative margin right there on the ClinCheck. And then if you have the bone superimposed with it, you can see if you need to do any crown lengthening procedures all in one platform. So really, this is a nice platform where you can get everyone involved. The orthodontist, the prosthodontist, the GP, the periodontist, all in one platform instead of using multiple softwares. And then the other option you can have is uploading a video of the patient, and you can even see that their smile design is directly on the patient's face as a video if needed. It's a good selling tool for the patient as well. All right, so this is the video that is not going to work, but I'm going to see if I can manually kind of drag it. Let's see. So this is, there we go. So this is just like a quick recap. So I choose adult, go to Invisalign Smile Architect, choose that, choose whichever package I want. Usually I do comprehensive for these cases. And then I'm going to go to the next slide now. Bear with me, it's a little slow. All right. And then over here, this is your actual ClinCheck. So up here, if you see my cursor, you want to make sure ortho restorative is chosen. And then let me see if I can get this video to play. You can fill out your prescription as usual. Where do you want your laterals to be in relation to your central incisors? How many arches are you treating? Upper, lower, both of them, one of them only. And then here is where you want to add the number of restorations you're going to do. Are you just doing the maxillary anteriors? Are you just doing the incisors? Are you doing a full mouth reconstruction? Choose however many teeth that you're going to restore post-orthodontically. And then, of course, all the other stuff that all of you orthodontists and GPs who use Invisalign already know. Which teeth you don't want to move, any areas you don't want to add attachments, any areas you're going to extract, etc. Now I'm going to go to the next slide. Believe me, this was a lot faster when I did it at home. All right, let's see. All right, so once you upload your iTero or 3Shape scan, you can even upload your CBCT over here. You can upload a DICOM file and superimpose that to your ClinCheck. And then once you get to the photo page, you want to make sure that wide smile photo has been uploaded. So make sure if it's not already uploaded here, go to the phone, and then if the patient's not in front of you, take a photo of the photo, and then it should then appear right there. All right, so advantages of Smile Architect. The main advantages is that you get the orthodontist, prosthodontist, periodontist all together on one platform, on one digital platform to treatment plan altogether. You can plan your orthodontic movements based on your final restorative result. So you can move your teeth so that you make sure that at the end you don't need to prep aggressively, so that you can help out your prosthodontist and GP. And there's features that will allow you to do that on the program. So this is kind of, these days when we place implants, we go with something called prosthetically driven implant placement. This allows you to do prosthetically driven orthodontic movement. So you move your teeth towards where your final restorative result is going to be. You work towards the end product. The end product is going to be restorative, so you move your teeth based on your final smile design. And then you can even, like, if for very complex cases, you're not sure how many restorations you're going to need, it's a good planning tool for you. And then maybe most importantly for those in private practice, this is a good visualization tool for your patients. I tell you, like all the cases that I've done with Smile Architect, a high percentage of them accept when they see, the patient can see on their face the final restoration before you even begin. Not the final orthodontic movement, the final actual restoration after your orthodontic treatment and your restorations are done. So it's a good selling tool for your patient. All right, so I'm gonna get into the actual, like, presentation. So today we're going to go through and give you an outline of all the features available through Smile Architect. I'm going to go through the digital smile design workflow that I like to use and how I can get all specialists involved in the treatment planning process. And then hopefully we have time to end off with 2 case examples, maybe only one today since we had a little bit of trouble with the IT. But the main thing I want to emphasize here is I'm not going to show you before after. I'm showing you the treatment planning process. We don't have time to go through all that today. So I'm showing you the actual treatment planning process for these multidisciplinary cases. All right, so let's start with the Invisalign Smile Architect features available. So you get a ClinCheck back initially. You get something that you're all familiar with, very similar to what you usually see. You want to make sure you choose the Smile tab on your ClinCheck, and that will pull up the wide smile photo that you took on your phone. And that should show up on the left side of the screen over there. And this photo is what you're going to use to actually create a digital smile design on the patient's face. There's something called the integrated smile view. So this is the tab on the far left over there. And under the integrated smile view, you have 2 options. You have something called the natural view, which is a view of the patient's natural teeth. And you can see the before and after of that view. And then you have the superimposed view, which is the actual ClinCheck, the actual cast ClinCheck over here you have on the right, superimposed directly on the patient's face at any stage of the process. All right. This is a video, I believe. No, it's not. Actually, it is. Let me see if I can get it to open up. All right. All right, so here I choose the natural view. I can choose a superimposed view. Under the natural view, we can see a before and after of the orthodontic final product. So before after on the patient's face of the orthodontic product. Under the superimposed view, you can see the actual ClinCheck, and you can modify the opacity of the patient's face if needed, based on your preference. And you can see the actual ClinCheck on the patient's face at any stage, and even the before and after, of course. All right. All right, so this is probably the most important feature that's available for us. These are called the facial lines. So this is what I use to treatment plan my smile design. So what I would do is I would have the natural view, the integrated natural view, the final, it'll show you the final orthodontic product. And then all these lines are gonna show up for you. And these lines you're gonna use as your landmarks to make your digital smile design. So you have your midline, intercanine width lines, you have your smile arc, your interpupillary lines, the incisal portion as well as the gingival portion of your smile arc, and you can manipulate those as needed. You can even manipulate the proportions of the widths of your incisors and canines viewed frontally to whatever golden proportions or whatever proportion you see fit for that patient. So this is treatment planning your actual prosthetics over the patient's final orthodontic position. All right, this is a video as well. So here you can see, give me 1 second. All right, it's not allowing me to do it, but basically what this video should have shown you is how I can manipulate the incisal and gingival portions of the smile arc. I can exaggerate this. I can change the cant of it so I make sure it's parallel to the interpupillary line. I can move this intercanine width line as needed in whatever landmark I like to use, whether it's the ala of the nose or the intercanthus line, the midline, all of that. So I get all of that set up under my facial lines. All right, let me see if this video works. All right, I'm just gonna skip over that, but you guys get the picture. All right, now after you do all your facial lines, you set your landmarks that you need for your final restorations. Now you can treatment plan your actual restorations. So then you have the restoration tab that's available for you with Smile Architect on the upper right-hand side over there. And then under that, you can choose the opacity level of your restorations. So it can go from 0 to up to 100% opacity in 25% gradients. And you can superimpose your restorations and manipulate them and change the shape of them and move them as you please over your final your final orthodontic position. So here I chose the 100% opacity just to really look at the restorations. Invisalign will give you just some random, shape for all the teeth. You can manipulate this as you need afterwards. You can go to the Movements tab, click on Restorations, and then what you can do is you can use all these toggles and move the restorations in whichever direction you want, mesial, distal, vertically, angulation, tip, in all 3 dimensions. You can choose the shape of the teeth that you'd like. You can, there's a library of different shaped teeth. You can choose round teeth, triangular teeth, rectangular shaped teeth, whichever shape you'd like. And then you can also alter the gingival margins. Where do you want the gingival aspect of your restorative margin to end? And then the nice thing about this is that if you superimpose your CBCT, you can look at the marginal bone level and where your restorative margin is and see if you need to do crown lengthening. You can even add and remove restorations as needed. So if you feel like I only need to do the upper incisors, you can remove the canines, or if I feel like I want to add premolars, you can add those as needed. And then after that, once you get your, all your restorations treatment planned and designed, you then go to the Tooth Mass Analysis tab. And this shows you a heat map of, based on where your final orthodontic position is, how much reduction do you need to, how much does the prosthodontist or dentist have to reduce? How much do they have to prep in order for it to fit that smile design that you have? So the nice thing about that is now you can see, is this going to be minimally invasive? Is it going to be very invasive? And then you can then alter your tooth position to make sure that the dentist doesn't need to prep as much. So it goes from, I believe red is 2 millimeters of reduction, orange is 1.5, yellow is 1 millimeter, etc. So you can see this in all views. So you see, for example, here, we're going to do a good amount of occlusal reduction on the 1-4 based on the smile design and based on where that final orthodontic tooth position is. All right. So here is my proposed final orthodontic, restorative product. So this is the smile design. And you can see on the right side on the patient's face, you can see it directly on the patient's face. So this is a great selling tool for the patient. I believe I'm going to try my best. This is a nice video. I want to try my best to see if I can show this for you. Okay, great. So here, I alter the restoration opacity. So under the restorations, that's your orthodontic final tooth position. And then over it is my digital smile design. So you can see where your restorations are relative to your orthodontic tooth movement. And then you can see stage to stage how your teeth move underneath where your smile design is. You can look at that in multiple views. And then you can do a before after, show the patient, pre-ortho and post-restoration. Post-restoration, post-ortho, of course. All right. All right, and then the final feature is the CBCT integration. So if you choose the Roots tab, if you integrated your CBCT on top of this, you can see the marginal bone levels and the roots all superimposed on top of this smile design that you already have. So on this specific patient, I didn't have a CBCT, but this is what it would look like. So you would see your teeth position, your final orthodontic teeth position. You can visualize the roots, and you can even visualize the marginal bone levels. And you can do something like this. Like, for example, if you have your digital smile design treatment planned over that, you can kind of toggle the opacity of your smile design, your orthodontic final position, as well as look at the bone levels. And then with your periodontist, you can treatment plan how much bone reduction is needed. You can 3D print an STL file of that final smile design and create a surgical stent for your surgeon. Or the surgeon can do it. You don't have to do it yourself. All right, so I basically went over this workflow just because the videos weren't working, but I'm going to quickly summarize this. The workflow I like to do is goes hand in hand with this concept of working towards the end in mind, right from the beginning. So the workflow that I do for my digital smile design, it integrates pros, ortho, and surgical disciplines all in one platform. It gets all the specialists all together in one area. A lot of you are going to say, there's a lot of products out there, a lot of softwares that do digital smile designs. Absolutely, you're absolutely right. But Invisalign is probably the #1 provider of aligners that we have for most of our orthodontists in the room, and even GPs. It's amazing that it offers you the option to trim and plan in one platform, the prosthetics and the perio surgeries if needed, all in one platform. So you don't have to go through multiple different softwares and programs. You can get everyone all together on one platform. And this relies on the concept of prosthetically driven orthodontic tooth movement. So just like I talked about before, just like we have the concept of prosthetically driven implant placement, this is the concept of prosthetically driven orthodontic movement. So here's the sequence that I specifically like to do. So once you get your ClinCheck back, I basically treat it like any other ortho case. I forget it's a small architect case. I get my teeth to the final position that I believe is best for them. I get the overjet over by in the right position, get the midlines on, get my canine classification, molar classification, etc. Then I start designing my digital smile design. So step #1 is identifying the facial lines. So let's see if I can, this is not a video, great. So I want to get my facial lines in the right position. So what you're going to have is you're going to have the natural view, you want to choose the natural view up here. And that'll show you where your final position of your teeth are orthodontically. And then after that, let's see if I can toggle here. Yeah, there you go. So natural view, then I choose my facial lines. And then over that, I can manipulate my midlines, intercanine line, etc. All right. All right, this one's not working, but basically on this video, you would have seen me manipulating the midlines as well as the intercanine widths, getting the interpupillary lines in the right position, then manipulating my smile arc to make sure it's parallel to the pupillary lines. So this is probably the key step. This is the most important step in the process of your smile design. So after I determine my facial line, I switch to the superimposed view, not the natural view. And with that, I determine where my final incisal position for my final restorations is going to be. And then I start designing my restorations and moving my restorations within the confines of those facial lines. So here I switch to the superimposed view, so it'll show you the ClinCheck on the patient's face. And I wish I can show you the video, but basically here I would I would insert my restorations and modify them, and I would try to fit them into the confines of those lines. And then what I do is I reduce the opacity completely. So now I use my facial lines relative to the patient's face. After that, I don't need the patient's face anymore. I already know where my midline is. I know where my intercanine width line is. I know all my landmarks. So I remove the patient's face completely so I can focus. So it's not distracting for me. And I zoom all the way in under the superimposed view. And then now I have all these landmarks and lines. and then I can move my incisors or my restorations within the confines of these lines. Keep in mind that I am not looking at the gingival levels yet. I'm just getting the teeth to fit into those lines at this point. All right, so after that, I now start altering my teeth shape, and I can add teeth that I want to restore, remove teeth that I want to restore, etc., and alter the shapes as needed. Let me see. Okay, great. So here you can see, I'm manipulating my teeth. I can move them, change the shape of them, etc. So here I'm choosing more round-shaped teeth, kind of manipulating things within the confines of these lines. And then I believe over here I am adding, I decided that with this patient I may want to add a premolar as a restoration. So let me see if this pulls up for me. Yeah, perfect. So I bring the opacity level back to kind of visualize things on the patient's face. And then I realized that I may want to give her a wider smile, so I want to add some premolars to the restorations. So over here, all right, it's not going to show you, but basically I choose the I choose this icon over here. Let me see if this icon over here. Oh, there we go. All right, so I choose this icon, and then I add this as a restoration. And then here I want to add an implant, so I place the implant crown that I want to place. And then if you have CBCT, you can then even create a surgical guide for your implant placement over that. All right. So in this slide, let's see if I can. There we go. Okay, so over here, I am manipulating the implant crown. And I realize that there's a space between that implant crown after I idealize the shape of it and the teeth posterior to it. So I now get my I modify my orthodontic plan and mesialize my posterior segment. So the video stopped, but it'll show you that I mesialized my molars. All right, so after I do that, now I alter my gingival margins as desired within the facial lines. And then if you have the CBCT integrated, this is a great tool. You have the soft tissue, the patient's actual smile, and you have the final restorative margin, so you see if you need to do any gingivectomy. And then if you have the CBCT and see the marginal bone level, you can see if you need to do an X number of millimeters of crown lengthening. So over here, you can see these areas over here. I'm not going to play the video because just in the interest of time. So you can manipulate the gingival levels as needed to wherever you think the ideal crown height to width ratio is, and also relative to the patient's smile line, their gingival display, their incisal display. You can modify how long you want your restoration to be, and you can determine your final gingival margins. All right, so after that, the final step is you check your final orthodontic tooth position, and then you look at if, you can use the tooth mass analysis tab and see how much reduction or preparation needs to be done for you to achieve this. And then you can modify your tooth movements to kind of reduce the amount of preparation that your dentist or prosthodontist needs to do. So I'm going to try my best to see if I can get this one to play. Yeah, so this is the tooth mass analysis tab. You see the heat map. And then with that, you can see in any direction how much preparation you need to do in order to achieve the smile design based on that final orthodontic tooth position. So basically, while this plays, this video would have, actually, I think we're ready. So based on that, you can manipulate your tooth position. So you can look at that right there.
Excuse me, doctor, you have 5 minutes.
All right. You can manipulate your tooth position to reduce the amount of preparation you need to get done. So this is the nice thing about that. All right, so I'm going to skip over a couple of slides just in the interest of time. There it is. All right, so going back to these steps over here. So you get your prosthodontist and dentist involved right from the beginning on the first couple of steps. You can get your periodontist and surgeon involved during the CBCT integration. And then finally, of course, your orthodontist along the way throughout the process. After you do all of this, you review the case with the patient, get the patient's approval. And then on the software, you can export an STL file of your file smile design. And with this STL file, you can create a mock-up, if possible, for the patient. You can do a preparation reduction guide for your prosthodontist. You can do a provisional matrix to provisionalize the restorations, and even have a surgical guide for the periodontist or the surgeon. So here's where you go. You go to the patient's name on top of the ClinCheck, click on Export, go to Smile Design Export, and then that will give you a bunch of things. So it'll give you the initial malocclusion, and the final result, STL files for each arch, as well as photos of the before and after that you can show the patient. So with this STL file, again, you can choose to do all these different types of stents and guides. You can also do a surgical guide for your periodontist if needed. So we don't have time for the case examples, but I do want to quickly switch over to I want to kind of just show you this. So this case, this patient had congenitally missing upper laterals. She had previous orthodontic treatment where the orthodontist brought the canines into the lateral position, extracted lower premolars. Her chief complaint is she didn't like the canting. She didn't like that each tooth was a different size, but she had a lateral open by other things that we need to do orthodontically. So we did a smile design for her through Smile Architect. This is how her teeth looked like initially on the left. This is the smile design final product. We didn't even start the case yet. You can see the final product before you even begin. You can 3D print the STL file of this final smile design, create a surgical guide, create a provisional matrix, create all of this stuff with your prosthodontist and surgeon right from the beginning before you even begin, which is the beauty of this. And then finally, very last slide, I'm going to skip over here. Exciting things that are coming with Invisalign. So now we can integrate CBCT, we can integrate a smile design, we can obviously integrate the patient's photos and face in the process. Very soon we're going to be able to integrate a 3D scan of the patient's face on the actual ClinCheck. So you can have the bone, the photos, and manipulate the face in three-dimensionally, both soft tissue and hard tissue. And I know that this is happening because last time I checked my last ClinCheck, this tab came up. It's called 3D Face. So this is where you're able to integrate this, facial scanner integration. And with that, I want to thank you all. Sorry about the technical difficulties today. It was a lot more interesting, I promise you, when, with all the videos. But we probably don't have enough time for questions, but feel free to reach out to me. Here's my professional Instagram account, my email. Take a photo of this. I'm happy to help any of you out. If you have any questions or need any advice on anything. And I want to thank everyone again for listening today.
Thank you very much for the interesting lecture. I don't think we have enough time for questions. Thank you.
test, test.
Hello.
Still not working.
Both.
Test, test. Okay, perfect. All right, we're good. Yep. Yeah. Yeah. Accept. Click allow. أيوة. All right. Okay, thank you. Yep. Perfect.
Okay.
All right.
Thank you, everyone. So I've been running through some technical issues. For our next lecture, we're having Dr. Muhammad Kelly. Dr. Muhammad earned his doctorate of dental surgery at Virginia's Commonwealth University. He then returned to Kuwait for an AGD one-year program before then joining University of Kuwait Periodontics Department as an assistant professor. Dr. Muhammad is a dual qualified periodontic and orthodontic who got his degree from the University of Pennsylvania, and then obtained his master's degree. Dr. Kelly is he's board certified by the American Board of Periodontics and the American Board of Orthodontics. He's also a fellow of the Royal College of Dentists of Canada in Periodontics and Orthodontics. He is currently a faculty member at Kuwait's University, University of Pennsylvania, Temple University, and the Kuwaiti Board. And in addition to being a faculty member, he is also a published author in prestigious journals such as Periodontology 2000. Now,
Right, thank you very much, everyone. Pleasure to be here. It's always fun to be in Kuwait with familiar faces. This is a little bit about my background. These are my certification, my academic affiliations. I want to start about this topic with this logo that we'll be talking about. I want you to see the lines coming together and continuation of how everything will be talking about the 360 concept. The idea of a 360 concept is that we will be working in synergistic approaches. We no longer look in single specialty dentistry. Now, it's almost 2026, we'll talk about multidisciplinary treatment. With that being said, we're going to talk about it in managing impacted teeth. So with that, I wanted to start by definition. A blocked out tooth is not an impacted tooth. What do you mean, doc? So basically, when we talk about teeth that are impacted, it means no matter what we do, if we clear the path, it will not erupt. A blocked out tooth, it means that once we create the path for it, it will erupt. So this is an example of a blacked out canine. So if we take a look here, the moment we create space for this canine, we will be able to have it come into the arch. So basically, we do take teeth out. So in that case, and what we do is, we were able to see here the canine erupting on its own, spontaneously. And then I want to thank my previous colleagues, Dr. Maryam and Dr. Noor, mentioning airway, because we have a lot of people saying about retrusive orthodontics, we should not be extracting teeth because it will cause airway problems. It is by definition. Before we do that, I want you to appreciate here the picture, how after finishing this case, we evaluate the soft tissues and we were able to recontour the soft tissues. With that being said, the American Association of Orthodontics came because we have people saying if you extract teeth, you're going to create airway problems. If you use a headgear, you create airway problems. This is not scientifically proven. There is no such thing as a retrusive orthodontist. This is a scientific-based statement. No orthodontic treatment have shown to worsen OSA, because OSA is a multidisciplinary. However, as my colleague showed previously, there are multiple treatments that we can give that can help in OSA. All right, with that being said, we're going to move to our topic of today's presentation, which is impacted teeth. Impacted teeth means the teeth are pushed against of that component. It's either by soft tissue impaction, hard tissue impaction, or a combination. So in terms of treatment options, we should always give our patients options. Option number one, no treatment. You can leave it as is. Since the beginning of time, before even orthodontics, humans lived for many decades without ortho treatment. Option number two would be extraction. Option number three would be autotransplantation. The most common treatment option is orthodontic resolution in addition to surgical intervention. All right, so basically, I always like to say, al-waqaya khayrun min al-ilaj. So please, since we have a pedo-ortho collaborations, let's evaluate our patients to see if we have retained Cs. Whenever we have retained Cs, if we do extract our primary teeth, what's going to happen is we have better chances of the teeth erupting. We already have that established in the literature. So a case like this, we just take out the Cs and the teeth will erupt into their position. Okay, doctor, is there other aspects that we can do? There is maxillary expansion. But Chetty showed that if in cases when we have maxillary constriction and we do expansion, we have improved areas where the transverse dimension, the canine will erupt into the arch. So let's take a look. I call this the two-in-one appliance. I'm working on two dimensions at once, the vertical and sagittal. Take a look here. We have here that we're working on the anterior bite plane to work on the bite, in addition to having maxillary transverse expansion. And now the canine erupt into the arch, and now it's a simple orthodontic case. As we can see, we have different options. We can do it with MARPs, different aspects. This is still, we're not going to the surgical phases, okay? The same thing here. We have another case where we expanded and the tooth erupt. As we can see previously been mentioned, airway consideration, it is by definition, we can improve airway in maxillary constriction if we do that. We looked into literature, me and some colleagues for the last 10 years, that is specifically proven that we can do that. Okay, so basically, we have to create space, either by removable or fixed appliances. The issue is the space. That's why we have to think about that, okay? So this is just some literature that we're thinking about numbers. It's more common to be palatally impacted instead of buccally impacted teeth. So in terms of techniques, we have the open technique. It means after we're done, it's already there. And there is the closed technique. But there is another technique that I'm currently working on publishing. It's called the semi-open technique, which is it's not completely open, it's not closed, but it's open just a little bit, and you'll know the rationale behind it later on. In the beginning, we like to appreciate and mention Kokich and Bernardal. They're from the East Coast, West Coast, closed versus open. They created the platform to which we continue to learn from those days. So in terms of any evidence that we find in the literature, you'll see evidence on different sides. However, we have to customize our treatment plan in order to have it for those patients. We no longer live in cookie-cutter dentistry. I only do open, I only do closed. This is not. I only do aligners, I only do fixed. You have to be versatile in what you provide your patients. So basically, let's take a look here. When we talk about closed versus open, this is what we think about. The labiolingual position. We think about the vertical position. If it's way too high, I cannot do it open. And then we look at the amount of keratinized tissue. You will meet every periodontist loves keratinized tissue. So you want to preserve that keratinized tissue as much as possible. and the mesiodistal position. Is the tooth close to a tooth next to it that I've opened it? It's going to cause recession. These are things to keep in mind. So a case like this, where we have a palatally impacted canine, what we can go ahead and do, we can go ahead and do an open exposure and then retract the canine away and then extrude it. This is your simple mechanics. So another question, Doctor. Exposing or expanding first. So it depends on the case. However, if you do decide to expand first, you have to let your surgeon know. Because once you expand, you have that maxillary diastema that's opened up. So what happens is, if we have any surgical complication, you could have created a fistula for that patient, and you created a cleft. So that's something to keep in mind on what is your plan. You have to have that 360 approach. Like a case like this, we know we're going to expand. That's why we did our design differently, to avoid any issues in the mid-palatine area. So we can see here, we expose, and then we can go ahead and bring the canines into their actual position. Same thing like here. If we have a functional shift, before even thinking about the canine, let's correct the problems that we have. The problem is the functional shift due to maxillary transverse issue. So in a case like this, once we expand, this case becomes your easy class 1 orthodontics. So you go ahead, you create that, and you have an open exposure while using it as a closed technique, because we don't want to damage the papilla of adjacent teeth. So these are things to keep in mind. So we have beautifully class 1 occlusion, and in terms of retainer as well, there is no one kind of retainer. It is case-by-case, case-dependent mechanics that we use. All right, in a case like this where we have a buccally impacted tooth, that we have to think about it. So when we have to evaluate the position. As an orthodontist, create proper space. Once you have created the proper space, what you can do ahead, extract, I locate where the canine is, 2 vertical releasing, and we can go ahead and you'll see here, this is the follicle. The younger the patient, the more likely you'll see the follicle, the higher chances the tooth will erupt into the arch. So in a case like this, what we call here is channeling the bone. So to create an easier orthodontic traction, you channel the bone, and we were able to actually, if you can see here in my video, the flap does not move. So what we can do here is suture it and bring it into the arch, and we can see here there is no complications that we have. In a case like this, where the canine is located here, it's above the mucogingival junction. Please just don't say, I have a laser, I'm going to go ahead and laser it. That patient will have recession 10, 20, 30 years from now. Appreciate the soft tissue that we have. So what we want to do is an open exposure while rotating the flap into its position. And now what we have created is an idea to how we can bring the canine in. And this is a swinging gate that we can go ahead to extrude the tooth and move it buccally. These mechanics, I always use it with very compliant patients. If your patient is not compliant and they disappear, this is the easiest way to do an extraction. Okay? So basically, we can see and appreciate how we have that from that component. Okay, so in a case like this, same concept. We want to preserve the tissue, so we want to do an apically positioned flap. If I have any surgeons that are in the room, this is the way the flap. The way you want the flap, it does not move. The sutures are there to secure it, but the flap does not move without that. And I do create a slit to make sure it looks like, mimics the anatomy of the tooth. So that's how it looks like, and now we can go ahead and do our piggyback mechanics. In a case like this, how would you treat? What do you guys think? We have a lot of tissue. So now excisional, you can use laser, blade, it's a simple case, you can do that. So now let's take a look about Nabil here. He is 9 years of age, that he was seen by a previous periodontist. They recommended, it's okay, we'll wait, we'll wait, we'll wait. And I'm like looking at the case here, what are we waiting for? There is no magic. We already know the history. This case will be complicated with time in, time out. So basically, let's take a look at the OPG. We can see that there is a lot going on in the upper right central area. We have probably 2 teeth that are impacted, and we have a supernumerary. So I'm like, okay, what is the next step that we should do here? What should we do? We should actually take a CBCT. I look at the CBCT and I'm like, there is a lot going on. I cannot differentiate how the teeth are. So now I know that I have maxillary constriction. So the first thing I'm going to start here with extraction of this primary teeth, the retained primary tooth, and expanding at the same time. After that, the upper right lateral erupted, but the central did not. So what we did now is we did the surgery to extract the supernumerary and pull the central into the arch. And this is a case we were thinking about a closed exposure to bring it into the arch. And now it's a more simple case. I always tell my patients, phase 1 is just to get things normal. We're not going to finish an ideal setting for a case like this. So basically, my goal in this treatment is to make an abnormal growth and development dentoalveolar or skeletal into a normal one, and then we go ahead and have that component. The next question is, Doc, we want to see under the curtain, so now he is ready to go ahead growth, and he'll come back in a year or two, ready for phase 2, which is going to be quick for me. Okay, in some cases, some physicians think about just the primary, the centrals, ignoring the canine. This came to me as a referral, actually. So basically what happened is they were doing ortho, ignoring that they have a large follicle. What we know now by CBCT evidence, a large follicle will create resorption on the roots of the laterals. That's why what we want to do is actually expose and let it bond into the arch. So basically, in this case, what we did is we actually exposed, no ortho treatment at this point, just exposing, letting it to the arch, and the teeth will ride into the arch. And now what we can see here, now it's your very simple mechanics. There is nothing more than that. It's just having a plan that you go with. Also about molars, please evaluate that soft tissue, that 2 millimeters of KT. I've seen a lot of patients come to me in their 30s, 40s, 50s that I do soft tissues for. If we have thinking about this, let's think about the tissue overall. That's what I mean by 360 concept, thinking about the soft tissue before anything else. I don't say always and never in dentistry, but there is one thing that I always say. I will never treat any patient that refuses to take an OPG. You know why? Because you are responsible for what's underneath that. So this patient comes to me, he's 8 years of age, and the dad's like, we don't want to take x-rays. I'm like, okay, we're not going to treat you. Then they agree to take the x-ray. You want to see how it looks? Let's see how the x-ray looks. Let's look at the canines. So this is a case. If you did not take an x-ray, you would have missed a huge problem. So that's why you don't want to go blind. You have x-rays, you have tools. Use them to your benefit. If the patient does not want to do it, maybe not every patient is for you. So in a case like this, what we go ahead and do that and bring the teeth into the arch with our simple mechanics. There's nothing, it's always been there. We simple mechanics, let the patient know, and we can get it into the arch. So I want to talk about the semi-open technique. Semi-open is basically, I cannot do it open because I will create recession on adjacent teeth. If I do it closed, I don't know if the tooth will still have that tissue is thick enough that it will need another surgery. I always have a philosophy telling my patient, I treat them the same way I want to be treated. I prefer to go through one surgery instead of two. All right? So in a patient that comes to me here with a supernumerary and a blocked out tooth that are happening here, the first thing that we want to do is, he has maxillary constriction, but I'm not expanding now because I want to get the tooth in, then I will expand. So basically, I go ahead and extract the supernumerary that we have. After that, what we go ahead and evaluate the area. So basically, the question is, should we graft versus not? If a growing patient, I'm not planning any implants, we don't graft at this point. But if it's an adult that is like, for example, 30, 40, 50, I'll be thinking about grafting those cases. So these things to keep in mind. So basically now, as you can see here, I can evaluate the tissue. I can see the amount of keratinized tissue that I have, and I will go ahead and trim just a little bit, preserving that KT that we like, and then I'll go ahead and bond the chain to it. The chain will not be activated yet. I tell the parents, let the tooth see. If it erupts on its own, we're fine. If not, we go ahead and do that. Some people will ask, why don't you just take the supernumerary out and see how the normal eruption is? I don't like to play 50-50, because if the tooth does not erupt, I'm taking that patient again to the surgery. This patient was done under sedation, and with sedation, I like to get things done in a definitive treatment. So basically what we can do, this is what I mean by a semi-open. So I can already see it in that position, and now I can see, I go ahead and place my expander, and now it's not active. I'm just holding the chain and monitoring this patient for growth. Then afterwards, I can just bring it into the arch. Same idea here. a patient has a maxillary central. She is 11. She's been seen by many dentists that told her, it's okay, let's wait, let's wait. Please, if you see a case, 11 years of age, the central is not erupted, let's not wait. Waiting is not the treatment, okay? So now what we have to do is idealize the position for the tooth to erupt. Then once we created the space, we wait a little bit. The chances of it erupting, it will most likely not erupt. Just something to keep in mind, I don't like to change open coil regularly, so what I do is place some composite to make sure that we go ahead and open the space as much as possible. Now what we want to do is, I open more than I need. The rationale behind this is what? I want to have adequate surgical space. Just something to keep in mind, you want to sometimes flip your brackets because of the tooth tipping. You don't want to be pushing the roots of the laterals into an erupting canine. Otherwise, you will be devitalizing those teeth. So now, I like to use this coil spring whenever it's called the IsoGlide. I prefer using it when it's a straight slam dunk case. So basically what I do is activate it, and my incision design, as you can see here, it was done right in the frenum to avoid any scarring, okay? And now I will suture only the mesial side. The distal side at this point is going to be left open, because now I want the path of least resistance. I want the tooth to be able to go from that component. That's what I mean by a semi-open technique. In a case like this that we have to appreciate, we have a retained primary tooth. Whenever you see that, please take it out, because that will erupt the premolar in its position. Then we have to evaluate. This probably is palatal. This is buccal. We do take CBCTs for every case. So now what we want to do is, we took the primary tooth, and you can see the upper left 5 erupted. Now let's take a look. Once I extract, this is what I mean. I did not apically position the flap. I did a gingivectomy just to the tip of it. The idea behind this is, you only need to bond to the tip, because you're not thinking about bodily movement here. The moment you think about bodily movement, you will delay your treatment. So in a case like this, what you want to do is actually, I use my hemostatic agent, and now see, by itself, at 2-week follow-up, we have soft tissue shrinkage, in addition to the tooth extruding a little bit. Now what we want to do is, bring the teeth into the arch with simple mechanics, just to bring it into the arch. Okay? So this is how we evaluate the teeth. And as you can see here, we preserve the papilla. Everything is good from that perspective. Let's take a look at the premolar. It's the same idea. This tooth here just needs a little guidance. It's not impacted, it's misguided, where we have to idealize the position of it. So basically, when I come to open that area, I'll have to bond as distal as possible. And when you come to get your forces, you want to be as mesial as possible, while preserving the soft tissue. So I did not do it as an open, not as a completely closed. You'll see, after I finished, I create a little V shape while appreciating the soft tissue that we have. With that being said, you will see now, the tooth will erupt, and now I just take it out, let it see, erupt on its own, and then I'll bring it to the arch. And look at the amount of KT that I have. This patient, as we know, lower premolar is the area with least amount of KT. This patient might have a lot of issue in life, but keratinized tissue is not one of them. All right? So when we talk about closed exposure, we have to be cognitive about the cases that we think about. A case like this, where we have 3 teeth that we can see here that are impacted. So in a case like this, it's much better to wid it in a closed fashion, and then you put the gold chain in the desired movement to bring them into the arch. Okay, one more thing. Whenever I'm bonding, it's okay to have access, but you want to have it on the coronal aspect, not the apical, because you want to have that in a component, and I'll show you what I use it in which techniques. All right? So we can see here, we can bring it into the arch. Now it's your simple case, not difficult anymore. In a case like this, where the location of the canine is on top of the lateral, this might be an indication to take the tooth out and erupt it, and then do a little bit of switching. So what we want to do here is bring it in a closed manner. If this was done in an open manner, it's going to be having periodontal issues. So in a case like this, we go ahead and activate. And whenever you bond the gold chain, please activate it like you mean it. You don't want it to be dislodging for those patients. So let's take a look here, bringing the tooth into the lingual aspect. And then you can see here, we brought it into the lingual aspect. And now, as we can see here, we are maintaining the midline. The right side is class 1, so I use class 1 elastics, and class 3 on the left side. That way I do two things. I maintain my midline, avoid canting, and I'll be closing that space. And then we have our restorative colleagues fixing those cases for us. So this is a case with a bilaterally, it's called bilaterally palatally buccally impacted tooth because it's located in the palate, but the tip of it is in the buccal. These have to be approached from a buccal aspect. When you talk to your surgeon, it's really important the bonding. This case is not the mechanics. It's all extrusive mechanics, but the bonding, you'll see. You want to bond closer to the tip as possible because you don't want to create a moment at that point. You're thinking about tipping the tooth in its position. Then what I do is, before extracting the C, because I don't want to create bleeding, I bond first, I create my channel to see how thick the bone is because I want to evaluate how much bone I'm taking out. So then I do take the bone out, I do take the tooth out and channel the bone. The teeth will love to go into those positions. And you can see here, we're channeling the bone, the same mechanics, as mesial as possible while having it next to the tip. And now we bring the teeth into the arch. I always love when the patient sends you a message before even texting, just a message, then they will reply. Is this normal? When I look at this, is this normal? What do you guys think? If you get this message.
Sorry, doctor. 10 minutes remaining.
10 minutes? Okay. Is this normal? So basically, it is the normal process because the tooth is erupting into the arch, and we can see here the teeth are coming into the arch, and from that component. Okay, now we talk about another case here that the patient want to preserve. It's pigmented gingiva that we think about is bringing the teeth into the arch, and it's a closed mechanics, and we'll pull from both sides, so we have it coming right in the center. And now what we want to do is derotate. We cannot talk about impacted teeth without talking about transposed teeth. So this is a case, actually, we have a poster with Dr. Munira that will be presenting more about it. I'm going to talk about more of the perio aspects. Whenever you see transposition, the first question you ask yourself is, where are the roots? The moment I look at a case like this, I know that radiologists don't like this view. I like it because it gives me an idea to plan from an orthodontic perspective. So whenever I look at a case like this, I'm thinking, the lower right canine is going to be, it's quadruple. The upper is easy. Maxillary is easy. It's going to put it into position. The question is here. Are we going to transpose or return it to normal position? The lower right, because of the positioning of the roots that we can see here, what we will go ahead and do is maintain this position. This will be maintained and we'll have transposition accepted. In a case like this, what we will go ahead and do, put it in its actual position. And I'll retract, and you'll see here, retracting, bringing it to the arch, and now we can extrude here to level the gingival margin, torque the roots in to get in that place. This is what I mean by a semi-open. If you can see, I can see the tooth here. I will not close it completely, but I don't want to get recession on that component. So that's how we look at. And I want to appreciate another case here that when I see this, and I'm like, are we concerned? Is this transposition? It always involves a canine. We have a lot going on. We have congenitally missing teeth. In the maxilla, we have a lot going on. We can see if it's 2 or 3 teeth that are happening. Think about those components. How do we get from here to here? What we want to think about is our growth and development and how the teeth erupt. So basically, into the arch. It is just stepwise mechanic. Anybody can do it. It's just an idea of having a stepwise process from that component. We position a flap and using our extrusive mechanics. This is a spring I love to use all the time because it's active and I maintain it with a little case, easy case, life is okay. So we can see how we were able to do that. Same thing, APF with spring into extrude. So we can see here, bending the wire in. Now, it says B. B, A. So the only issue is the torque here, but as you can see here, what we exposed, we were able to get it into the arch with ID, get it into the arch. 75. Who would are we gonna attempt? So I did this in a school setting, by the way. In a school setting, when the patient wants something, we can't at a kid, but now she can afford it. But you have to think, is it worth it versus not? Okay? This is a case where they tried open exposure, orthodontic forced eruption. It's your natural way to build bone and soft tissue. Just by doing orthodontic forced eruption, we were able to correct a problem like this. Okay, the orthodontist is like, "Doc, I cannot see the tooth you exposed." I'm like, "What do you mean you cannot see it?" And I look here, there is no tooth. So now what we have to do is re-expose, but soft tissue only. Complications typically happen if either we're trying to take shortcuts or we are thinking of an inappropriate way. So let's take a look. How did this case? They're coming to me and I'm like, "What should I do?" The first thing, whenever they send a here, they bond it to the lingual aspect when they should have done to the buccal, because it was difficult to bond to the buccal. And now we can see here, this is what happens. This basically bringing the tooth into the arch. Using the canine, we can use the primary canine to hold the teeth into position. Then when it comes to things from NASA, the heat wires, they've been invented by NASA. We are very fortunate that we get to use them. At the end of the day, closed or open, which one would you choose? There is not win-win cases I'm showing here today. They've been worked together. And this is one of my favorite quotes that I created. It's, "The future belongs to teams that look in 360. It's where clinical, it's more of 360 approaches that we think about. Thank you very much for having me. And I wish to have you a pleasant Friday afternoon. Thank you so much.
Questions. We do have more time for questions this time.
Yes. Yes. Mike, okay.
Concept, especially within the context of impacted teeth. Now, what I noticed in the presentation was that most of the cases that you were treating orthodontically.
The topic of today was fixed. With
Yes.
aligners or hybrids, we use specific technique with auxiliaries that we can extrude the teeth. There is auxiliaries that we can use. Now, while having the aligners on top, we can go ahead and do the buttons, for example, to extrude if it's buccal, and if it's lingual, we can have TADs and using that component.
So you're saying that when it comes to using clear aligners, it's a mixture of...
Yes, it's hybrid technique. Because of the anatomy of it, the aligner cannot go ahead into the arch, but you have to use using a hybrid technique.
Yes, thank you.
All right. Any other questions? How much, Dr. Mohammed?
Thank you very much.
I'd like to present you with a certificate.
نبتدي خلاص اوكي
Hello, everyone. To be with you to introduce our esteemed speaker, Dr. Fatma Al-Kenderi. Dr. Fatma Al-Kenderi is a craniofacial King's College London. She further specialized by obtaining a cleft craniofacial and special needs fellowship from Great Ormond Street Hospital. And join me in welcoming our speaker and expert in orthodontics.
Hello, everyone. A huge team that covers every single aspect in terms of dentistry and medicine as well. So we've got plastic surgeons, ENTs, clinical psychologists, audiologists, speech and language cases, and what we can do for those special cases. So what is craniofacial microsomia, which is also known as hemifacial, zygoma, the ears, facial soft tissues, muscles, facial nerves, and other structures. There are also dental anomalies associated with those cases, some fusion, and the cervical spines, cardiac and lung, and gastrointestinal as well. So what is the exact cause for craniofacial microsomia? Basically, we've got a mutation in the FOX, and they are very variable in expression. So it's very different in every single patient. So assessment has to be tailored for every one of them. So we've got something called Ullmann's classification, the mandibular hypoplasia and ears, the facial nerve defects, and soft tissue defects. And each category has a sub-category as well, according to the severity. So this is look at, and it's also subdivided according to the severity of the presentation of the case. So in terms of management, it's very patient selective, and the treatment plan has. And we have also to focus on the flow and of the treatment to be provided. So our aim is basically to have great function and aesthetics at the same time for them. So the management of craniofacial microsomia, our main goal during birth, after birth to 6 years, is that we have to make sure their airway is patent, feeding, hearing, and vision. And then there are skin tags that usually happens around like the ears if it's not fully developed, and that has to be removed early on as well. And then some cases they have macrostomia, which is a very widening of the side of the mouth. They need to be closed as well. And torticollis release, which is basically, it's a muscle around the neck that it becomes very tight that it basically cannot sit upright, and it affects their development as well. So that muscle has to be released. Around the age of 6 to 8, we monitor their dental development and provide treatment as necessary. Around the age of 12, we do genioplasty, which is the repositioning of the genioplasty, which is the chin, just in case of bullying for those patients. It's not 100% recommended for every single case. And then around the age of 13 to 15 years, there is a hybrid functional which allows to help with correction of the cant that happens usually. Usually if the mandible is affected, it grows on one side and toward the affected side. And then the occlusion also, it compensates according to that. So we try to basically to decompensate early on by giving them functional appliances to correct the occlusal plane. Above the age of 16, and then we start our definitive treatment when we are sure that they're fully grown and we don't have any complications later on. And then we provide orthognathic surgery, synthetic joints if they are indicated for the TMJ. And then we've got the restorative treatment. We're going to go through cases. So the first case that we have is Ala. She has a craniofacial microsomia as well as a unilateral complete cleft lip, palate, and alveolus on the right side. She presented to my clinic when she was 18 years old. She was already in treatment, and according to her family history, her uncle had a cleft. And then, as I said, with there's a cleft as well in addition to the craniofacial microsomia. And then she had her surgeries already done for the lips, palate, and bone graft as well around the age of 11. And it had a regraft treatment around the age of 16, so it failed the first time. According to the extraoral assessment, she has a skeletal 2 with a facial asymmetry, and the mandible deviated to the right side, which is the affected side. She reached the vertical proportion is reduced where the affected mandible is, and there is a huge maxillary cant and a mandibular cant as well because she hasn't been treated to compensate early on. Intraorally, she had poor oral hygiene, hypoplastic teeth, and missing upper right 2, extracted lower right 6, and lower left 5. Incisor relationship, she has a class 2 division 1 with an overjet of 2 millimeter, and then she had a crossbite, but there is no displacement. So this is how she represents clinically, and so basically this is what I mean with the maxillary and mandibular cant. It hasn't been treated early on, so it's very exaggerated. And because they have the deformity on one side, so you've got she has a reduced zygoma, the mandible is affected as well, and the eyes are very slightly dystopic, according to size mainly. And this is the ear tags that has been removed before, but she doesn't have the ear formation properly, so we have to basically create an ear for her. And I noticed as well she had a macroglossia on one side and a smaller tongue on the other side, but it's not very representative of a craniofacial microsomia. Intraorally, she already had treatment when she presented to my clinic. And then this is the area of the bone graft where it has been retreated. And because the area wasn't filled or the tooth was not moved into the area, so it looks like it dipped a little bit and we might need to regraft. So this is how she presented. This is her intraoral scan that has been taken. It was very difficult to try to put the bite with the intraoral scan, so I did that manually. These are her x-rays, and you can see the curve in the occlusal plane. This is the mandible that basically the coronoid and the condyle, the coronoid process of the condyle are very, they're there, but it's very small in size. This is from the previous radiograph that has been taken. Those are pins that are used to basically bone graft the area. So they use the pins as one of the techniques. And then once they take the x-rays and they're happy with the amount of bone they're there, sometimes they leave it, but they have to take it out after a while, at least 4 to 6 months, to make sure there is bone fill in the area. So her treatment plan, according to the orthodontic treatment plan, so we're trying to align the arches. We're not correcting the occlusal plane 100% because it's a combination of dental and skeletal. So we have to work on that and we have to be very careful. And then we have the missing upper right too, where the bone graft is. We decided to close the space and we have to mesialize the canine into the area to make sure there is a bone fill in that place. Especially she is a non-Kuwaiti and it might be difficult for her to afford any kind of restorative treatment for lifelong maintenance. According to plastic, this is the sequence of treatment. So we're starting with orthodontics, and then for plastics, basically their plan is to have an ear reconstruction, either a Medpor, which is this one. Basically, they take their ribs and then they reshape them and then put them under the skin and then do like a vacuum technique to get the shape of the ear. She cannot hear from that. Or another option to have something called a PEEK implant, which is this. It's basically, it's like an implant that represents the bone structure rather than soft tissue. And then add that together, as well as having a TMJ replacement. It's a synthetic joint. For that joint to be there, where it's a custom made, very sensitive if there is any kind of inflammation or anything around the area, it will definitely fail. So there are other options of treating the TMJ in that aspect, not only joint replacement, which has to be done after the patient is minor cut, and then you put metal plates, and then you force them, you open that, just like the expander in the upper arch, but it's basically for that distractor. And then the idea of that is like while you're distracting, you're having a slow bone rib graft where they have a piece of their ribs cut down and then they place it where the mandible condyle should be in order to correct that, the mandibular asymmetry. So this is her CBCT that I requested just to evaluate the amount of bone that we have in the area. For another aspect about the lecture today, it's about ectodermal dysplasia. So basically, it mostly affects ectodermal structures that are hair, teeth, nails, and sweat glands, and then one osteotomy of maxillary advancement in the area. So it's very limited in terms of how can I manage this case orthodontically, because he already done after 18. But if they haven't been treated, like they haven't received their full treatment to begin with, we have to delay that to be the last step for the rhinoplasty. Intraoral bands all over the place, that actual bands on the front teeth that they did not have any prescription, so it was difficult to work around the case. So intraorally, he has class 2 division 2 incisor relationship. For that was only a supernumerary, and then when we took CBCT, basically it's kind of like probably a gemination. Basically, it had one root that had 2 crowns. But it's a bit different in due expansion. The expansion that we're planning is a quad helix because I don't want to do anything skeletal in that relation. So we're working dental at this stage. And then once we're done with the extraction, we have an upper and lower fixed appliances, non-extraction. You have to measure mesiodistally from the thinnest part of the crown in order to have an idea how much the mesiodistal width of the crown to be replaced would be. Before debonding, or it happened because of a relapse after prosthetic treatment. So that was a tricky question. Definitely collapse if they don't wear their retainers, and it has to be a rigid retainer to maintain the transverse width of the upper arch. So we're moving on to cleft cases. So we've got Ghalia, she's 11 years old when she presented to my clinic. Her plan was to debond the present appliances, improve her oral hygiene, and then extract there was an impacted upper right B and then it failed, and then we had to redo the alveolar bone graft as well in the area. The issue with this patient, whenever she does any kind of surgery, she disappears. She thinks everything is done. So we're good. I have bone in the area, so endodontic cold test. It was vital, so wanted to basically have a regular follow-up on that tooth just to confirm is it actually endodontic the tooth. So this is her CBCT around the area. So this is the last, see a bulge of that. And then if you can see this image, there is absolutely no bone on the palatal surface of that tooth. So it's mainly, the crown is buccal, but the whole root is palatal and soft tissue covered only. We have to make that decision. Are we extracting the lateral and then closing the upper arch, either to be treated surgically with a Le Fort 1 advancement, or do we start in 2 teeth in the lower arch and maintain it orthodontically as an orthodontic chemical? So in orthodontic treatment already, almost all of these are transfer cases. He had his lip surgery done, the bone graft, which was on the right side, and we had the lower midline shifted to the left. And the maxillary can't because of that reason. So his treatment, he had to go for orthodontic management as well. And then we wanted to do arch wire expansion. The yin-yang basically method is, which is basically a wire bending in the wire itself to have it higher, and bonding both upper and lower arches. I always band or bond the 7s in my treatment. We started with putting glass ionomer cement on one on the left side to correct the cant as well. That was one of the methods that were used. We're talking about mechanics now. And then it didn't work as much, even with the yin-yang wire and those methods. And then we rolled in. It wasn't actually extruded. So basically, when we're pulling on the buccal side aspect by itself, it will help correct the inclination of the tooth and intrude it at the same time. So we managed to correct his occlusion orthodontically. It wasn't 100% end result, but it was acceptable. He had to go to study medicine in Egypt, bless his heart. So the debond was, this is in his cedric relation, he can manage to have like a great class 1 in every single aspect. However, because of the mandibular elongation and the movement, he goes for the centric inclusion with the mandibular deviation to the left by 2 millimeter, but it's comfortable for him, and it was an acceptable result for us. So this is how he started and how ended in treatment. Another case, we've got Peter. He presented young. He had a unilateral complete cleft lip and alveolus. This is a fistula. Whenever they repair their lip or the palate, if it was involved as well, they usually leave a fistula in the area to allow the alveolar bone to grow in all aspects three-dimensionally. So he had a class 2 division 1 incisor relationship with average vertical proportion. The upper right tooth was not erupted yet, the canine as well, but we wanted to treat him early because we thought sometimes it takes a longer time for us to do orthodontic treatment, and then they take a longer time in the waiting list for the surgery. So sometimes we start a bit earlier just to make sure that they are treated on time when they're needed to. So this is a CBCT snapshot of the teeth. While I was treating, so this is the cleft area. While I was treating him, the lateral came down into occlusion. So I wanted to create a space for that as well. And then we did the bone graft, and the canine came in, the lateral, which is a good sign that basically it worked. How do I know that my bone graft is stable? If I have a permanent tooth bud coming into the bone, making sure it stays. If you do the bone graft and you don't move a tooth or the roots into the bone graft area, it will resorb. It needs something. You have to move something into the area for it to stick in place. So for this case, it was debonded. And when I reviewed him back again, basically, I felt there is a loss of bone in that area. When I thought there is a bit of a notch in the area, just because the roots were not moved completely where the bone graft was done. So I didn't want to lose more bone in the area, so we started phase 2 of treatment, which is the definitive orthodontic treatment, early on, just because he has a class 1. He started with a class 2 representation, and then he's now a class 1. He's still growing, but he's in his growth spurt, so I'm not worried too much about reverse growth or going to class 3 in the area. So my goal is to move that lateral, even though the bone is a bit like high, and I need to move that root of the lateral into the bone area, and then since I'm delivering orthodontic treatment, so I'm just gonna treat him fully. That's it, thank you.
Thank you very much, Dictora, for this amazing and informative lecture. Any questions from the audience? Thank you, Dictora.
Thank you.
Dr. Fatma Hussein is a board-certified craniofacial orthodontist and a fellow of the Royal College of Dentists of Canada, with a special interest in the treatment of complex craniofacial and surgical cases. She received both of her Bachelor of Medical Science and Dental degree with honor from Kuwait University. Pursuing further training, she completed her residency in orthodontics and obtained a Master of Science in Orthodontics from the State University of New York at Buffalo. Dr. Hussein also undertook a fellowship in craniofacial and special needs orthodontist at the Children's Hospital, Los Angeles, one of the busiest craniofacial centers in the US. She's currently an assistant professor at her alma mater, Kuwait University, and the State University of New York at Buffalo, where she continued to contribute to the field of orthodontics. Please join me to welcome Dr. Fatma Hussein.
Assalamu alaikum. Thank you very much for the kind introduction, and thank you for taking the time and spending your Friday evening with me. So today I'm going to be talking about a topic that's very dear to my heart, segmental distraction, and specifically distraction osteogenesis, and how we can use that as a solution to cleft-related problems in the dental arch form. So just to get started, some disclosures. I don't have any financial interests in any of the appliances that I'm going to be showing today, and I'm not going to be discussing anything that's not FDA approved or anything that's experimental. This is the outline of today's lecture, just some background statement of the problem. We're going to go over distraction osteogenesis, just a refresher for most of you guys, and then we're going to talk about the segmental distraction protocol that I use, and then I'm going to end up showing you around 3 cases of how actually to do that. So those who've heard me speak before, either here or in the US, you probably have seen this slide before. I love having this slide on my craniofacial talks. It's called The Road Not Taken. And I only have this slide because I want to remind you guys that it's actually good to think outside the box every now and then. I know for orthodontists in here in the audience that a lot of the time we just do template treatment for most of our patients, but in craniofacial orthodontics, or every now and then when you have a difficult case, it's good to try to think outside the box. It's very rewarding for both you and the patient. So let's talk a little bit about distraction osteogenesis. What is distraction osteogenesis? In simple terms, it is a surgical procedure where a cut is made, and then 2 pieces of bone are moved apart to try to stimulate the growth of new bone. So in here you can see we have a single piece of bone, and then we created a controlled fracture. We inserted pins on either sides of the bone, and then we start, after healing have started and the callus has formed, we start pulling those 2 pieces of bone apart, stretching that callus. Once the desired length has been achieved, we're going to stop, we're going to stabilize it, we're going to go through what we call a consolidation phase, and then we're going to have our new longer bone. In order to implement distraction osteogenesis, or in order for anyone to use it, you have to understand the stages of distraction osteogenesis. So you'll start with a latency period, which is the time between when your surgeon first creates the osteotomy for you and the time when you begin the movement, when you begin stretching the callus. And this period is between 5 to 7 days. And it's very important because you want to allow the site to heal. You want the callus to form. You cannot achieve distraction osteogenesis unless you have a callus. So if you do it too soon, it's going to fail. Then you're going to have the distraction period, which is the active distraction period, the time where you're pulling the 2 pieces of bone apart and trying to create new bone. And then you have the consolidation period. Once you've achieved your goal, you're going to have to stabilize that area because you want the callus to start to calcify. And you have to keep in mind that the longer you distract, the longer you're stretching the callus, the longer the consolidation period is going to be. But it's generally, it usually is between 6 to 8 weeks. Now that we're talking about distraction osteogenesis, you're probably thinking what kind of distraction device or appliance is she using. So there are many, at least in the craniofacial region. There are some that are specific to the maxilla, some that are specific to the mandible, some that are internal, others that are external. But I think the interesting thing about my talk today is that I'm not going to be using any one of those for my patients. I'm going to show you how you can use things that you actually have in your practice, things that you use on daily basis, and how you can use your regular orthodontic mechanics to distract in the arch form. So distraction osteogenesis can be as simple as moving one segment that contains a tooth forward, or it can be as complex as, or using something as simple as a Lefort 1 face mask, Waller plates, and class 3 elastics. So a little bit of come back to me with a malformed maxillary arch form, and many of them have a wide cleft. And this makes it really difficult for the plastic surgeon So we were thinking, how about we send our patients to our plastic surgeon or to our oral maxillofacial surgeon and ask them to do a segmental osteotomy. And using our everyday orthodontic biomechanics and appliances, we can do some sort of distraction osteogenesis to correct that arch form, or even to reduce the size of the wide cleft we're using on daily basis that we can actually put to use when we're doing distraction osteogenesis. So over here you can see a cleft, a wide cleft, or two segments that we're trying to dock. So use a NiTi coil spring to try to approximate those two segments. And then at the apical level, you have to think of the apical level. I know a lot of you think crowns, brackets, translate. So we actually can place TADs and then do this exact same thing and put a NiTi coil spring. And this will allow the segment to translate and callus. So this is what happens with distraction osteogenesis. Your surgeon makes a cut for you. Somehow, with your appliance, translate that segment wherever you want to move it. For example, in here, we're trying to have the two segments dock, or we're trying to reduce the cleft. Your callus is being stretched. So who would benefit from this protocol? What kind of patients would benefit from this protocol? You could use it for patients with class 3 malocclusion. On choosing a case selection is very important, and this is something that I'm not going to be discussing today because it's really complicated. But today I'm going to show patients who have crowding, and I think this is relevant to all of the orthodontists in here, because every now and then you have a really difficult crowding case, and you're thinking, should I extract? Is there a way to fix it? This is actually a really good case, not parallel. You have dilacerated roots or roots that are in the path of your osteotomy cut. So you have to prepare them as an orthodontist for distraction osteogenesis. You start preparing them. Obviously, you're going to have a full set of records. Nothing at all can substitute your clinical exam, so make sure you do a consultation with the surgeon, and you have to do that before the patient is ready. The surgeon will have to see the patient, will have to okay the case before you decide on doing distraction. Unilateral cleft lip and palate. And the patient basically presented with some crowding in the maxilla, his midline is off, and later on, as we continued to collect our records, we found that that patient, we wanted to make room for the teeth. And the patient's mother was one of the most compliant parents, so we thought this is probably a good case for distraction osteogenesis. So this is the patient's panoramic x-ray. You can appreciate of -8. So you formulate your problem list, and then you get your patient ready for distraction. So you treating with a plastic surgeon or oral maxillofacial surgeon, whether you're working with a resident, a fellow, or an attending. You have to give them very clear instruction on where to make the cuts, and you have to share those records with them. And you can appreciate on that CBCT, especially if they're not very experienced in doing dental-alveolar surgery. Then you have to bend your own appliance. It's basically an expander that we flip 90 degrees, and we have 4 bands. It's very important to deliver your appliance at least a week before the surgery. So you send the patient to your surgeon. And this is basically, and then the patient comes back 3 days after surgery. I usually want to see those patients 3 to 5 days after surgery. Your mechanics are, whatever your device, whatever you're going to use for distraction, make sure it's in the patient's mouth and ready to go before you send them to surgery. Even put my finger in the vestibule. There is no way. It's very painful for the patients. They're very swollen. So make sure whatever you're going to use is there and it's ready to go. For example, we delivered this expander a week. Knew how to activate it. If you're using NiTi coil springs or a wire, make sure it's in there and figure out a way, an easy way to activate it when the patient comes back. We also verify the cut when the patient comes back after the surgery, just to make sure they didn't cut any roots. So this is a patient 7 days after surgery. We did achieve some distraction. You can see the arch perimeter is increasing. But one thing that I noticed and made me freak out on that day is that the upper right side actually came off. And that's why we didn't have as much distraction on that side. So you have to think outside the box again, and you have to realize there was no way I could take this appliance out with that maxillary anterior segment being very mobile. So what I ended up doing is I basically just built up a huge amount of composite to try to connect those two segments and waited for a couple of days to see if this actually works. And it did. We did get some distraction, so it did work. So we continue to distract, and this is a patient 45 days after surgery. You can appreciate how much new bone we got, which is going to be really good for aligning the impacted teeth. Unfortunately, I didn't get to finish this case, but basically our next steps were to continue distracting and then at some point consolidate and try to move the impacted teeth in the arch. Now the second case is a case of space opening for palatally displaced premolars, and I think this is relevant to all of the orthodontists in the audience because we often see patients that have severe amounts of crowding, that are missing teeth, and we don't want to extract more teeth for. So this is a patient who was 13 years, 5 months old. Again, a patient who had multiple surgeries because she had a unilateral cleft lip and palate and alveolus as well on the left side. Molars. For this kind of patient who's already missing teeth, that patient is actually missing lateral incisors. I really want to give her as many teeth as I can because it's only going to complicate our surgery later on when we prepare the patient for orthognathic surgery. She's going to be really deficient in the maxilla in comparison to the mandible. Another expander that is flipped to distract forward. So my expander has become my distractor. So we delivered the appliance. Again, we planned everything. We sent the patient to surgery. They came back. We verified the cuts, and we started with active distraction. At some point, we maxed out that expander, so we had to replace it with another expander. And this is the patient 18 days after the surgery. And not just showing you the occlusal of the maxilla. Why am I showing you all of the angles? If you look at the lateral shot, you can appreciate that you have to clarify this to the parents. A lot of the parents are going to see that and they're going to love it. But guess what? This is not why we're doing the distraction osteogenesis in this patient. We think that this is why we're doing the surgery, when it's not really why. So this is a patient almost a year after the surgery. You can appreciate how we managed to fit those premolars in. It's of wide alveolar cleft. So this is memory. Again, another patient with a unilateral cleft lip and palate, had multiple. So this is how the patient presented, and at this point in time, we just wanted to prepare her to receive her alveolar bone graft. And we did what we usually do for all of our patients. We used an expand. Did not want to give her something that she would overexpand. I wanted something that was programmed, and this was actually a programmable NiTi expander. So if the patient left what I programmed in that NiTi wire. So we did this. We sent the patient to the plastic surgeon. She got her AB. We still have a very wide cleft, and we were thinking, what can we do? And just because the patient has a lot of crowding, we thought the two segments together? Why not have the two segments dock? So this is what we ended up doing. We planned our osteotomy sites. And this is the surgery. We placed some TADs to use, again, TADs you use on your everyday practice, so nothing new really. And this is a patient 3 days after the osteotomy or 3 days after the surgery. So we decided to use the TAD with an iTi coil spring just to try to drag the two segments closer together. So we had those two segments that we wanted to move towards each other, so an iTi coil spring and just a TAD. So we continued to do that, we continued to distract, and you can see that we're creating space at the back. We're actually creating bone that we're gonna use for the teeth that are crowded. And then again, we continue to do the same thing, but at the same time, we're also moving the teeth around, trying to fit them in. Again, we continue to use the TADs and an iTi coil spring, continue to do the same thing. And at the very end, at this point, when we're getting closer to our finish line, I was thinking we probably don't have space for that other premolar, the one that's ectopically in the palate. So, and again, another tip for cleft or craniofacial patients in general, don't take an extraction decision lightly. Think twice before you decide to extract, because those patients tend to be missing a lot of teeth. So make sure you don't decide early, because sometimes you're gonna regret it. There are ways to create space. And that's why we were very patient with this patient, but then at the very end, it looked like we didn't have enough space for that tooth, so we were okay sacrificing it. So this is a patient after we were done aligning the teeth and creating an arch form for her. At this point, the patient was still not ready, not fully grown, so still not ready for orthognathic surgery. So we just wanted to give her some retainers to keep her occlusion where it is, and then have her come back when she's 16 to prepare her for orthognathic surgery. But this is what you can do with distraction osteogenesis. You can transform this into this. And I bet a lot of people are gonna look at this patient and say, we're sorry, there's nothing that we can do for you. We're gonna send you to a maxillofacial prosthodontist who can do a removable appliance or some sort of restorative treatment. But you can actually achieve this. So this is the before and after again. This is basically the take-home message out of this talk. Please dare to think outside the box. I promise it's very rewarding and it's very interesting and it's a lot more fun than everyday orthodontics. Good case selection is key for success in everything that we do in clinical practice. Work with a craniofacial orthodontist who has experience in distraction osteogenesis if this is the first time that you're doing this. And make sure you pick or choose your team wisely. You're gonna need a plastic surgeon, you're gonna need a craniofacial orthodontist to advise or consult if you're not trained, and obviously you're gonna need an oral maxillofacial surgeon. Now when it comes to choosing between plastic surgery and oral maxillofacial surgery on who's gonna do those cases, I was lucky enough to practice with surgeons who were dual certified, were both trained in plastic surgery and oral maxillofacial surgery, but their advice was always go for the oral maxillofacial surgeon, only because they're more comfortable doing dental-alveolar procedures. Last but not least, definitely practice good orthodontic mechanics, because I've seen cases where it actually failed because of poor mechanics. Always think of the roots, think of a segment as a whole, don't just look at the crown and work at the crown level. And finally, if you ever come across a case that you think is too difficult or where you can't help the patient, do refer a patient to someone who can help the patient, because there are options, only if you think outside of the box. I think that's it. Obviously, I have to thank my team. I worked with amazing plastic surgeons, amazing oral maxillofacial surgeon, and I had an amazing support team. Whenever I was not there, there was someone to take care of the patient, and I had an amazing mentor who is known for thinking outside the box. Thank you very much, and I'm ready to take your questions.
Thank you, Dr. Fatma, for this presentation. Anyone have any questions?
Thank you, Dr. for the great lecture. I just have one question. For the distraction part, that they do the surgical cut, and then you push that segment, but you approximate
Conflict on how to define a success of a graft. The way I was trained, having a bony bridge is enough to call it a success. So that patient did have a bony bridge. So that's why we decided to distract. But there was a bony bridge. It was just not a full fill.
You mean where the area, the cleft area, was it approximated with a bone? Go for that option of distraction.
Yes. I mean, you could do it. I mean, I've done it for cases where where we had a failure, no bony bridge at all the bone that we put in patient to the surgeon, there is no way they're gonna like
Grasp
close
the
it,
whole-
at least
yeah.
tension free even.
Okay, perfect. Thank you.
You're welcome. Or even a combination. We're doing an experiment where we're using a combination of both. We actually use it for all of our ABG, our secondary ABG, and the way we used to practice in CHLA, we didn't.
Thank you, Dictora, for a very informative and thorough lecture. Really nice information shared. Additional failure in the previously cleft area, which was repaired. Would there be any issues that would arise, protruding or proclining those teeth?
So one thing that with the palate, they do close the palate with a palatoplasty, but most of the time there is no bone in there. So those patients are easy to expand. So I do tend to expand like that fistula. But then many times there are really small fistulas that only get bigger when you expand. So I think it's really important that you inform the parents ahead of time.
Thank you.